We should, right? Yeah. I have it, but so I can't do. No, I actually cut it off from our management. Good morning. Thank you all for coming today. It's a full house here, and I'm sorry it's a little bit warm. We're trying to fix the air conditioning, so that should come up automatically, hopefully in the next hour or so. So just before I start, I'd like to acknowledge a country. So the Northern Adelaide Local Health Network and the University of Adelaide acknowledges the Ghana people as the traditional custodians of the land, where we proudly work and deliver health and well-being services. We also honor the Ghana elders, past, present, and emerging. We recognize the Aboriginal Cultural Authority and their ongoing spiritual connection to country. So with that, I'd like to welcome all of you again to the 6th Advanced Endoscopy Imaging and Therapeutics Masterclass. So this has been quite some time in the making. Over the last 3 years or so, we had to sort of work it out with COVID and whatnot, and finally managed to pull it off this time. I think our registrations were kind of full, so we had to close off our regos about 5 or 6 days ago. We had booked the other hall as well, but unfortunately I think we decided that it's nice and cozy over here, and we'll just keep with this strategy here. So the course aims to teach all of us the latest advances in mucosal imaging techniques to improve our diagnostic ability to detect, characterize, and treat GI lesions. So we concentrated a lot on the upper GI segment yesterday, and we will sort of move on towards the lower GI, the small bowel and the lower GI today. So there's how I do it sessions, there's videos and image presentations of interesting cases, and we'll have a Q&A towards the end of each session for about 2 or 3 minutes. So if you have any questions, you can put forth through the chairs, and we've got 2 roving mics, and we will, you can ask these questions of the speaker or through the chairs. We have actually a stellar cast of local and international faculty. So we've got Professor Sano, who is from Japan, and who's come down. And Professor Noriya Uedo, who's also from Japan, who came down sometime yesterday morning. We also have Dr. Mohan Ramchandani, who's from India. And then we have our national faculty, including Dr. Cameron Bell, Professor Bronte Holt, and Professor Spiro Raftopoulos. So thank you all for coming. Professor Raskovic, who helped us with the histopathology session yesterday, will join us later on for the colonic sort of session. We also have a lot of local faculty who has helped us tremendously. So that includes a lot of our friends and colleagues, Dr. Asif Chinarata, Biju George, Hamish Philpott, Harsh Kanhare, Sarah Thompson, Jesse Bumer, Philip Game, William Tam, Sarah Saxon, Andrew Luck, Tarek Samo, Arvin, Raja Gopalan, Devinder, Gary, and Diane. So they're all somewhere in the midst here, and thank you for coming as well and for helping us out. This meeting actually would not be possible without the support, or massive support, I would say, of our sponsors, NBIG and Olympus, as well as the help of the University of Adelaide and NALAN itself. I'd like to especially thank Kate Elliott and Joanne for helping us out. So look forward to an educational day today. And I'll hand over to Professor Danny Liu, who's the Dean of Medicine and Head of School of the Adelaide Medical School, to open this forum. So thank you.
Thanks, Raj. I was thinking as I was walking down here, what is the collective noun for endoscopist? And I did what people do in 2023 now, and is to ask ChatGPT. And I asked, and ChatGPT said it was a group, which didn't seem very funny or lighthearted. So I asked ChatGPT, what is a funny collective noun for a group of endoscopists? And it says a hilarious collective noun for a group of endoscopists is a gaggle of gastroviewers, which is not particularly funny, I thought, as well. And the gag bit would only apply to, obviously, the gastroscopists and not the colonoscopists. I welcome you to the University of Adelaide. I'm looking at the program. It looks amazing. I'm particularly interested in hot scopes and cool snares and hot scopes. I'm not sure what that means. One of the benefits of my role is actually to attend conferences like this and pretend that I can learn something. There was a vascular surgery conference not long ago where they were talking about navigating the endo-EVA system to try and find the landing place, which sort of sounds very Star Wars-like, and Millennium Falcon. Unfortunately, everybody, I can't stay because I have to drive to Melbourne later on, so I do have to leave straight away. I apologize for that. But just a very brief comments about the Adelaide Medical School. So I'm new to this place. My home is in Melbourne, and my previous home is Melbourne, so this is my new home, adopted home. And the Adelaide Medical School is seeking really to boost its relationship with the health sector and improve the sort of academic profile of the health sector. That's a very, it's our obligation to do that. And I think a conference like this is very much aligned with that. So I thank Raj and the organizing committee for establishing or hosting something like this, which is very much aligned with the goals of what the Adelaide Medical School wants to do. For the faculty who've come from out of town, especially from Japan and India, welcome. Also from Perth and Melbourne and Sydney. So I hope you have a good day. I'm sure you will. And thank you very much for letting me open, Raj. It's such an honor. And before I go, I'll try and see if I can fix this cooling for you to my right. I can't promise that I will fix it, but I'll pass over to you, Raj. Thank you, everybody.
Thanks, Danny. So just to let everyone know as well, we are live streaming this course today. So people with access to YouTube, mostly overseas, have got a link where they will be accessing this. So these talks will be available probably for a month or so after today. So welcome to whoever is watching from overseas as well. So thanks, Danny. And we'll start off with just to give you a bit of background. This was, and I put this up yesterday as well, but most of you weren't around. This is Professor Sano and Uedo 10 years ago. So they look younger now compared to 10 years ago, but this was our first imaging masterclass. I think it was held in Sydney then. So this was the last time, just before COVID hit, probably a month before COVID hit. It was almost cancelled because some of our faculty were coming from Hong Kong. So, but we managed to pull that through, and that was linked to Bronte's group in Melbourne, as well as Spiro's group in Perth and also in Auckland. And we did have live endoscopy at that time. This time around, we decided to make it a little bit easier or simpler given that we're just back on the ground running. So hopefully next year we'll have some sort of live endoscopy thrown in. So this is the program, you all know. So if you want to ask questions, as I said, please feel free to do so, or you can speak to the faculty perhaps during the break sessions. We'll just go on to the program, and part of the program was to recap of what we'd done yesterday. So I managed to get some slides thanks to my fellow Andrew Beanie, who's walking in. And we did a little bit of this while our international speakers and national speakers were speaking yesterday. So Professor Uedo spoke about esophageal SCC, and he did mention that we should identify high-risk patients if possible, especially those with concomitant SCCs of the head and neck and esophagus. He introduced this concept of alcohol phase flushing. If you're interested, you could look it up, and some of us do have this actually. So it's quite an interesting sign, and if your face turns red or you blush after a drink of alcohol, then there's a higher risk of SCCs. And also knowledge of high-risk endoscopic findings, especially melanosis of the oropharynx. So that was interesting. He also mentioned about use of advanced mucosal imaging techniques, including NBI for detection of superficial mucosal changes. This is just some strategies we can use if we find an area of abnormality in the upper esophagus, looking at microvascular structure. So you can find that these are called IPCLs, or intrapapillary capillary loops, which are sort of closed loops, and this is in keeping with an SCC which basically involves the epithelium or the lamina propria. So these are quite suitable for endoscopic resection strategies. Of course, when those loops, just like anything in malignancy, if it starts becoming more tortuous, as you can see there on the left, so-called type B2, or when they have neovascular formation like the B3 on the right. So these are kind of deeper cancers. So we should consider with B2 whether an endoscopic resection is suitable, but in a B3 sort of lesion, you probably want to take samples and send them off either for surgery or radiotherapy. So we also had this Ask the Expert session where we looked at some of the slides and worked out certain aspects of endopathology actually, and we got Professor Raskovich to help us with that. This is just an example of a slide of what looks like reflux disease, but with NBI it still looks like reflux disease, but when we look at the IPCL patterns, you can see this sort of closed loop patterns on the IPCL. So this is using again narrowband imaging with some level of magnification. Either the near focus mode can also sometimes help you find these sort of things. Looks like a cauliflower, and these are in keeping with early cancers. And we also clarified that to look at the lateral margins, it's useful to use something called Lugol's iodine. And Noria mentioned to us that probably the best strategy is to use 1% of Lugol's iodine to sort of delineate the margins like this. The normal esophagus would look brown, and as you can see in this example, which was taken probably about 13 or 14 years ago now, the SCC turns yellow. We also then talked about something called the pink color sign. So this is just one of the patients which we discuss of a patient who's having long-standing Barrett's esophagus. Slowly, the aim was to survey the Barrett's, but you can see that something more abnormal is occurring in the mid-esophagus. So as we went down further, we found that the capillary loops were actually in keeping with these closed capillary loops, in keeping with an early SCC. So again, this is a B1 type pattern, and based on the Japanese classification, this could be a cancer which is approaching the epithelium or lamina propria. So of course, Lugol's helped, and you can see that Lugol's iodine basically shows that it's probably larger than it seems, and you know, the margins can be clearly seen here with Lugol's iodine. And once one waits for about a minute, according to Noria, you will find that the color changes from yellowish discoloration like that to pink. So those were just a couple of biopsies which we took, and then subjected the patient to an ESD. Barrett's esophagus, Professor Holt helped us with looking at things. This is just a simplified classification, and this will be the general theme throughout the day, as you would find later on in the colon as well. Once the pit patterns becomes abnormal or irregular, as you can see on the right hand slide, that's in keeping with probably dysplastic change or early cancer. You will also see that there's this area which was biopsied over there. That was from a previous biopsy, and in this Barrett segment you can see a nice clear demarcation line. So it's quite useful to sort of switch on the image enhanced endoscopic sort of features on your scopes to kind of study this in greater detail before we take biopsies. So we also, Bronte also told us about some of the histological evaluation of resected specimens, and you know, what is deemed to be what we should be looking at with lateral and deep margins, submucosal invasion, lymph and perivascular perineural invasion as well. And these are some of the criteria which we can use to try to discern if patients can be treated endoscopically or whether they need to have more treatment. So even tumors expanding into the submucosa, which is less than 500 microns and well differentiated, could be good candidates to just be managed endoscopically. There was, of course, a debate with some of the chairs who were surgeons. But we then went on as well and looked at a case. This is just a case of a nodule. And we had to sort of work out whether this, we clearly decided as a group when we were discussing that this is not going to be useful to do an EUS here. Mainly because the EUS ability to work things out is not as good as endoscopic resection. So this is on retroflexion, which is another important point which we should use as when we're assessing patients with Barrett's esophagus. So clearly RFA, or radiofrequency ablation, was not part of the armamentarium for this sort of lesion. It would do no good to any patient, so that should be out of the equation. There was some talk about esophagectomy. We clearly decided that EMR would probably cut that specimen into 2, 3, or 4 pieces, and not quite useful to do. So this specimen firstly needed, or this nodule rather, needed to be assessed endoscopically, and this is what we did. But very quickly we also realized that there's this entity called a bit of dysplasia going underneath, or subsquamous dysplasia within a Barrett segment. So this nodule is just not a nodule. It obviously has got lateral extension. This is just a TXI mode being used to try to define this. It clearly is, again, quite friable. It bleeds on flushing, so some of the early signs of cancer can be seen here. And very quickly, as we move on, we can actually see that there's clear demarcation line or lateral extension, flat extension. You can see quite normal pits at the 6 o'clock and abnormal pits at the perhaps 12 o'clock region. So we're slowly moving the scope around, trying to determine the borders of this lesion. So it was not obviously nodular, but it was what we call as a Paris type 2A with a bit of a sessile component to it. So there's a flat and sessile component. So if this lesion needs to be removed, ideally, given that there's suspicion that this is probably going to have some superficial submucosal invasion, we should try to get this off in a single piece. So that's part of the assessment, and sometimes it can be quite tricky, but we ended up performing an ESD for this patient, as you can see there. And we looked at this image in retroflexion, and that's not a very clear image. There's a bit of debris on the lens of the scope, which sometimes I'm not happy with. But you can actually see the lateral extension there, and that's something we need to consider. So careful look is more important than just taking biopsies right away. So we looked at pathology, and we found that this had submucosal invasion, and for the patient basically underwent further endoscopic type strategies because of multiple comorbidities, and this was 2 years ago. On last sort of checks, he's still around and doing fairly well. So we opted for approach number A. So Professor Ueda also spoke about certain issues within the stomach. So we're just moving down the track, and we looked at basic concepts, again cleaning the mucosa, optimal air insufflation, looking at intestinal metaplasia, and some of the features of early cancers, including irregularity again of the vessel and surface structures, and a demarcation line. And then we went on to look at gastric polyps, which I found really intriguing. And Spiro, we took some pictures of you speaking and came up with these slides. So I hope you don't mind if we show it here. It's Spiro Raftopoulos told us about 4 very common gastric polyps, the fundic gland type polyps, the hyperplastic polyps, neuroendocrine tumors, and adenomas, and where they're commonly located, as you can see there, and the neoplastic potential of these polyps. And you can actually work out that we tend to see a lot of fundic cystic type polyps, which we tend to ignore, but when it comes to hyperplastic NETs or adenomas, then we clearly sometimes got to do something about it, especially for hyperplastic polyps. They're more than 1 centimeter in size. We have to try to look at removing them, mainly because there's some dysplastic or neoplastic potential. And the NETs obviously is divided into type 1s, 2s, and 3s. And the present recommendation is probably to remove them. But again, it depends on the patient's age and comorbidities. And then surveillance strategies, which were put forth as well by Spiro. And then Mohan talked to us about early gastric cancer and how important it is to check the H. pylori status and look at gastric atrophy, and if it's no atrophy. So there was an overlap between Mohan and Noria talking about gastric atrophy and how we can try to look for these sort of features when we're doing an endoscopy. And if you do find one sort of early gastric cancer, Mohan did inform us that you have to look for another one because there could be a field change, and sometimes synchronous and at other times metachronous cancers can occur. So you have to be mindful of that. So we looked at a couple of scenarios, as well as looking at some of the approaches for endoscopic resection. I didn't put the slides up yesterday, but this is just quite a standard sort of lesion in the lower body. Obviously, you can see some of the early signs, including the change in color, which Noria explained to us, as well as irregularity of the mucosa and the margins and the easy friability, all typical features of early cancers, and an ESD was performed here. We discussed that when resections are performed, we should try to get deep into the submucosa, just clearly above the muscle layer, which you can probably make out in this image over here. And this is the end result. So these slides weren't put yesterday, but I just added them on later last night. We did not discuss some of the strategies of closing these defects up, because some patients, generally patients are quite comorbid and they are on multiple antiplatelets and anticoagulants. So there are different strategies to close them, and we'll probably discuss some of these during the GI or lower GI bleed session, but probably that will be in keeping with using clips and APC perhaps. So I'll just end with this. We did not touch on the duodenum, and Bronte is going to speak to us in the next few minutes about non-ampullary duodenal lesions. This is just an example of one of them, and I quite like this video because with using a bit of imaging, we can actually see the villi floating, but the polyp sort of being quite firm, quite firm. So you can again see the villi moving as the water is being flushed like that, but the polyp still appears to be firm. So sometimes I find that this strategy helps with delineating the borders for this sort of lesions, so that we can remove them safely to prevent recurrences as well. So with that, hopefully that's a brief 15 to 20 minute encapsulation of what we discussed yesterday, which was a 4 or 5 hour session. And I'll hand the proceedings to the chair. So we've got Dr. Sarah Saxon, who's a pathologist. Thank you for coming, Sarah. We have Associate Professor William Tam, who works at the Royal Adelaide Hospital and the Lam McEwen Hospital. So thanks for coming, William. And we have Dr. Philip Game, who's a senior surgeon. Thanks, Philip, for coming as well. And we will go on with the next talk. Thank you very much.
Is this on? Thank you, Raj. Good morning, everyone, to this very first session of this second day of the AIMS meeting. Thank you for that recap. We'll start off introducing the 4 stellar speakers. I'll introduce the first one, who is Associate Professor Bronte Holt. You've already heard her speak yesterday. So Bronte has a national and international reputation as a gastroenterologist and interventional endoscopist. And many of you would know that she started her training at the Westmead Hospital before doing a PhD, and then actually getting the Queen Elizabeth II Diamond Jubilee Award to help her go to Florida to train as an interventional endoscopist before coming back as a gastroenterologist in St. Vincent, where she has spearheaded all the interventional stuff there and has continued to amaze us with all the work that she does in EMR, ESD, ERCP, EUS, you name it, third spacing. So today she's going to start off with a talk on non-ampullary duodenal polyps and what to do with them. Thank you very much, Dr. Holt.
Thank you, William, for a very kind introduction. So firstly, I would like to say thank you to Raj and the Asian Novel Bioimaging and Interventional Group and Olympus for sort of sponsoring and assisting with this event. It's really a great pleasure to be here to talk. Today I'm talking, as mentioned, on non-ampullary duodenal lesions, their classification and treatment. So duodenal adenomas can either be sporadic or part of a syndrome, and the 3 main syndromes are familial adenomatous polyposis, attenuated FAP, and MUTYH associated polyposis or MAP. FAP patients have a prophylactic colectomy to prevent colorectal cancer. So the main issue that we're now dealing with these patients is their risk of gastric and duodenal polyposis and malignancy risk. FAP patients have a 100% lifetime risk of developing duodenal adenomas. With FAP, it's an autosomal dominant mutation in the adenomatous polyposis or APC coli gene. They have a 5% risk of duodenal cancer by age 60, and this increases to 18% by 75 years old. Attenuated FAP occurs in about 10% of these patients, and polyps generally develop around 10 years later than the FAP patients. They also have a lower burden of duodenal polyp, but an overall similar risk of duodenal cancer developing. MAP disorder is recessive. It has a variable phenotypic expression, and it has a similar duodenal cancer risk as FAP and attenuated FAP. We grade FAP patients using the Spiegelman score, and that's part of our decision-making to help determine who's at higher risk of dysplasia progression towards cancer. The severity with the Spiegelman score is a combination of endoscopic and histologic classification, and it helps determine the endoscopic surveillance interval. The cumulative duodenal cancer risk increases with an increased Spiegelman score and can be as high as 36% in patients with the most advanced Spiegelman score. Other risk factors on top of the Spiegelman score are ampullary involvement, which does not form part of the Spiegelman score, size more than 10 millimeters, high-grade dysplasia, and high-grade dysplasia. In patients with FAP, their upper GI endoscopic surveillance should start at age 25, and that's the same for attenuated FAP. In patients who have MAP, it should start 10 years later at age 35. It's really important that when we see a patient with FAP or one of these conditions, that we only biopsy if we see a lesion that we're concerned may have high-grade dysplasia or, may have invasion, or if we're considering that they're not suitable for endoscopic resection. If we think that they're suitable for endoscopic resection based on our endoscopic evaluation of the lesion, then we should ideally not biopsy it due to the risk of fibrosis development. It's also considered to take a biopsy at their very baseline assessment, so not every time they come back, but when they have their first procedure. So this will see whether they have a tubular adenoma, tubular villus adenoma, or villus adenoma, which is part of the Spiegelman scoring system as well. This is a cohort study of 224 FAP patients. This is following their endoscopic management of them. And it found that most of the non-ampullary duodenal lesions were removed by a very standard lift and snare EMR technique, with a small proportion were removed by cold snare polypectomy, which I'll go on to discuss as well. So 21% of the defects were closed endoscopically with clips, and most were not. And there were 13 adverse events in this entire cohort, and most of those were related to bleeding risk. When endoscopic resection strategy is used in these patients, their duodenal surgery-free and cancer-free survival is significantly impacted in a positive way, so they have a good outcome of 97% surgery and cancer-free survival at 12 months and so forth. In this cohort, about 10% of patients went on to have surgery. Most of these patients had more advanced Spiegelman score, and one had an incompletely resected high-grade dysplastic lesion. So when we're seeing duodenal polyps, it's sometimes quite a challenge to know, is this an adenomatous polyp, or is it one of the other non-adenomatous conditions that can affect the duodenum, such as gastric heterotopia or an inflammatory type polyp. This is a paper which Professor Uedo is part of, and it describes using NBI to help differentiate the pit pattern and vascular appearance of adenomatous versus non-adenomatous lesions, which I find very helpful. So with adenomatous lesions, they have a pit-type pattern, where you can see in this image on image A, I don't know if I've got a pointer, but you can see there's a white circular pit surrounded by a round darker structure of the capillary. And in the C sort of picture, you can see that this also has an area of white opaque substance, which is overlying where the capillary structure is. So this pit-type pattern is what an adenoma in the duodenum looks like. And that's compared to this groove-type pattern, which is what we see with non-adenomatous lesions. This can be inflammation, gastric metaplasia, Brunner's gland hyperplasia, and lymphangioma. So these are the ones we don't need to be rushing in to take off by any means. So here it's the white, you can see on the picture in number A, they have this semicircular curved sort of white pattern, and that's the crypt. And then the vessels are within that curved white area, and that's the capillaries, and this is the groove type pattern. This is an editorial from Evelyn Stecker's group in AMC, and basically says that we shouldn't really be doing routine biopsies in these FAP sort of groups because of increasing fibrosis and complicating future polypectomy, and that we should be considering endoscopic resection for polyps that are more than 10 millimetres in size, which have an abnormal mucosal pattern or both. Endoscopic resection in the duodenum for non-ampullary adenomas can be quite challenging, and that's because of the anatomical considerations. It's a thin-walled structure, it's high vascularity, there's limited space to manoeuvre within, and there's also the increased risk of bleeding and perforation, and that's thought to be largely due to the bile and pancreatic enzyme exposure beyond the ampulla onto the EMR defect or ER defect. When we're considering a patient for an endoscopic resection, we think about the location. And these are the sort of main areas that I consider as a more challenging location. So we're thinking about the D1, D2 flexure on the medial wall, a periampullary region, because this has its own sort of risk factors associated. When you're in the horizontal duodenum and heading towards the DJ flexure, anything that's in the sort of 12 o'clock position, it can be sometimes challenging to resect because you need to turn your scope around 180 degrees to be able to get the snare into the right working channel position, or you need to use a side viewing scope to get deep down past the ampulla to reach it. And then at the DJ flexure, particularly if it's on the curved wall, because it's quite challenging to resect when the lesion is going across and over the flexure on the other side. These are the sorts of things that we use and consider for each of the endoscopic resections in the duodenum. So the endoscope choice is largely made by the location and access for the lesion. In more proximal duodenal locations, you can consider using the gastroscope, a paediatric colonoscope I'd use for anything beyond, in D2 and beyond, and a duodenoscope if it's on the medial wall around the ampullary region. And if you're using a gastroscope or paediatric colonoscope, then to utilise a cap. All the resections, if they're being done hot, should be with a microprocessor controlled generator. In my unit, we use the Urban machine on Endocart Q Effect 3. Carbon dioxide insufflation should be routine for these procedures as well because of the risk of microperforation and also post-procedural discomfort with air. In terms of device choices, typical sort of EMR devices can be used, but there's just a couple of considerations here. If you're using a side viewing endoscope, I like to use a Carlock needle, which is a Teflon coated needle, and it means that it doesn't bend and kink when it's passed over the elevator. So this is what I would use with a duodenoscope. And otherwise, a standard injection needle is used. With snares, I always choose small snares, so it's very rare that I would use a 20 millimetre snare in the duodenum at all. And depending on whether it's going to be a cold snare polypectomy or hot snare, it's always a thin wire snare though. And then a scope cap, as mentioned. For any lesion that's more than 5 millimetres in size, I perform a submucosal injection. If it's sort of 5 to 10 millimetres, this can simply be saline. I love opening up that submucosal space in these patients. But if it's a larger EMR, whether cold or hot, I would use gelifusин, or you can use saline mixed with indigo carmine blue if you have it, or methylene blue if you do not. And I usually use adrenaline as well to limit the immediate blood within the defect. Cold snare resection in the duodenum is a really important concept that I'd like people to take away from, because the main issue in EMR in the duodenum is bleeding and perforation, and cold snare virtually eliminates these risks. Doesn't quite, but it significantly reduces them. With hot snare, the post-procedural bleeding rate can be as high as 33% for larger resections. There's a significant risk of intraprocedural perforation, which if it's in the duodenum can be quite a significant complication to manage, and also a risk of delayed perforation. This is the ESGE guidelines for management of superficial non-ampullary duodenal polyps, and they recommend a cold snare polypectomy for small lesions in the duodenum. But there's increasing numbers of papers coming out looking at using cold EMR and cold snare for larger lesions. This is a retrospective study. It's relatively smaller numbers, but it's a duodenal adenomas, 20 millimetres or greater in size. And they assessed 33 who had cold EMR, 101 with hot EMR, and they found a higher rate, though not significantly statistically, for technical success. They found that the procedural time was shorter. There was a significantly lower intra-procedural and post-procedural adverse event rate, and a lower rate of residual, interestingly, at recovery, at follow-up as well. Most likely because we feel more comfortable taking wider margins in these lesions. And this is another study which compared cold snare and hot snare polypectomy for their resection. It's a retrospective study at 2 tertiary centres, and these were included smaller lesions, so 5 millimetres and greater in size. And again, it found that there was significantly lower delayed adverse events in the cold EMR group. So apart from hot and cold EMR, what are other resection techniques that can be used? I must admit I don't do either of these, but there are centres that would routinely sort of employ these techniques. And one is a cap-assisted EMR. The terminology here can sound a little bit confusing because a standard EMR uses a cap, but this is where you use a cap with a snare. It's a sort of a semicircular type snare that is able to get placed within the cap. You suction the tissue into the cap and then close the snare around it. And then there's the underwater EMR technique where no submucosal injection is made. The duodenum is insufflated with water, and that's meant to sort of allow the polyp to float more within the duodenum and allow for a resection. But I don't feel quite comfortable with this technique yet because I love lifting it away from the muscle personally. If we do hot EMR in the duodenum, how can we reduce the adverse events? So immediate perforation, a submucosal lift using a smaller snare, and resect in line with the duodenal folds. So when you see the folds sort of in front of you, you want to try and get your snare in line with the duodenal folds rather than placing it over the top. In terms of delayed perforation, so try and avoid injury to the EMR defect, and one of these things is a diathermy choice for resection, so using a microprocessor which combines a cut and coagulation current, so don't go for a forced coagulation resection with hot EMR in these patients. It's really important to assess the EMR defect for muscularis propria injury and then to close it if it's present. This is a picture of a patient who had sent to me but had multiple central biopsies from this duodenal polyp. And that's reflected, you can see in the defect, which I've already treated with snare tip soft coagulation around the end, but there's a lot of fibrosis in the middle. And so I had to use, I'll discuss it later in the colon talk, but cast technique where you pick away at the adherent adenoma in the middle of the defect to get rid of it and then burn it. And so this patient ended up having quite a lot of diathermy into the duodenum to get rid of this fibrotic adherent adenoma. So I clip closed it with a zipper sort of technique afterwards. How can we reduce the risk of post-procedural bleeding? So we don't routinely coagulate visible vessels, and we really want to avoid putting diathermy into these defects. There is a lot of work being done on using topical hemostatic agents such as Purostat and Hemospray, and there's a multi-centre trial run through Liverpool with Milan Basan looking at Purostat at the moment, and also defect closure, whether that's through the scope clips, over the scope suturing, so using an over-the-scope clip or suturing, which all of these images sort of describe. One of the final sort of things I want to talk about is when we do EMR in the duodenum, just to recognise the risk of leaving some residual adenoma behind. This is a study recently published from Michael Burke's group, similar to the colon sort of work that's been done doing snare tips off coagulation to the defect edges. And it found that when you use the thermal method to the defect edges, it significantly reduced the recurrence rate at the index for surveillance down to 2.3% from 17% if a conventional EMR was performed. Thank you.
I think we're leaving questions till the end, right, Raj? Okay. Any questions from the audience?
Can I start
thought there was an instance of dysplasia even in smaller polyps. Do you know what that instance is? Because you've sort of said leave them alone if they're less than 10 millimetres, but...
So in sporadic adenomas, we would remove them. We would remove all polyps, all comers, whatever size they were, 2-3 millimetres. We would remove them in the duodenum. In conditions such as FAP, yes, we wouldn't routinely remove smaller polyps in those patients. Yeah.
But there is still a risk of
correct
dysplasia in
there,
those.
there is, and I think that highlights the importance of doing a really careful endoscopic assessment of the polyps and setting aside enough time during that surveillance endoscopy to allow you to actually look at all the polyps and if there's any that look suspicious, then to remove them even if they're less than 10 millimetres in size. Yeah.
Question from Cameron.
Bronte, by definition... There's a microphone next to you, in front of you. That's live? Okay. Bronte, by definition, all the adenomas are dysplastic,
yep.
right? But I was in a duodenum in an FAP kid yesterday, and he had quite a number of 1 millimetre areas. And I was sorely tempted to just use a cold biopsy forceps, not to biopsy them, but to just get rid of them. Would you discourage me doing that?
I would, Cameron. I think I'm glad we brought this up today. No, no, I would. I think we've got when you've got cold snares, and you can ensure that you've got a clear margin. Because what we're worried about with doing a cold biopsy resection is that you're going to leave something behind, and then if that continues to grow, if there's one little cell left behind, then you're going to be left with a polyp that's got some scarring and fibrosis underneath it. So I would just simply change it out and then put a cold snare down if you really wanted to remove that polyp. Yeah, I don't think it adds significant time really to doing a biopsy.
Question from Spiro.
Bronte, what about Lynch patients? I certainly have a subset of Lynch patients that have very subtle duodenal adenomas with quite advanced or early cancer.
Yeah.
Even. I know the recommendation is not necessarily to do surveillance in these patients, but I must admit I've increasingly started doing it when I do their annual colonoscopy.
Yeah, I mean, I think that's a good approach, and I've had the same happen as well. And so I think at least a baseline endoscopic evaluation, and it may not be at the same frequency. I'd be interested to know from the panel as well what their experience here is. But yes, I think they are an increased risk population.
I wanted to just... Oh, okay. So maybe we can take this offline at the end. Thank you very much, Bronte.
Our next speaker is Professor Mohan Ramchandani, and we all heard him yesterday with the excellent talk on gastric cancer. He is from the Asian Institute of Gastroenterology at Hyderabad and has an international expert in the endoscopic field, and we're looking forward to his talk on the small bowel. Thank you.
Thank you. At the outset, I thank Raj and thank you, Philip, for the kind words. And let's talk about some of the unexplored areas. And one of the place where we really struggle to go in is small bowel. And why it is? Because it's a freely hanging structure in the peritoneum. It's not like a fixed, like a esophagus, where you push your scope and your scope advances. It's like doing endoscopy in a noodle. If you go into the noodle itself will get pushed rather than your scope traveling through that. It's like putting a thread into a loose cloth. You cannot push it, but you need to have some pleating device for the cloth to be put on the thread. And that is why the endoscopy in small intestine has never been by bare endoscope, and it is with some pleating device. And alone, endoscope cannot be, the only way where we can have a diagnosis. I think we have to take care of a small bowel by a group of, the persons who are treating this, who can do capsule endoscopy, who can read a good CT or MRI, and with this combination of three technologies, we can reach to a diagnosis. But we are still looking for an enteroscope which is ideal. And what is ideal enteroscope? Which can allow us to do complete small bowel intestine in reasonably quick time. And it should allow us to study a particular point where we can come back and forward and steer our endoscope to read that lesion. Not only read that lesion, but also to do therapeutic endoscopy to remove a polyp, to do a APC of angiodysplasia, or so on and so forth. But we need a good therapeutic capabilities, and should be relatively non-invasive, unlike intraoperative enteroscopy, or even which requires a lot of invasiveness, which we do not want. That's why the history of enteroscopy been slow to progress. Previously, we had Saunders methods, or which will gradually travel through the intestine. We have to wait for hours. The paradigm shift was brought with the balloon-assisted enteroscopy, where in 2001 onwards, we saw a lot of improvement being done with some of the devices, including the spiral enteroscopy, which has come in the vogue very recently. And these were some of the guys who introduced the device-assisted enteroscopy. So enteroscopy is always a device-assisted, and the device can either be a balloon or a spiral. So this is the first enteroscope which was brought in, was by double balloon enteroscopy, where enteroscope will be pushed along with an over tube into the bowel, and then there will be a balloon on the enteroscope which will go inside first, which will stabilize with inflation of the balloon, followed by an over tube balloon which will be inflated to keep it in place and avoid looping in the stomach, and then through that again enteroscope will be pushed, secure its place by a balloon, and over tube will be pushed forward. So this is a sequence of push and pull enteroscopy which allows the intestine to pleat onto the endoscope, and the endoscope moves forward. So this is about the double balloon enteroscopy. The single balloon enteroscopy is also similar way, but there is no balloon onto the enteroscope, but there is a balloon onto the over tube. And this made this procedure slightly more simplified, but ultimately it remains same, that you need to have a sequence of push and pull maneuvers to be done to allow your endoscope to travel forward. Then comes the another technique where people thought that why not to use a mechanical advantage of a screw, where a screw is rotated, and this rotation movement is converted into a linear motion, and this was the over tube which was used onto the existing long enteroscopes like Olympus 200 centimeter scopes or Fujinon scopes, and the over tube of the balloon was replaced by this over tube which was 118 centimeter long, and it was again a method of pleating where over tube was rotated by the hands, and there is another physician which will help us to direct our tip of the endoscope to the lumen. So it was like a two operator method, very cumbersome, but it was very effective because it allowed us to travel throughout the small intestine in very reasonably quick time. So the problem with balloon-assisted enteroscopy was those scopes are long, 200 centimeters. They require, the therapeutic channel is 2.8. The spiral enteroscopy was slightly better because it allowed us to do enteroscopy in a reasonably quick time. And another advantage was that as soon as the disadvantage with balloon was as soon as you deflate the balloon, you may lose some ground, you may fall down, while it was not happening with spiral. So it provided us a stable platform. So these are the two advantages of spiral, being very quick and two, providing a stable platform, which was advantageous over the balloon-assisted enteroscopy. Then came, but still the problem persists that the scope is cumbersome, it's time-consuming, and it was traumatic to endoscope. I developed a tennis elbow doing all these procedures. Then came the help of Olympus when they took over, and then they came up with an idea that why not to take advantage of a spiral and allow the spiral to be rotated by a motor. So this is a new technology where the first time the endoscope being propelled by a motor, and it takes away some tactile feedback from the endoscopist, but it makes this procedure much more quicker, and already we had advantage of stable platform and the quickness of the procedure. So it comes with three things. One is the endoscope, which I'll talk about that, and a motor control unit, which has foot pedals, and you can accelerate like a car, pressing a right pedal, which will move forward, or a left pedal, which will bring this scope back. And it has a disposable over tube, which is 24 centimeter long. I'll quickly go through this video showing how the scope is. It's 163 centimeter long. That make us to use all the accessories which are available in our endoscopy unit. It has got a coupler over there which only rotates, and this coupler, rotating coupler, has to be attached to this disposable over tube, which is 3 centimeter wide. That makes this over tube a bit bulky, but it is, most of the part is still collapsible. It's only the 18 millimeter part which is hard, and we have to use CO2 insufflator, and there is an accessory water jet which allows us to do enteroscopy. And because we do not have any tactile feedback, we have an automated system where this resistance is gauged by this machine, and if there is an undue resistance, it stops. So this can be sometimes advantageous because you do not have a tactile feedback, and if there is a kink or a stricture, the machine won't go forward. Sometimes it may stop in esophagus if there is an infiltrative disorder of the esophagus, where there is no distensibility. And this is how the over tube is attached to the enteroscope, and it is now ready to use. This is the enteroscope as I was talking about. The good thing about this scope is there is a 3.2 channel, there is an accessory water channel, and this scope is not very long. So this makes us to use many of the common situations, but there are peculiar contraindications because, as I said, if we have a large esophageal or gastric varices, we will not use it. If there is a foregut stenosis, because this 3 centimeter over tube cannot pass through that, if there are deep mucosal laceration, or if there is an infiltrative disorder of esophagus which won't allow esophagus to distend, or if there is, it can be done by retrograde method also, or these are some of the contraindications. One will be very careful in doing enteroscopy with this method in patients who have already undergone abdominal or pelvic surgery, because there will be a lot of adhesions, and then, as I said, there can be a blockage of this scope because it won't cross any kink. The good thing about this scope is, again, a very quick method. This is the esophagus, which was preemptively dilated to 20 millimeter by Buji. That is the prerequisite, as company tells us, but gradually we are not using that technique. And then we go across the stomach and reach to the pylorus. And then the advantage of this scope is there is an accessory water channel. You can switch off the CO2 and start doing underwater enteroscopy, which is very easy to do with this procedure because there is a water pump attached to this. And this is the duodenum. And then once you cross the DJ flexure, it's like swimming across, and you can just quickly go into the distal part of the intestine. For initial few cases, we do this procedure under fluoroscopy, and this allows us to do pan enteroscopy in very quick time. If you choose your patient right, you can reach to the cecum in 30 to 35 minutes. And you can take help of a fluoroscopy. You can see we have come right into the distal ileum, and we'll just switch on the fluoroscopy to see where we are. Sometimes from inside the lumen, we cannot tell where we are, and we keep our track by doing this fluoroscopy, inject contrast, and we know that it's just a few centimeters away from the cecum. and then we go and try to do some maneuvers like based on the fluoroscopy, and then we can see here we are reached to the back of the IC valve. This is the back of the IC valve, and with some pressure, and you will reach into the cecum. So this took around 40 minutes to reach to the cecum. And this happens with most of the cases. And once you go inside, and it's time now to observe, because the initial aim is to do as much examination possible, and then once you come back, the release is so gradual as compared to balloon-assisted enteroscopy, where if you deflate the balloon, you may fall down, and the passage of accessory is so easy because there is a 3.2 channel, and management of bleeding cases are also easy. Not only that, we can do retrograde enteroscopy in similar way. Crossing the IC valve is so easy, and then we can reach to the DJ flexure also. Not only that, we can do a panenteroscopy by bidirectional method, where we can put a tattoo to the maximum reached mark and go by a retrograde method. In such a way, we could achieve a 60% panenteroscopy. That was early in our learning curve, but gradually we knew that we have to exclude some patients, like patients who had previous surgery, those who are not fit for general anesthesia, chronic liver disease with large esophageal varices. And if you choose your patient right, like avoiding doing in children or less than 40 kg weight, we can choose our patient to get maximum yield out of this. And this is what we compared between a single balloon and spiral enteroscopy. And we found out that the speed, the diagnostic yield was same, because we took a lot of help from transabdominal imaging, but the depth of insertion was much higher with motorized spiral enteroscopy, and the panenteroscopy rate was 37% in this study as compared to 0.7% in single balloon enteroscopy, and the speed, depth per minute, was much better with this. We can also use this scope as a therapeutic procedure. You know, like this is a very common problem to have a capsule got stuck in between once a patient is being evaluated for Crohn's disease. And this video is to demonstrate how easy it is to pass difficult accessories. Those who are using balloon-assisted enteroscopy must have realized if you are deep into the intestine, it is very difficult to pass thick accessories like balloons to dilate the stricture. And Crohn's disease poses a problem where we need sometimes to dilate the stricture. The capsules are stuck. We can pass through this small bowel, as I said, very smoothly. You need to have a general anesthesia, because in cases of desaturation, we may take some time to remove that. That's why general anesthesia is required to do this enteroscopy. And you can quickly reach to the lesion, and then we can dilate these. You can see we can pass the contrast. We know that there is a stricture, there is another stricture, and then there is a capsule which is stuck over there. The passage of accessory is so easy here. You can dilate this, and then once you dilate, there is another stricture to be dilated. And then once the dilatation is done, we can remove this capsule. The another situation where I use this scope very frequently is Peutz-Jeghers syndrome, where we are supposed to do panenteroscopy, complete examination of the small bowel, because these patients come to us with many problems of intussusception, GI bleed, where we need to do complete examination of the small intestine. You need to remove these polyps. These are very big polyps causing intussusception, intestinal obstructions, and we need a stable platform like that. So if somebody is removing a EMR, doing deep into the ileum, will realize that in balloon-assisted, it was almost impossible to remove such polyp with such a stable platform. So that allows us to do complete removal of these polyps from oral to cecum, and then the patients are kept for surveillance for other malignancies, but the mechanical obstructive or bleeding problems are removed completely. I'll skip this video for the want of time, but now this scope is being also used for ERCP in altered surgical anatomy, and we can reach to HJ side, hepaticojejunostomy side from the Roux-en-Y loop, and we can do this procedure. There are many series now. We have a largest series. The problem with this scope is definitely a fear of causing some mucosal tear, and there will be debate about the safety of this scope, but we have been using this for now almost 4 years. We have done almost 600 cases with minimal severe adverse event, one perforation while doing a balloon dilatation. Rest of them were all minor adverse events, and the pan-enteroscopy rate gradually is rising to 80%. So in the end, I will say that there are now 3 methods available for enteroscopy, the double balloon one. This is the most utilized endoscope throughout the world. Unfortunately, it's time consuming, it is difficult to disinfect, it's cumbersome to assemble. The single balloon is easy to assemble, but it has got inferior rate of pan-enteroscopy. The spiral enteroscopy has got an advantage that it enables deep small bowel intubation in a very quick time. I think these all are complementary to each other. I will use a double balloon or single balloon in a post-operative patient or a small children, while I'll use spiral enteroscopy in a patient whom a pan-enteroscopy is required, like a patient who has obscure GI bleed, whom I need to have complete examination of the intestine, like Peutz-Jeghers syndrome. I'll use spiral, and who is relatively fit. With this, I'll end my talk, and thank you very much for your patient hearing.
I think that was absolutely amazing, and you've taken scuba diving to a new level, swimming through the small bowel. Because we're short of time, we'll just have one question. Did you?
Can I?
Oh, sorry. Yes,
Thank you for your interesting presentation. I have one question. When I use single balloon or double balloon endoscopy, sometimes happens pancreatitis and hyperaminonemia.
Yeah.
But how about the complication of spiral balloon?
Yeah, so that has not been seen because that was the pancreatitis because of balloon-assisted enteroscopy. The mechanism is the frequent to and fro motion of the overtube around the papilla. And once in spiral enteroscope, the overtube crosses the papilla, there is no further trauma over there. So there is a scientific point that it may not cause, but we have seen so many cases, not a single case has been reported of pancreatitis post-spiral enteroscopy. It has got its own disadvantages, but not pancreatitis.
Okay, thank you very much. That was an amazing talk.
It's now my pleasure to introduce the third speaker for this morning, and that's Dr. Cameron Bell, who is no stranger to all of us here. He is indeed a national name in gastroenterology in Australia. As you know, he works at Royal North Shore as an endoscopy lead there, but his most famous claim to fame is that he really has been very interested in quality in colonoscopy. He has been the instrumental chair of the NETI, the National Endoscopy Training Initiative, for the last 9 years. He has also, for his sins, been the chair of the National Working Party, which has generated for us the 2011 surveillance colonoscopy guidelines, which was then revised in 2019. Now, he's about to tell us what's new in the colonoscopy surveillance space. So welcome, Dr. Bell.
Thanks very much, Will. Rather than an update, I'm going to muse about an approach to surveillance guidelines. I'm going to concentrate I'm going to ignore inflammatory bowel disease and dysplasia. I'm just going to concentrate on post-colorectal cancer resection, which is pretty straightforward, and then compare and contrast the Australian guidelines, which I think are unjustifiably complicated and complex, and mention the British and US guidelines. So we just try and sort this out. I'm sorry, I'm not an Apple guy.
It's not recognized. Okay.
No, I cannot.
So while we're musing this, Cameron, we will are you taking responsibility, accountability for the unjustifiably complex surveillance guidelines that we now have?
Oh, look, I guess like a Prime Minister whose ministers are misbehaving, I suppose I have to. I'm not going to fall on my sword over it. I desperately tried to talk the chapter leads around to my point of view, but I failed, unfortunately. So, but I don't think they're a complete waste of time, but unfortunately there's the complication that they were then used to link to MBS item numbers, which I'm not even going to touch on. So basically we might start on the easy bit while we're sorting out, and I apologise that I'm not an Apple sort of person. So the colorectal cancer guideline is basically if you've crossed the cancer and done a complete colonoscopy before resection.
Cam, which is your talk?
Yep, we see something there.
It should be Raj. It should be Raj. Yeah, here we are. Raj, and it's over this. Yeah, that one.
This one?
Yeah.
Go.
Okay. Yeah. Thanks. Sorry for the delay. So, thanks. So, after a curative resection for colorectal cancer, the colon should be examined completely before or within 6 months of surgery. The latter in the case of an obstructing cancer where the unexamined proximal colon wasn't resected with the cancer. The subsequent colonoscopy should be at 1 year, and then every 3 to 5 years according to polyp findings as per the polyp surveillance guidelines. So that's pretty straightforward, although it's very common in my experience for post-cancer resection patients to end up with annual colonoscopies, which is not something that the literature would bear out. So most of the time I'm going to talk about surveillance after resecting conventional adenomas or clinically significant serrated polyps. And I'm going to spend most of my time musing because I've thought an awful lot about this. So the problems facing analysis of the literature, or those charged with analysing the literature and generating surveillance guidelines, are that these are old studies, they're using old scopes and old colonoscopist behaviours. To my mind, that almost makes the literature uninterpretable. And if you read the British or the Australian or the US guidelines, many of the recommendations are low evidence, low confidence. So weak evidence, low confidence in making a recommendation. And when you consider the proportion of our colonoscopy burden that's taken up with surveillance, it's a substantial issue. And they're old studies because they need a certain amount of follow-up to work out what the consequence of having 1 or 2 small adenomas or 3 or 4 adenomas and mixed in with some sessile serrated lesions are. So translating those results into 2023 expectations of high quality colonoscopy is difficult, and you have to remember that built into these guidelines, polyps, we know that polyps can be missed or incompletely resected. So the final thing is that they're generally an extrapolation from unplanned observational cohort studies rather than planned follow-up intervals. And one of the areas that's crying out for research is to compare a surveillance strategy after initial findings versus no surveillance, because there is mounting evidence that it's the first colonoscopy in a patient's lifetime that has the most impact on reducing the risk of colorectal cancer. And if I were a dictator, I would only let high ADR colonoscopists do people's first colonoscopies, but I'm not. So theoretically, once the colon's cleared, the next scope should take place at a Goldilocks interval. It's not too late before a new polyp becomes a cancer, and it's not too early because there's little point just removing low-risk diminutive adenomas, the vast majority of which, I keep telling my registrars, are never going to turn into anything in the patient's lifetime. Considering that good ADR colonoscopists find polyps in 50 to 60% of people, and only 5 or 6% of people are ever going to get colorectal cancer, it just makes that point that the vast majority of the numerous polyps we cut off were never going to do anything. We just don't know which ones would have and which ones wouldn't. And you ideally want to find and remove endoscopically manageable advanced polyps in a significant proportion of the surveilled population. So we'll get on to the Australian guidelines, but I'm not going to spend a huge amount of time on them, and I'm not aware of any plan from Cancer Council Australia to revise them anytime soon. So the standard nomenclature is of low-risk adenomas, meaning only 1 or 2. They're small, so they're less than 10 millimetres, and they don't have high-grade dysplasia or velocity. High-risk adenoma is basically any other conventional adenoma, more than 2, and with any of those other features of an advanced status. And this is the only table, the only colour-coded table that I'll spend any time talking about. You would all have this on the wall of your endoscopy units. So let's talk about low-risk findings. So that's these. So 1 to 4 adenomas less than 10 millimetres without high grade or velocity. And the 3 to 4 number used to attract a 3-year interval in the 2011 version, and the 1 to 2 used to attract a 5-year. Now, there is plentiful evidence that if you have 1 or 2 conventional adenomas only, and they're without any high-risk features, that having those found and removed at colonoscopy, you are then at below average population risk for subsequent colorectal cancer. And there was a strong push in the working group to return these people to FOB testing. I might just move on there, but just one sort of observation that subsequent to those guidelines, the New Hampshire group suggested, with a reasonable amount of evidence, that diminutive and small conventional adenomas, so those essentially above and below 5 millimetres, may have different significance. And I think a lot of US colonoscopists take this into account, and instead of doing it at 10 years if they're both diminutive, do it at 5 years if they're both small. So high risk findings without multiplicity is the rest of those first 2 lines on the table, and you can see that that's either that the high risk is either because the polyps removed have high-grade or villous changes, or that they're then a mixture of a couple of things. And the riskiest polyps and the ones for whom earliest surveillance is recommended are those with at least one of the adenomas being more than 10 millimetres in size, with high-grade and with villous change. Now, the impacts of those 3 things are difficult to tease out because they interact with each other, and the presence of 2 or more of those 3 factors probably confers greater significance to colonoscopic findings. And it's interesting that the Brits don't rate velocity at all. They've taken it out of their equation largely because of variation amongst pathologists. Multiplicity, which is the bottom 2 lines of the original table, suggests that there's a possible field defect or a polyposis syndrome, and it increases the increased spectre of having missed something at your initial scope. So essentially, unless you're very lucky, you score a 1-year colonoscopy. Now, my biggest problem with the 2019 guidelines was the serrated polyp follow-up, which was touted by the chapter authors as being groundbreaking. I'm not going to concentrate on this because really I'm not going to concentrate on this slide because I don't want to get into that. But all of the cess-ulcerated lesion surveillance problems rely on 3 studies. They were graded level 2 or 3 evidence, and they were felt to be of low quality. They were more than 10 years old. Well, they're now more than 10 years old. And my big problem with them was that the SSA detection rate was, as it was called at that time, was lower than 5%. Now, I'm not going to embarrass the audience by asking you to tell me what your SSA detection rate is, but we know that in elite hands it should be up around 15 to 20%. So what these studies were identifying was what was happening to the 3/4 of SSAs that they were missing. And to then base a whole series of complex tables of SSAs only, SSAs with adenomas, and then second and third surveillance recommendations on such flimsy evidence strikes me as being unjustifiable. I don't mean to sound too harsh, but you know, we've been burdened because of the MBS issue with trying to rely on this stuff, and I just don't think we can rely on it. I'm going to skip to a colour diagram that I think reflects that situation. So this is the first surveillance if you only have cess-ulcerated lesions. That's pretty straightforward, and it's probably not unrealistic. But then to get to this degree of complexity and try to convince me that any one of those 16 squares on the diagram has enough evidence to justify applying it to at a national level, I'm not that gullible. Let alone this. I don't even know what the hell this means. I have looked at this and
You drew this up? You made it up.
Fair to say it wasn't me. This time it really wasn't me, like the farmyard cat in trouble. Now, and this. So this is the, This is the colour diagram that I think reflects this situation. When I was preparing this talk, I was reading to my 3-year-old, and I thought the Cat in the Hat had it all just about summed up. So I'll move on quickly to finish off. The larger neoplastic polyp surveillance is largely based, I think, on Michael and the Westmead's opinion that on block resection be looked at again in 12 months and piecemeal at 6 and then 18. The multi-society, the US multi-society task force guidelines, which came out a year later than the Australian ones, are reasonably parallel but much simpler in terms of the first surveillance interval. If you look at this, and I'm happy to have the slides shared, etc., you can come and get a copy from me afterwards. It parallels pretty similar. It parallels pretty closely the Australian guidelines. So they, for example, recommend 7 to 10, not 5 to 10, for 1 or 2 low-risk adenomas. And their first surveillance guidelines are very similar regardless of what your baseline finding was. So on the uncircled side of the diagram, it doesn't really matter whether you had 1 or 2 tubular adenomas, 3 or 4, or advanced adenomas, you ended up with a similar surveillance recommendation. And I think if you're going to apply, you're going to get beyond first surveillance, I think something like this is necessary. Now, this is the British version, and I think this is my last slide, Raj. I'll get out of the way in a minute. But I wondered whether Boris Johnson was involved in generating these, because they are very, very nihilist. And by comparison with Australia, where we perform 1 million scopes a year, head per head, the Brits do 38% of that, and largely it's because they don't do nearly as much surveillance. So the only bit of this that refers to adenomas and cess-ulcerated lesions is the third green diamond in. So over on the left-hand side is colorectal cancer. The next diamond in is large non-pedunculated polyps. Then there's the bit that refers to adenomas and their high-risk findings, which are really just more than 10 millimetres or high grade. And if your initial findings are high risk, then you have a one-off surveillance colonoscopy at 3 years. And if you're not, you bugger off back to the fecal occult blood testing program. So if you look at the people involved in generating the US, the UK, the Australian guidelines, they're all experts. And one of the things that makes me suspicious about this is the fact that they can all be looking at the same literature and come up with such vastly different opinions. So this is my last slide, I think. I think in future we need a different approach to surveillance guidelines that should probably also incorporate operator stratification according to ADR and SSLDR. And it should also take into account polyp biology. You know, we're all familiar with the phrase polyp cancer sequence, and no one can actually tell me what that is, whether it's a thing that if an adenoma turns into a cancer, whether it's going to take 5 or 10 or 10 to 15 or even longer. But as far as I'm aware, the only polyps that have a more rapid pathway through that sequence are Lynch polyps and some polyps in serrated polyposis, maybe SSLDs, but maybe patients who develop velocity or high-grade dysplasia in a small lesion. I think this is the way that future guidelines are going to have to be generated. And I'll stop there, Raj. Thank you.
Thank you for that excellent overview, Cameron. We have time for one question one question.
So what should we be following now, Cameron?
It's a very, I reckon the 2011 guidelines were much closer to the mark. And I think the next revision of those guidelines, and I'm not aware there's any funding or any intention at the moment, but I think that needs to be, that we need to sort of bear in mind the fact that expert groups come up with quite different. And I think the big hole is what to do with SSLs. Generally, you know, just the feel from reading all those guidelines carefully is that SSLs of the same shape, the same size, probably carry a slightly more weight than a conventional adenoma. But we also know from the work from southeast Queensland that many people have SSLs in their bowel for 17 years and nothing happens. Thanks.
Good morning, everyone. I think we're going to push our break back for 15 minutes and break at 10:15. It's now my great privilege to introduce our next speaker, Dr. Yasushi Sano, who's clinical professor at Kansai Medical University in Osaka. He's a world leader in the field of diagnostic and therapeutic colonoscopy. He was a pioneer of narrowband imaging, and he developed the first capillary pattern classification system which bears his name. He's a member of several advisory boards, both in Japan and the US, and since 2019 has been chairman of the Asian Novel Bioimaging and Intervention Group. And on top of all of that, he's got a PhD in gastrointestinal pathology. So please join me in welcoming Professor Sano.
Thank you very much for the introduction. So good morning, everyone. So on behalf of AMBIC, so I hope great success of this meeting. So thank you very much, Professor Bell. I want to follow the Japanese side of view of the using data of the Japan polyp study. So we published some guidelines in Japan from the results of this Japan polyp study a few years ago, and the Japan polyp study primary outcome endpoint is to evaluate a surveillance program after the removal of all the polyps in Japan. And the study started in 2000, so that 23 years ago. When I was 34 years old, I started to write this protocol. And then, this is the scheme of this study protocol. The patient received the first initial colonoscopy, and then the old polyp was removed. And also, polyps means adenomatous polyp, and sessile salivary lesion. I'm sorry, but 2003, there is no term of sessile salivary lesion. So that we removed all the serrated lesion more than 10 mm size. At that time, we called large hyperplastic polyp. And the older patient received the second colonoscopy 1 year later again. And if we identified the polyps, so we removed all the polyps. And the patient randomized into 2 groups. So the patient received one at 3 years later, and the other is patient received 3 years later. So this scheme, this part is almost same as the national polyp study in the U.S. And so we evaluate the advanced neoplasia during this 3 years period, compared to 2 examination group and 1 examination group. This is also same as a national polyp study. And so this is final data. So we identified the advanced neoplasia 2.1% in 2 examination group and 1.7% 1 examination group. There is no significance, so we recommend a 3 years interval after removal of the polyps. And so during this 4 years period, so metachronous advanced neoplasia identified 29 advanced neoplasia and 28 patients. And so 62% classified as non-polypoid colorectal neoplasm. In the non-polypoid, so 83% classified as LST non-granular type, complete flat lesion. And unfortunately, so serrated lesion of the advanced neoplasia is very few, only 1 lesion. So this is a national polyp study compared to the Japan polyp study. National polyp study identified 3.3% advanced neoplasia so during follow-up, compared to 1.9%, overall 1.9% identified in the Japan polyp study. And I think maybe we use high resolution endoscopy with chrome. Sometimes we use imaging Hassan endoscopy. This is location identified metachronous advanced neoplasia. So the 45% is located in right side, and so 38% is the left side, and 1 invasive cancer identified in the rectum. And as I said, mostly this metachronous advanced neoplasia classified non-polypoid lesion, especially LSD non-granular type. So this is summary. From the result of the Japan polyp study, we recommend the 3 years interval if the patient having some polyps, more than 3 polyps. And even after the 2 round baseline colonoscopy, LST non-granular is very important to don't miss this flat lesion. And so this study still continued. We followed this all the patient, and so this is a national polyp results. They reported reduction of the colorectal cancer incidence after removal of all the polyps. They showed 76 to 90% reduction after polyp removal. So in Japan polyp study, we also we followed the patient every 3 years and still ongoing. And we evaluate 2015 data to evaluate effectiveness of the colorectal cancer risk. So only 4 invasive cancer identified this cohort study. One is cecum, one is lectin, and ascending column and sigmoid column, T1, T2, T3, T1 stage cancer. I show you the picture. As you see, these 4 lesions, except this one, type 2 advanced cancer. The other is almost flat. You know, this is cecum 2C-like depth type lesion embedded to submucosa. The other is a 2A 2C type embedded to the muscular submucosa T2 stage cancer, but very similar to 2A 2C type. And this is 2A 2C type, so-called LST non-gram type. This lesion embedded to submucosa. Only 4 invasive cancer identified. And so we evaluate this incidence using a population-based Osaka Cancer Registry. So Osaka City is 8 million population, and so very strict covered using cancer registry. We compared to the this Osaka Cancer Registry, observed the expected ratio of the colorectal cancer. So the in Japan polyp study in male, 82% reduction can be seen, and so in the female, there's no patient cancer patient in the female. So a total 86% reduction can be seen in our prospective study. And also, this is a metaclonus advanced neoplasia detected, this cohort study. So the metaclonus neoplasia can be seen on the right side, 57% located right side, and left is 30, left means 13. And also the morphology, it's also same. A total of 77 metaclonus neoplasm can be detected, but 70% is 60% is classified non-polypoid, and in the non-polypoid, 40% is LST non-gram. And so long years follow-up, but unfortunately, serrated lesion with advanced neoplasia future is only 1 per 77, so 1.3%. So I think still the importance of the identification of the flat means LST non-gram type. So Professor Huston, he reported that high performance AI system in recognition flat lesion lies a big hope to minimizing the human performance related liability. But many papers published regarding to the AI for the polyp detection, but still few. It's a controversial for the flat or LST non-gram type detection. So we need a much more further study to improve artificial intelligence detection for the flat lesion. So in my conclusion, recent our study demonstrated reduction of primary length lesion, including flat lesion, by high resolution chroma endoscopy with image enhanced endoscopy effectively reduce colorectal cancer. So I think flat lesion, especially non-granular type neoplasm, is very important. Don't miss. And high performance artificial intelligence system recognition flat and LST non-gram type lies a big hope to minimize colorectal cancer. Thank you very much.
Thank you, Professor Sano. Are there any questions? We have time for. I have a question perhaps for both Dr. Sano and the rest of the panel. As pathologists, with the advent of ESD and EMR, we're increasingly being asked to comment on margins. And in flat lesions, I was wondering, what is the significance to you of the dysplasia at radial margins? Does it influence your management? Does it influence your surveillance interval?
So the dysplasia?
Yes, dysplasia at radial margins.
Dysplasia, you mean the high-grade dysplasia or low-grade dysplasia?
Well, either, really, yes. Would it change your surveillance interval?
Yes. Now we analyze, but I don't have now. But so if the patient showing high-grade dysplasia, so they have some higher instance of the metaclonus advanced neoplasia. Okay. Yes, compared than with low-grade dysplasia.
Right.
Yeah.
There's
pathologist reports involvement of the lateral margins. That's a patient that we would bring back a lot earlier, regardless of whether it's low or high grade. If you've got a positive margin, there's an increased likelihood that you've left behind residual dysplasia, in particular if it's an advanced lesion. Even if it's only low grade at the margin, it is an advanced lesion, and that has been left behind potentially.
It's good to know we're still useful. It's sometimes hard for us to comment on the radial margins if there's diathermy change or if it's a piecemeal resection. So but it's still worth us trying.
Yeah. So in Japan, the move is more towards removing these lesions en bloc. So they do quite a bit of ESDs. Yeah. In contrast to I guess our population, where a piecemeal strategy is still the main strategy to remove these polyps.
Yeah. Thank you. Any other questions? We'll all invite you to join us in the foyer for a coffee and tea. Thank you.
Well done.
Great session.
I'll just put it up there. Yeah, it's just, I think I'm next. So it's there. Yeah, yeah. Do you? Yeah, move this through everybody. Is that all right? That's it? Yeah. Okay, do you want the slideshow or like that?
No, that's good.
No?
I know what's coming next.
Okay. Or you want the other one?
No, this is good.
Okay,
Good.
okay.
Yeah.
Okay,
Yeah,
that's
so
good.
sorry
No,
about
that's all right. It's okay. All right. We all right. We all good. No issues. We're doing all right for time, and yeah. We just move things a little bit. Scott, is this okay? That's all right. I just worried that it's not.
Hey, mate. How are you? Yep. I'll catch up with you soon. Sorry, say that again?
I've got an additional program. So I think Rubial, Sano, they've all been. Yeah.
And you're going to do that? Yeah, I can do that. Yeah, okay. Yeah, perfect. Yeah. Yeah. All right. Well, and then you can. I've already got a couple of questions from both.
I think if people have questions, just ask them to shout it out.
I thought the same thing.
Yeah.
It's not a big room.
Good.
I asked him to turn that one down. Good acoustics. Yeah. Good acoustics there, so that's very nice. You can't shout that enough.
I think we won't use just use the mics for the chairs.
Yeah.
But
It
if
just
people
means
want.
it doesn't get in the stream.
Oh, in the stream.
You have to then put the question in the answer.
Okay.
So,
Okay.
yeah.
So I think we'll let someone ask the question, and then maybe the chairs.
Yeah.
That's fine. It's not a big task. We just get that.
GPT testing in that algorithm, you know, particularly that low group, restrict 1 or 2, because that's never quite clear to me on the diagrams as well.
I think it's just presumed that that will be the default, that you go back to
Programs.
Yep. Second year.
Okay. Yeah.
And you know, the NIH data, or the group that produces the reports on the program, if you look at their data, it suggests that if you have a negative quick lock-off blunt test, your chance of developing colorectal cancer within the next 2 years is about 1 in 2,000.
Right.
So it's, if you think about it, it's probably as good as colonoscopy in low risk people.
Our problem is more, you know, GPs doing FABTs sort of more than they should, and then we get the referrals, and it's like, yeah, this patient had colonoscopy 3 years ago. Yeah. For some reason, someone did an FABT, and you know, what do I do now? It's positive. Or they did an 83-year-old in a nursing home. Why did you do it? Yes. Yeah. So, do you have? You know, I mean, I often feel that I'm under pressure to do a scope anyway, but is that
legally?
Yeah. Yeah, all right. And I think it would be really good to put that in a bit more clearly into the guidelines, especially for GPs. I reckon, I don't know, I mean, I think that, you know, there's some very good ones out there, but there are some that just do a lot of, yeah.
Well, they're just, they're catering to very well.
Yeah.
And they're probably, you know, like all of us, covering their own up.
Wanting to do the right thing.
Yeah, well, you know, the problem is that this concept of wanting to do the right thing by an individual, by you know, and the typical patient of a GP like that is one who says she's supposed to suffer.
Yes.
Cares so much about it.
Yes.
And then that panders to a worried world-class patient.
Yeah.
But the problem is that that's an individual thing, and there can be, as you know, there can be negative consequences of doing far too many colonoscopies.
Anxiety of
but from a population point of view, I mean, I don't know what the right level of involvement is, but I did a calculation writing something one time that at the current level of a million scopes a year, roughly the estimate, everybody over the age of 50 in Australia could already have a scope every 8 years anyway. It's all comers, just we do enough.
No, just do one every 8 years.
Do one every 8 years.
Yeah.
Now,
that's sort of lean thinking type approach, you know, just make it simple. Yeah.
Well, you know, the problem is, and you know, I also have discussions with people who come back and say, you know, they want another one when 75 because mum had a bowel cancer when she was, you know, whatever age.
Yes.
And you think, well, you know, you've had 3. See, this is the other thing. I'm completely like myself. I don't trust anybody else's colonoscopy.
Right.
And I think that is think you'll
Yes,
like too.
that's a
So
lot of
you
it as
must
well.
be,
Yes.
you must find this all the time. That
Yeah, someone else.
that you get the 83-year-old with the positive blood test who's had a negative colonoscopy done by someone you don't even know. And the thing is, it could be done by one of your closest colleagues. You wouldn't know whether they're any good at colonoscopy or not. And so, you know, I have a lower threshold when it's that sort of scenario because I'm up myself.
Interesting. Yeah.
But it's,
Anyway, okay. Yeah.
Yeah,
If you ever doing the guidelines
yeah,
again,
so they're not going to use the same thing.
Right.
And then I said, yeah, the chair can lead it. But it doesn't mean that we have to. We can completely gap my loads. Never double one. It was louder. Do you know what was glitching? Just a frequency. Just a frequency. 112, 1112. Yeah, the first person who went like that and put it down here. It was down there, wasn't it? Or was that one that I saw? I thought they moved it.
Yeah.
But hopefully they can see the mic on it. Yeah, when I went into this, so you go into this, you go to this, right? This is your thing.
Okay.
And then you got this chairman override, which allows me to turn on, but they don't turn on. But then random ones will. You watch. No, nothing will. It's a heap of junk. There you go. So one turned on. That turned on. No, that one didn't. So the whole thing's just useless. Yeah, Raj just said, so none of those mics are working. And I said, even if they were, I can't get them.
Yeah.
If they spoke into the PA, we might get it back into there. But only random ones. So if they push the button in front of them, yeah, they don't work. Only random ones turn on. So those two don't. Yeah, that one does. But then you talk into it, there's no level in them anyway. It's just EQ'd with an image of its life. So 1, 1, 1, 1, 1. Doesn't even add anything. 1, 1. So I've got this volume here. I'd say that's all on the out. 1, 1, 1, 1, 1. So it's useless. It would be great in a stream probably, but completely useless for a here. And there's no volume on those either, so I can't do anything with that. What do you do? Just like everything else, they try to do it so that they never get out and do anything. Oh, yeah.
and then you can alternate from there.
The questions again, people shout out if they want to.
Okay. Wait, do you want to say that or do you want me to say that?
You can say that. I'll just introduce you guys.
I'm actually looking forward to this talks. Oh no, I looked at it. Yeah, pretty practical stuff. Yeah, unfortunately I can't stay for this, but I reckon there's a bit of stuff in there that I wouldn't mind, particularly this one.
Yeah, I wonder who the panel is.
Although I do get to listen to Raj and Ruskovic go on.
Welcome. Yeah, right. Welcome back. Brian, is that? Yeah. Welcome back, everyone. So what we'll do is we'll crack on. We probably about 15-20 minutes late, but that's what happens, I guess, with workshops such as this. We'll just cut short the lunch break. I'd like to introduce the next panel of chairs. So we have with us from my left, Dr. Andrew Luck, who's a senior consultant colorectal surgeon in Nagaland and in private practice. And then we have Associate Professor Tariq Samo, who's a colorectal surgeon as well. And Tariq works at the Royal Adelaide Hospital and also in private practice. And then the rose among the thorns, I guess, Arvind Rajagopalan, who's a gastroenterologist. He works in Nagaland. So I'll leave it to the chairs to introduce the next speaker. Thank you.
Thanks, Raj. I suspect most of the speakers have been introduced already, so I'll go a little bit off-piste when I introduce Cameron for this one. I've had the pleasure of working with Cameron on the National Endoscopy Training Initiative and the Train the Trainer courses for the last 15 years or so, and I think he's the perfect person to talk to you about this topic. One of the things that I've noticed in that time with Cameron is that he spends a lot of time thinking both about colonoscopy technique, but also how to deconstruct that technique so that you can then teach it to the next generation. So anyone in the room who's learning colonoscopy and anyone who wants to get better, this is a vital talk for you. Cameron.
Thanks, Andrew. That's very kind of you. So I'll crack on. I just predicate it by saying why am I giving this talk? Because I'm not the best colonoscopist in the room, but I guaranteed that I have talked with at least 10 times as many fellow colonoscopists. I've shot the breeze, chewed the fat, whatever you want to say, with a vast number of colonoscopists, and I've picked up tips and tricks from all of them. So let's go. Andrew would know that I would start with this. My number one, and these are sort of high-level tips. I'm not going to tell you how to get around the rectosigmoid or how to negotiate the hepatic flexure. So my number one tip would be to work on your conscious competence, because all 250 consultants who've done the Train the Trainer, their biggest barrier in terms of being a better trainer is that they don't know what they're doing. They're competent, but they don't know how they do it. And you get that by actively reflecting about the things in your own scopes that work and that don't work, and asking yourself why they did or why they didn't. And to do that, you've got to have a way of discussing that in your own mind that relies on the 12 things that you can legally do with a colonoscope, and I'll tell you what they are later on, if you want. Number two, I would encourage you to consider using water-assisted insertion for a variety of reasons. So this is a Kagaka colon model, and this is what it looks if you shove the scope in the artificial anus and inflate. You can see the dreadful obstacle that the sigmoid becomes. If you avoid overinsufflation with CO2, it makes it a little easier, but there's still a bump in the sigmoid. And if you avoid overinsufflation and fill it with water, that then becomes pretty much a straight shot. Now, it doesn't always work as simply as that, but I would, if you're not using water assisted, I'd consider finding someone who can teach you how to do it. It's not hard. Number 3, I would urge you, particularly the non-surgeons, to understand the way that a standard sigmoid alpha loop forms. It's not rocket science. You do need to know the anatomy of the mesosigmoid. And in essence, this comes back to something that David Hewitt taught me many years ago. Between the rectum and the splenic flexure, you want to aim to use net clockwise torque. Now, in a series of quick slides where it looks like I'm doing horrible things to Sam O'Connor, I'll explain what I mean. So this is me, Sam, looking terrified about what I'm about to do to him. This is my starting position, and I can explain why I do that if you want, but I won't. That's how I start an insertion. So this is the neutral C-loop. If I apply anti-clockwise torque, you can see, concentrate on the bit of the scope between Sam's hand and my hand. So if I start applying anti-clockwise torque, you can see what starts to happen. And I keep applying anti-clockwise torque and see what's happened there. And now I have 2 loops. I have a standard alpha sigmoid loop inside the patient, and I've got a mess on the bed outside the patient. Now, to reduce that, you all know how to do that. I'm not going to teach you to suck eggs. But by applying clockwise torque and withdrawing, I'm just reversing the whole process until it's back to neutral, which tells you a lot about how a standard alpha sigmoid loop, not a reverse alpha, that's a different kettle of fish, but that's how a sigmoid loop, and you can avoid that pretty much. I used to think people who talked about avoiding loops were full of themselves and talking rubbish, but it works. And water-assisted helps. Number 4, be aware of obstacles to successful torque application. Those of you who teach trainees must get frustrated when you ask them to get rid of a loop by applying torque. You watch their hand, and number 1, they only twist it once, which is sort of maximal 120 degrees of torque, so they've got to re-grip the scope. But there are things that we all do in every scope that can, without our being aware of it, stop us applying torque successfully. So you can't apply clockwise torque like this. Now, I'm sorry, it's a bit of a rubbish slide, but the horizontal bit of the scope disappearing into the double towel anus is actually on top. The horizontal bit's behind the bit on top. Now, if I want to apply clockwise torque here, it's the loop on the bed that stops me. So I can't apply clockwise torque there unless I lift my right hand up, clear that loop, and if I think it's important to keep applying clockwise and to make that worse, I can apply more clockwise torque if I lift that off the bed. Similarly, my forearm is stopping me applying clockwise torque here, and this is the worst of all for people who don't keep the scope on the bed, and there's nothing wrong with, Hewitt doesn't keep the scope on the bed, but there's just no way you can apply clockwise or anti-clockwise torque. All you're going to do is injure your kneecaps. Number 5. Understand what you're trying to get your assistant to achieve when you ask for abdominal pressure. I'd love $1 for every time I've been in a scope suite where someone's asked for sigmoid pressure. And I can count on one hand the time that applying pressure over the sigmoid has helped me. So, for the trainees in the room, if there are any, this is what I think sigmoid pressure looks like. You put your hand out in the right paraumbilicus and you push down towards the left hip, or that's what you explain to your assistant to do. And that keeps the sigmoid colon over in the left abdomen. If that doesn't work, you keep it in the one plane by putting your forearm down across the lower abdomen. And the only other predictable pressure that's successful is preventing the transverse colon sag by putting your hand suprapubically and encouraging the transverse to stay up above your hand. Now, very quickly, insertion point number 6 is suck. The number of times when you're proximal to the splenic flexure that you complete the colon over the scope just by sucking without doing anything else is remarkable, and it's the magic way to get from the distal ascending colon to the base of the cecum. If you haven't tried it, do it. Now, withdrawal, which is I should have started with because this is the more important part of colonoscopy. My number 1 tip is to imagine that the patient on the other end of your scope is your significant other, presuming, of course, that you're fond of them. Now, these aren't the latest research data, But this is ADR. So you've got to be 25, have a 25% ADR to qualify, and there are people out at the other end who are cheating. The median is the dotted line. Now, the research data also show us that cecal intubation is consistently high. So why are the people who are finding adenomas in 27, 28% of their patients, what are they doing differently? They're examining the same amount of colon, because their cecal intubation rate's pretty similar, to the people who are up in the sort of the love heart range. So what are they doing differently? And I would argue that they're just not withdrawing properly or carefully enough. So important withdrawal tip number 2, use the Doug Rex, ancient, this was him and one of his colleagues, and he got a third colleague to look at what they were doing. So the higher ADR colonoscopist inspected the proximal surfaces of folds and flexures in the IC valve. They washed and suctioned luminal residue. They didn't, they didn't, excuse my French, they didn't scope with bird shit on the windscreen. They adequately distended the lumen, which I think is most challenging around the splenic flexure. And they spent an adequate time viewing. Now, this was before he came up with withdrawal time targets, which he's now abandoned. Beware of the hotspots for missed lesions and have a strategy to reduce the likelihood of missing things at each site. Strangely, in view of the next slide I'll show you, my pet fear is just proximal to the splenic flexure. But the straight arrows here are what's in the literature, the flexures, the bit between the appendix orifice and the ICV, the medial wall of the ascending colon. How do you know where that is? In left lateral, that's where the muck sits. And on the proximal side of the folds or the valves of Houston. Personally, I think the other wall of the cecum can be very challenging, particularly if there's a pronounced ceco-ascending fold. That bit at the middle of the transverse where there is almost a kinking like a sock, that can be difficult, and the distal rectum. So this is a recent Danish study looking at the site of so-called interval cancers, which more correctly are called post-colonoscopy colorectal cancers. And the thrust of this was have a good look at the rectum. We all know about cecum and ascending colon and double examination. It's double inspection, retroflexing if you can. And cecum, 15% of those interval cancers. Ascending colon, 15%, but rectum, almost a quarter. Number 4, and this is a tip for trainees, when you're re-inspecting an area, and I've given up writing that I've double inspected this bit and that bit and the other bit, I just say I've double examined everything because I never pull the scope straight out. I always move it backwards and forwards. But when you're examining an area, re-examining an area, concentrate on the part of the circumference that was more difficult to see. Concentrate on that bit only. And I think the second last tip, because I cheated and snuck a couple of quickies in, take your time but use it well, because overall colonoscopy performance is quality times quantity. It's no point sitting in the rectum for 5 minutes to get your withdrawal time up to 10 minutes. You use that 10 minutes or whatever however much time you need to inspect as much of the colonic mucosa as humanly possible, as well as possible, is what your withdrawal time should be. And this is just the point I made earlier, double inspect the right colon. Although the studies suggest that 2 forward views in withdrawal are as good, anybody who retroflexes routinely knows with dread the size of adenoma that can be missed just proximal to the hepatic flexure in that very, very tight angle, and even in the fold above the ICV. So the yield of this is highest in older males with bleeding indication for the scope, and when you've found polyps on that first forward view look. This is the last slide. This is the only one that is a site-specific tip. When you see the triangular haustra of the transverse, when you've got your way through the worst bit of the colon and you see the triangular folds, just stop, pull the scope out a bit with the angulated tip so that you're dragging the flexure down a little bit, deangulate and sacrifice that perfect lumen-centered view lube the scope at the anus before you start again, and then insert really slowly so that you're sliding something across a polished tabletop. You're much less likely to have friction in the sigmoid, reform the loop that you've been battling. So thank you for your, I think I've stuck to 10 minutes. Thanks.
Thanks, Cameron. Question, Spiro.
Thanks, Cameron, for those tips. Just a question, rolling a patient on withdrawal. I mean, that's something that I was always taught, and there's certainly enough evidence out there to suggest that you will increase your pickup. But I see increasingly that people don't do that routinely. What's your view on that? And
just before you answer, Cameron, for the tape, I need to repeat the question. So the question is...
Spiro asked, what about rolling the patient? Because there is good evidence that it improves pickup rates. And it's very commonly done in the UK. I think our problem here is that we're addicted to propofol and we're fat. So to get a patient, it's the truth. You know, if you're in left lateral, to convince your anaesthetist and your assistants to roll them 3 times, because you've got to roll them into right lateral and then get them back onto their back. It's just, it works, but it's just logistically very challenging.
I must admit, you know, cases referred to me for resection of large laterally splitting polyps, and I will go all the way through to cecum knowing the right area, and I just don't see it. And I'll roll the patient, and then all of a sudden this polyp disappears. So I tell my anaesthetists that's just what they have to do, and wake the patient up.
Yeah.
If needs be.
Yeah. Well, John Anderson, when he demonstrates in sedated patients, he just gets he doesn't get his assistants to do anything. He gets them to lift their knee, roll onto their back, let him put the scope between their legs, etc. Yeah.
I think that also introduces another comment on that, in that there's actually no need for the patient to be anaesthetised on withdrawal. So you can allow them to quietly wake up. Yeah. I've got a Dorothy Dixer for you, Cameron, because I know we've talked about this. When should we be removing the pressure? If it's been placed?
As soon as it's achieved what you want to do. So the worst thing in the world is to look up and have your registrar or your nurse blue-faced putting their pressure on and being unaware of how long they've been doing it. So generally it's not very long. The only exception to that would be in a very difficult long left colon, where you need to get a good look at the cecum, and the only way you can do that is to keep the pressure on. But even then, it's only a couple of minutes.
Thank you.
A question. Can you give us some tips on how do you get into the terminal ileum?
Well, the best tip that I've picked up in the last 12 months, I mean, so firstly, return your scope to the neutral position. And with modern scopes, once it's in that question mark configuration, you can just rotate it with impunity. I like getting the ICV into the 9 o'clock position. I then anti-clockwise, proximal to it, so down on the cecal side. And when I drag back, I do it very slowly. And as soon as I see villi, I put my foot on the water pedal. I let it slip into TI a couple of millimetres, and then I head north, so clockwise. That's where the next bit of the TI always is. The tip that I've picked up in the last 12 months is, if it's really difficult, because there's also the thing about retroflex in cecum, and then you can see it on FAS. But the tip I've picked up is something from one of Doug Rex's things on ASGE. Sit in the mid-ascending and deflate. Because if your ascending is super inflated, that pushes the ICV into an unfavourable position. And it's remarkable the number of times. So you've descended, you've looked at cecum, you're finished with cecum, but you haven't got into TI yet. And it's remarkable the number of the times that the valve will then ask for it.
Thanks, Cameron. One last question.
I'm just wondering, would you suggest and advocate that we use Scope Guide for teaching and for...
I think it's incredibly useful.
So the question was, should we be using
should we be using Scope Guide for... Well, I know that one of the best colonoscopists in Australia, Gregor Brown, uses it for every case in private and public, and we use it in all the trainers. It's an incredibly valuable tool, and it's a huge aid to conscious competence building, because you can see what's going on.
Andrew, sorry, can I just... what about using a withdrawal
cap, you know,
So the question is, what about using a withdrawal cap? I did a talk at AGW last year or the year before looking at caps, cuffs, rings, AI. And my problem with all of those things is, and it's coming out with the AI literature now, it's not that impressive. The problem is that all of those things, even in the best studies, improve ADR by maybe 5 to 10%, which, if you remember my research graph, gets the people who are really underperforming just up to below median still. It's not enough. I think careful technique. And the problem with AI, I think, is that unless you point your scope with good technique at the polyp, AI can't see around corners.
Thanks, Cameron. I think we might move on to the next speaker. Thanks, Tarek.
Thank you. Our next speaker, again, needs no introduction. He's already given us an excellent talk this morning about the Japan polyp study. So please welcome back to the podium Professor Yasushi Sano from Kansai Medical University in Osaka. He will be talking to us today about medical imaging for polyps, all you need to know. Thank you, Professor Sano.
Yes. So thank you very much, Chairman. So I would like to introduce mucosal imaging for colorectal polyps briefly. So this is the channel. So during a cell colonoscopy, if you identified polyps, so I think 95% is differentiation diagnosis between the non-neoplasia or neoplasia, including a cellular lesion. And the other side is less than 5% is estimation of the depth of the invasion. It's not so quite common. And so in Japan, this is a preparation for the appropriate diagnosis. So water jet function is definitely very important. And remove the mucus on the surface. But strong setting for the water jet may cause bleeding. So very softly remove the mucus. And attachment, I don't use oftenly, but attachment cap usually keeps appropriate distance from the polyps. And when I use a soft cap, prevent the bleeding. And some doctors using a black reducing reflections. And chromendoscopy, usually we use angiocolumn dye, 0.2%. And so it highlights a pit pattern. And sometimes we use a crystal violet to obtain the more detailed observation. And classification for the characterized polyps. This is organized 2008 maybe. So this is international group to develop this NBI classification. So it's Professor Tanaka, Lex, and Sanders, and Doi, and Ponshan, and me. And of course, David Hewitt is one of the members. And so we discussed for maybe 5 years, and we reached nice classification. The name, I named the nice classification in 2011 sightseeing board in the Thames River in London. Yes. So this is an international nice classification. Divided into 3 types. Type 1 is it's correlated with serrated lesion, and the type 2 is correlated regular basalt and regular surface. So it's correlated with adenoma. And the type 3 is having destroyed area, basals and surface are also destroyed. This is classified type 3. It's very working very well. But in Japan, we need a more precise classification because the NICE is very simple, but rate of high confidence prediction is still low, and type 2, NICE 2, include the various region so adenoma, intramucosal cancer, and some submucosal invasive cancer. And in Japan, so indication for ESD is so suspicious of the cancerous lesion more than 2 centimeters as an indication for ESD in Japan. So that we need a more precise classification. So that NICE-2 divided into 2 types. I think this scheme is very similar to Sano classification, original Sano classification. But anyway, type NICE-2 divided into 2 types. 2A showing a regular surface and regular bezels on the surface. Type 1 is almost same as NICE-1. Type 3 almost same as NICE-2. And type 2B showing irregular and obscure surface pattern, and most likely and bezels is variable caliber and irregular distribution. And type 2B correlate with high-grade dysplasia intramucosal cancer. So nowadays, a genetic classification needs a magnification endoscopy. But this is dual focus function using the X1 system. This is 1,500 XZ scope. And as you see close the lesion, you can identify very easily the surface pattern and bezel feature as well. And this digital magnification, you can obtain the very clear surface. So that I think there is not necessary to use magnifying endoscopy. I think as a conventional with a dual function colonoscopy is enough for genetic classification. So I show you. So this is a hyperplastic because no bezel on the surface, and dot-like surface structure can be seen. This is endoscopy. After staining using a methylene blue, you can see the star-like pits on the surface. And this is endoscopy. Endoscopy maximum 500-fold magnification can be, and close to the lesion. I'm sorry. Video. I'm sorry. There is no endoscopy finding. So in this video, okay. This is next case. Switch to NBI. You can see the brownish bezels on the surface, and you can see the branching tubular-like surface pattern. So that this is adenoma, genet type 2A. And this is endoscopy. I show you some very interesting findings. So close and touch, so you can see the cells, living cell. Very easy to obtain the findings. The nuclei, you show the stratification, so that this diagnosed as adenoma, yes, in vivo. And so type 2B, 2B is showing variable,
which means that the caliber of the vessels are variable and their distribution is not regular. In contrast to type 2A. The vessal feature of JNet type 2B is the irregularity.
Okay. Listen.
In contrast to type 2A, the tubular structure on the surface becomes obscure or irregular. The most likely histology of these polyps is high-grade intramucosal.
He's an Australian.
Or shallow invasive cancer. JNet type 2B findings may be observable in deep submucosal invasive cancers. Additional magnifying chromoendoscopy is recommended to determine the appropriate treatment strategy of JNet type 2B lesions. Here we present a Cecile lesion 8 millimeters in diameter with a depressed area at the center. While elevated areas at the edge show regular vessel and surface patterns, the depressed area at the center has variable caliber, irregular distribution of vessels, and irregular surface structure. So this polyp is classified as JNET type 2B. By staining with crystal violet, type 5I pit patterns in the depressed area and type 3L pit patterns in the elevated area are observable. This sessile lesion was removed by EMR. The histopathological views show well-differentiated adenocarcinoma without any submucosal invasion.
Okay, so so this e-learning video you can watch in YouTube. Please search JNET classification. And I show you finally so JNET type 3 or nice 3 lesion. This is a 2A 2C like features, and there is no dystaloid. There is a dystaloid surface features, and so irregular surface bezel pattern can be seen on the surface in the narrowband imaging. So this is classified as type 3, nice 3, or JNET type 3. So this is a crystal violet so staining. So after staining, the lesion showing so irregular pits, kudos type 5I pits, and the area, demarcated area showing a type 5 pits is more than 6 mm in diameter. So that we diagnose that this is invasive cancer. This is a key point. This is an index for SM 1000 microinvasion. You know, if you identify the suspicious of the submucosal invasive cancer, you observe the this area showing irregular pits, and precise observation, and this diameter is very important. If the lesion flat or Japless type lesion, it means 2C or 2A like or LSD-NG. If the irregular surface, the demarcated area, more than 3 mm in size, it's correlated with 1000 micron. And protruding lesion, if it means 1S or LSD-G or LSD mix, the diameter of the irregular pits more than 6 mm in size correlate with 1000 micron. This is very important tips. And so we sent to the surgical operation. This is invasive cancer, SM2 LY positive and lymph node positive. So in summary, this is a scheme for using JNET classification. I think JNET type 1 follow-up or more than 6 mm in size showing JNET 1 usually we remove. And 2A of course called snare resection or hot snare resection. And type 2B lesion, we usually in Japan we add some chroma endoscopy and estimate more precise diagnosis. And we perform EMR or suspicious cancerous lesion more than 2 centimeters. We usually perform the ESD. Nice 3, JNET 3 lesion, so we send to the surgical resection. If the lesion less than 1 centimeters, we try to remove endoscopically usually. And this scheme, you can download. Please access the AMBIC homepage. You can search internet AMBIC. So you can download this poster freely. So put this poster on your unit of the endoscopy. So thank you very much for your kindness.
Thank you, Professor Sano. I think we have time for 1 or 2 questions. I might kick it off. surgeons tend to be simple creatures. So, and I'll tell you honestly that many of us don't classify polyps because our classification system is either it's removable or it's not removable. So it's a 1 and 0. If it's removable, we remove it and we get the pathological result. If it's not removable, we think it's a cancer and we biopsy it. So my question is, what is the additional benefit of endoscopic classification above the binary removable, not removable classification?
Yes, it's benefit is reduce more benefit.
So maybe I can just answer to that. I know what Yasushi is thinking. The question would be with regards to the removable and how do you remove it, right? So as you saw in that last schema which Yasushi put up, if the polyp is a tubular adenoma or let's say a sessile serrated lesion, there is a possibility that one can remove it in a piecemeal fashion. However, if there's risk of a submucosal invasion, then it's necessary to remove those lesions in an en bloc fashion as best as we can. In Japan, of course, there's a lot of ESDs going on here in Japan, but the key component to that is to basically know when a piecemeal resection can be performed and when an en bloc resection should be performed. And the other thing is, when we move further down the trajectory, there are lesions where we should not remove at all. So there's sometimes this contention whether we should take it off en bloc or whether this is a deeply invasive cancer and we should just biopsy it. So the classification basically allows us to plan therapy.
Okay, thank you for that. William?
I'm gonna ask a question for you, Tariq. So I mean, I'm curious to understand if you judge that a polyp is unresectable, is that based on the fact that you've identified that endoscopically as being invasive because of the signs that Professor Sano has told us? You know, those abnormal vessels because of this Paris 2C that you think it's invasive, or is it because of some other criteria that surgeons have and we don't?
I'm reluctant to speak on behalf of the whole surgical community, but from my point of view, if the polyp is too large for me to remove, I might refer it to Scott or Raj. If I think it's resectable but requires specific expertise. If it's ulcerated, it doesn't lift, then I think that person, depending on their age, may be best served with upfront surgery, and I would biopsy the ulcer. So I think most of us can determine whether something is removable or not without specific chromoendoscopy or other NBI imaging techniques based on the characteristics macroscopically of the polyp.
That's an important point because that's what we have to teach our trainees to understand and master. Thank you.
Yes, thank you.
So yes, classification, I think, definitely needed in the future in Australia. So this is a very common classification in Japan now. But 10 years ago, I think maybe a few people used. But now, almost all use because we performed the ESD EMR called pulpectomy or follow-up and sessile-serrated lesion diagnosis. Everybody knows. So
Yasushi, just one more question. Can we use the JNET classification with the dual focus scopes, which are probably 80 or 90% available in the country in Australia?
Yeah, it's okay. I think a dual focus function can be applied as a JNET classification. Yes.
Okay, thank you very much. I think we're up to time. Thank you very much, Professor Sano.
Thanks, everyone. Was that on? Yep. So it's now a pleasure to introduce Associate Professor Spiro Raftopoulos. He's a staff specialist at Sir Charles Gardner Hospital in Perth with a clinical and research interest in all aspects of diagnostic and interventional endoscopy. His main focus has been on management of both pre-malignant and early malignant cancers of both the upper and lower gastrointestinal tract, and in that role he's involved in several multi-centre studies and serves on a number of advisory committees, including the Cancer Council of Australia and the Royal Australian College of Pathologists. He's not just an esteemed clinician, but also has a long history of computing experience and has designed, implemented, and presently managing over 20 clinical and research databases in local and international centres. So very fortunate to have him on board today. And the first part of his discussion in this session will be the hot tips for a cold snare. Thank you, Spiro.
Thank you very much for the kind introduction, and once again, thank you, Raj, and the organisers for the kind offer to present at this wonderful symposium. So I think Professor Sano's talk is very fitting to come before my talk, because there are certain aspects of my talk that are very strongly contingent on our ability to look at polyps and determine whether there's a risk of malignancy or not. So I'm going to be really concentrating on three key areas: device selection, what I believe is the ideal technique, and then briefly talk about adjuncts to resection, in particular in the context of cold snaring. So you'll see a few of these images. These have all been generated by AI, I'll declare. So I put in cold snare revolution with a physician stint, and this is what we came up with. And there certainly has been a cold snare revolution in probably in the recent 10 years. And this really initially started with small diminutive polyps, so under 10 millimeters in size, with now numerous studies showing that these polyps can be quite safely and effectively removed through a cold snare technique comparable to hot snaring in terms of efficacy, but obviously with a much lower risk of post-polypectomy bleeding and perforation. And this is also even in the presence of antiplatelet and anticoagulation therapy. So I think most people would agree that this is standard management. But this then progressed to sessile serrated lesions, which, due to their very low and thin mucosal profile, they are ideal targets for cold snare polypectomy. And this is irrespective, really, of the size, with numerous studies now showing that it's comparable to hot EMR, with long-term recurrence rates, around the 1% to 2%. But there has, however, been a significant reduction in post-polypectomy bleeding, in the region of 10% in the right colon, down to virtually not seen nowadays. And so, outside of dysplastic polyps or serrated lesions with concerning features for early cancer, these polyps are universally now removed through a cold snare technique. Now, for my Japanese colleagues, please block your eyes and close your ears. Okay, this is somewhat of a controversial area. And, what about adenomas? So Bronte already spoke about adenomas in the duodenum, large adenomas in the duodenum, which are quite safely and effectively resected through a cold snare technique. But what about adenomas in the colon? Obviously, these have traditionally been removed using either diathermy with en-bloc EMR resection or piecemeal resection, and of course in Japanese Endoscopic Society through en-bloc ESD resection. But because of their superior safety profile, cold snare polypectomy is being increasingly used even in large adenomatous polyps. And in my personal practice would probably represent 95% of the cases of modality for resection, even with large adenomas, some involving almost the entire cecal pole. Now, I will say, though, that the evidence in this area is not as mature as the evidence for cold snaring in non-adenomatous lesions. But I believe probably in time this may become a standard in certainly highly selected polyps. It is, however, very important to realize that when doing a cold snare technique and removal technique of resection is really critical to avoid residual rates, and of course to make sure that this technique is not applied to malignant or suspected malignant lesions. So in 2020, through Alan Moss's group, we published a retrospective review of outcomes of cold snare polypectomy in EMR. And these are large sessile lesions, more than 20 millimeters in size. And you can see a significant proportion of these lesions were up to 3 centimeters in size, predominantly in the right colon where there's a significant appeal for cold snaring. Only 32% of this cohort were in fact adenomas, but if we look at the residual rates at first and second follow-up, the overall cohort was quite low, around the 3 to 5% mark, and if we just drill that down to adenomas, 7.7% at the first follow-up and 3.3% at the second, and all of these cases of follow-up were easily managed with a combination of either cold snaring, cast, or hot avulsion. If we looked at predictors of residual, it appeared that less experienced endoscopists had a higher rate and possibly related to technique, and cecal location which may just reflect access or concern in that area. But more importantly, adverse events were very low. Immediate bleeding was low and easily managed. There were a small number of self-limiting post-polypectomy bleeds that did not require intervention, and there was one patient in our cohort that had some abdominal pain with observation. But we went on to look at this in more of a prospective fashion, again with Alan Moss's group, and we targeted polyps between the 10 to 19 millimeter mark, of which almost 70% of these were in fact adenomas. When these polyps were resected using a cold snare technique, either with injection and resection or just resection at the discretion of the endoscopist, we then did biopsies around the margin of the lesion as well as the center of the lesion to look for any evidence of incomplete resection, which would prompt an earlier return. And then all these patients would have had a follow-up at the 12-month mark. And you can see that the incomplete resection rates were, again, quite low at 2% with 1.7% recurrence. Interestingly, half of the incomplete resection, when we followed them up, they didn't have residual, so there was a feeling as to whether this was possibly contamination in the channel. Minor adverse events were minimal, and there were no serious complications. So watch the space, I think. Now, as a registrar, I was probably taught very poorly about snare selection, and this is even more relevant when we're talking about cold snaring. And it's kind of like Tiger Woods saying to his caddy, well, whatever the usual is, and that's what I used to say as a trainee. But obviously, it's not whatever the usual is in your department. There are specific snares that are ideal for cold snaring. And so, these are the characteristics that really make an ideal cold snaring. So stiff sheath, because that's what's required to cut through that tissue. Small diameter loop wire to ensure you have good resistance at that wire point, and a small to medium loop diameter. Anything larger than 15 mil increases your likelihood of stalling the snare when closing. And for those of you who want to look at a technical paper, this paper looks at various snares using cellulose rods. They really showed that regardless of the shape, the orientation of the configuration of the wires really didn't make a difference. The main issue was the loop wire diameter, and pretty much this is consistent in all the cold snares that we currently have available in Australia. So for diminutive polyps, less than 10 mil probably doesn't make a difference, and Gregor Brown's group showed this, where they randomized to dedicated versus non-dedicated snare, and they found that there probably wasn't any difference between the two groups, but certainly over 10 millimeters, I think a dedicated snare is recommended and makes for a much smoother, quicker procedure. In my opinion, 10 millimeters is ideal. Even with very large polyps, you can quite quickly do a cold snare polypectomy. You can use the 15, but there is a tendency to stalling. And if diathermy is likely to be required, there are hybrid hot cold snares. So I've spoken a lot about snare choice, but probably in reality technique is the most important aspect of this. And first and foremost is looking very carefully, because and this is very relevant in particular when we're dealing with serrated lesions. So I would encourage everyone to use their best eyes. So make sure you ask for the best scope in the department. I annoy a lot of the endoscopists in our department because I'm always putting it on my booking sheet that I want that scope, and those that don't ask don't get. So I would encourage you to use your best scope. Really take your time to solidify the margins in your mind, because once you start resection, in particular when you're doing a cold snaring technique, bleeding can be an issue and you may miss small areas. And consider using adjuncts. So, in the era of push-button chromo, it's highly effective and very useful, but of course, indigo carmine, either sprayed or injected, can be quite useful. And, taking your time, you can see very subtle lesions here that are not easy to see, and lesions here. So this is a serrated polyp with dysplasia, which you may only kind of appreciate that, but has quite a long lateral extension component. So what about position? Well, I think position makes the difference between something that can be quite difficult and challenging, and then suddenly it just becomes easy and you remove a polyp in a short space of time. So sometimes I even forget about the patient needs to be repositioned. So unlike Raj's comment, I think, yesterday about gravity being your friend, I say gravity is not your friend in the bowel. So if you're taking care of a polyp, you shouldn't put in a dependent position because you're going to have fluid collecting in that area. When you start to have bleeding, it can obscure your view. So try and get your polyp into a non-dependent position. The 12 o'clock position is also not your friend. It's the worst for scope dynamics. You really need to have a good ability to bring that polyp down to the 5 to 6 o'clock position. And just remember that a patient has 3 sides, and one of those sides is going to be ideal for that resection. So if you're struggling in the left lateral, go into the supine and roll them onto the right-hand side, and you'll find that it can open things up and make for a much easier resection. So what about technique, which is most important? So obviously accurate snare placement and suctioning is key. So when we're doing a cold snare technique, it's really important that we want to work, one, very close to the lesion, accurately place your snare and ensure that you get a nice wide rim of normal tissue. And with cold snaring, we're really not worried about injury or post-polypectomy bleeding or perforation. So you can really be quite generous with your margins. I then apply downward pressure with slight suction and then slowly get your nurse to close the snare until you start to see that tissue being captured, and then you can cut through. Once you've removed a polyp, don't just pat yourself on the back and move on to the next one. It's really important to go around that margin carefully, and anything that you're not certain about, resect it further. It's a very safe technique. Now, what's important with cold snaring is don't be Mr. Greedy, because that will increase your risk of snare stall, and certainly snare stall with traction has been associated with perforation with cold snaring, albeit very uncommon. But if you do get a snare that stalls, so this is a snare that you fully closed, doesn't cut through, firstly, just be patient. Often you'll see it will be very slowly cutting through, and it will eventually cut through the tissue. Ensure that your assistant doesn't have loops in the sheath, because that can increase resistance. If those 2 points are not an issue, securing it at the port and just straightening out the sheath can also cut through. If that doesn't work, I tend to loosen the snare and I elevate it up, kind of like a mushroom effect, just under the head of the polyp and close down, and that will often cut through. And if that doesn't work, I'll then use slight traction, and I tend to do slight traction with snare open, so under the polyp head, and just pull it off, and it just slides it off, and you're left with that vascular stalk in the center. Now, with repetitive use, and in particular if you use a lot of traction, these snares very quickly bend out of shape, and if you don't reshape it, it starts to make areas that you can resect much less, and so be in the habit of pulling it out from time to time. So I'll just quickly go through adjuncts, which we know are available in certainly hot snaring. I just want to bring your attention to this study which looked at the safety of cold snare polypectomy, but they actually looked at standard cold snare polypectomy without injection versus a standard injection cold EMR technique. And they found really there was no difference in the overall technical success rate, adverse events, or residual rates, regardless of which technique you use. They did interestingly find that residual rates were lower with the cold snare technique compared to cold EMR. And they found, obviously, that the larger your polyp, the more likely you were to have some residual, and that's a bigger area to examine. But there was no difference on univariate or multivariate regression. So when should you consider submucosal injection? Well, probably with SSLs with poor margin visualization, very important. Larger SSLs, I feel it reduces the stalling of your snare. If you're not using your best eyes, using indigo carmine submucosal injection is helpful, and at flexures and folds in difficult areas to push it forward. I'll just very briefly talk about adrenaline. I used to use this routinely. I don't use it anymore because I do find that pain can be an issue, and this was shown in this study by Doug Rex. I'm going to, in terms of snare tip coagulation, obviously well established for hot EMR for adenomas, but it's an evidence-free zone currently with cold snaring, although I believe that there is currently a randomized controlled trial going on at Westmead to look at this very question. And I'm just going to finish with a couple of videos. So this is a large serrated lesion. You can actually see here that centrally there is an adenomatous component. So this is a dysplastic lesion. In this situation, I still do perform piecemeal EMR. Sorry, Professor Sano. But I make sure that that area of the dysplasia is resected in an en-bloc fashion. So the technique here is placing your needle just above the lesion and injecting and pulling back until you get your plane, and you get that nice submucosal lift, snare placement is critical, and as I said, having a nice wide margin of normal tissue, slight downward pressure and suction and cutting through. And as I say to my son when he's complaining about his homework, you eat an elephant in small pieces. Okay, so it doesn't matter how big the polyp is, you methodically go, ensure that you're overlapping, and you continue until it's resected. And again, look at your margins, because you will see small little areas potentially that you can see there, which will then be easily resected. And I just want to finish with this final video. So this was a patient in his 30s who had a mechanical valve, who was found to have this very large laterally spreading granular 2A polyp in his ascending colon. Whenever his INR dropped below 2, he would have embolic complications. So we actually did this procedure fully anticoagulated, again using a cold snare technique. Unlike with hot snaring, where you really are cautious about how much submucosa you get, when you're doing a cold snare technique, it's quite okay to include additional submucosal tissue to make sure that you don't leave small islands within the EMR central defect. And so this lesion was fairly quickly resected, only using, there was adrenaline in this injectate, using a cold snare technique. And this patient never ceased his anticoagulation. He was observed just on the size of the lesion, and he was discharged home without any issues. And this was his follow-up at 6 months. Thank you.
Thanks very much, Spiro. Are there any questions for Professor Sano? That mic doesn't work, so...
Thank you very much. I want to ask one question. Piecemeal cold resection is very effective for SSL. But in Japan, maybe we performed pre-cutting EMR. After making a excision, cycle excision, we use snare, same snare, and then block resected. So it's a very common in Japan. So how do you think?
Yeah, so again, coming back to your talk about your index of suspicion of malignancy, if there is a high-risk lesion with an advanced vascular pattern that you're suspicious of early cancer, we would always advocate an attempt at a non-block resection, of which there are numerous techniques. But in a polyp that has a low likelihood of invasive cancer, a lesion of that size removed in a piecemeal cold fashion would probably take around 10 minutes. The risk of bleeding and perforation is virtually zero, and these patients go home the same day, and we can then do the other 5 or 6 patients waiting on the list on that same day. So there's a lot of other constraints of our time and resources that lead many of us to not be able to do purist resection of these large lesions. But I agree, if there's suspicion of cancer, we should always preserve on-block resection.
If performed piecemeal fashion, you have to retrieve all the piece. So I think maybe you need sometimes a net or something.
Well, actually, the advantage of the cold snaring and using the 10 mil is that often with a standard colonoscope, you can retrieve the specimen through the suction port.
Okay.
So I rarely need to use a net. And that's, in fact, another advantage or something I like about the technique. If I do a hot snare in the right colon, I may have to do 2 or 3 trips there with a Roth, whereas with cold snaring small pieces, you can mostly suction it.
Okay, I understand. Thank you.
I'd be interested to know which of these large resection sites you would consider closing with clips.
None of them. No, and we'll hopefully be publishing our literature at AGW this year, but my standard practice is also not to stop DOACs or anticoagulants or antiplatelets. As long as it's a cold snare technique, bleeding is virtually not seen. So we'll have about 1,000 polyps over the previous 5 years that we have resected. Not necessarily this size. These are kind of the average less than 10 mil polyps with very low rates of bleeding. And no, I don't close cold. Although I will talk about this briefly in my next talk. There are some circumstances I would, but no, I generally don't in this situation.
I think there's time for one more question and then we'll move on.
Now, if you find a polyp in the diverticulum, so what would be your advice?
So if the polyp is extending completely down the lumen, you can't see the distal margin, or you can see the distal margins. Because if you can see the distal margin, I'll try to inject distal and push it out of the diverticulum. If I can't see the distal margin and it's extending down the diverticulum, really your options at that stage are either to use a full thickness resection device and resect it completely with all the layers, or depending on the location, patient factors, sending that patient for surgical intervention. So, you know, we unfortunately can't spare all patients of our surgical colleagues. We do our best to try, no offense, but these are indications for surgical intervention for benign lesions. I think, you know, benign lesions, very few of them should have surgery, and that's maybe one of the indications.
Thank you.
All right, thank you very much. Alrighty, so our next speaker has already given us one talk today, and this is 2 of 3, I think. So Associate Professor Bronte Holt from St. Vincent's in Melbourne and the University of Melbourne, and she will be giving us the counter-narrative today. So cool tips, hot snare. Thanks, Associate Professor Bronte.
Excellent. Okay. Thank you very much. So yes, today I'm talking more about techniques to use the hot snare. Again, I'd like to thank the organisers, Raj and everyone, for inviting me to talk on this topic. I'm going to talk about 3 main sort of areas that we use the hot snare, and we've already heard a lot about some of the advantages of a cold snare technique, which I 100% agree with. So this is not really a debate of one versus the other, just we don't use cold snare for everything. And one of those areas is Barrett's endoscopic mucosal resection, or EMR. There are a couple of different snare techniques for Barrett's EMR, but the vast majority of times that we do Barrett's EMR is with the multi-band mucosectomy device. And one of the key aspects of doing a band resection in Barrett's is to define the resection margins first, and then to ensure that you're having good tissue capture. And with the tissue capture, you can either work cranial to caudal or caudal to cranial. So my preference when you're doing a tissue capture with this device is to work from the top downwards, and you want to work in a confluent pattern of resection of the Barrett segment, so to avoid leaving any little Barrett's islands in between, so you end up with a confluent resection. When you're suctioning up the tissue into the cap, it's okay to fully enclose the cap or fill up the cap with the tissue. However, you don't want to sit there with your suction on for a prolonged period of time because of the risk of capturing up the muscle layer of the esophagus. The next sort of step with the tissue capture is when you've got the tissue within the cap of the duet, then you're not in a hurry. This is not like one of those cases where you've got a bleeding varix or something and you're using a similar band ligator. If you're not 100% happy with your placement, you can just let it go before putting the band on and reposition. So take your time. And then when you're deploying your band, you can deploy it slowly, and you can actually feel how it's released, how it's coming up into the cap, and how the band is released. Once you've got your sort of pseudopolyp, then the key is to not sort of pass that pseudopolyp, because it can sort of gradually sort of work its way off, so you no longer have the band nicely in place. And then if you're resecting at the gastroesophageal junction, to make sure that you're including part of the cardia as well, to make sure you get the intestinal metaplasia there. The next sort of thing I wanted to talk about is how you actually get your snare over this pseudopolyp that you've created. So when I'm working in the tubular esophagus, then I like to actually place my closed snare beyond the pseudopolyp first. I ask my assistant to open the snare, and then I will then pull back the open snare and lay it down sort of over the pseudopolyp. And here I want the V of the snare, which is at the end of the catheter, to be really embedded down underneath the band. And then when they're closing the snare, it essentially brings the back of the snare towards the pseudopolyp, like this. At the gastroesophageal junction, it's sort of the opposite. So here what I do is I, again, get them to open the snare beyond the pseudopolyp, place it down over the pseudopolyp as I'm pulling it back. But here I want the edge of the snare to actually be what's capturing underneath the band at the other end. And so the technique here is a bit different. So I ask my assistant to slowly close the snare, and then I push the catheter out through the working channel as that snare is getting closed. So it maintains the position of the snare on the caudal end of the pseudopolyp. And this is important because at the gastroesophageal junction you can, this is one of the places that you can perforate. If you capture, you usually have a larger volume of tissue in the Barrett's pseudopolyp that you created, and there's a higher rate of perforation here. So this is a technique where you're actually drawing the polyp back into your snare rather than pushing it down into the cardia. In this technique here, like that, before the resection. The next thing I wanted to talk about is hot snare resection in pedunculated polyps. This is one of my patients who I saw at the start of the year had a positive FOBT, and this was at 22 centimetres from the anorectal junction. And I was quite concerned about this polyp. I thought it might have an early adenocarcinoma in it. The image that showed the tip of this wasn't really that great, but it was clearly a dysplastic, a significantly dysplastic lesion. You've got you've got a number of different approaches to polypoidal lesions like this. The main issue is managing the risk of bleeding on resection, and then also if this is a malignant polyp, you want to make sure that you're getting plenty of stalk. So you can imagine, you can actually see the slight blue colour in that stalk. This is a really vascular lesion. It's got an arterial supply to it. So your options to try and reduce it is either you can preemptively inject the polyp with saline or any other sort of fluid containing adrenaline, and then that helps shrink down the head of the polyp and can also control any bleeding, or you can preemptively clip the base of it. Or you can do sort of a combination of both. In this case, I elected to pre-inject with some saline containing some indigo carmine blue, and then also adrenaline, and then took it off en bloc right down at the base wall of the colon. You don't want to be taking this underneath the head of the polyp, because if it's an invasive lesion, I want to get plenty of space in between the lesion and the wall of the colon. And indeed, at the end of this, there was no bleeding. It was all very, very nice and clean, and I just prophylactically closed it because this patient had a cardiomyopathy and was on rivaroxaban, so I wanted them to start that ASAP. The pathology came back as a low-grade adenocarcinoma. It was invading into the submucosa. The margins were clear, so there was 13 millimetres of clear tissue from the wall of the colon and the adenocarcinoma. And the patient has since come back for their first surveillance scope with me, which I had 2 weeks ago, which is lovely and clear as well. And we discussed them at an MDM to come up with that surveillance plan as well. I'm going to move on and talk about hot EMR now, and this is the sort of equipment that you need to have in your unit if you're going to perform hot EMR, and I'll talk about the sort of clinical impact or the rationale behind each of these. I mentioned previously in the duodenal talk about the importance of having a microprocessor controlled electrosurgical generator, and typically I'll perform all EMR with the Irby Endocut Q Effect 3, and then on the blue pedal I'll have soft coagulation Effect 4 80 watts ready to go. I don't do any EMR with a forced coagulation setting, which is often what's preloaded. So if you ask your nursing staff, set it up for EMR, and the blue pedal will always be on forced coagulation. So you yourself have to learn how to change it over. I use carbon dioxide insufflation. This has been shown in good quality studies that it decreases the post-procedural pain. A colloidal solution, ideally, and here in Australia we would use Gellifusen. You can also use saline, but it doesn't have as sustained lift, and it's been shown to result in requiring more resection pieces to clear the lesion. We use an inert dye in the submucosal injectate. As this helps define the submucosal layer, it only stains the loose areolar tissue of the submucosa. It does not stain the muscle or the mucosa. And so it allows you to see, have I got the margins clear, and do I have an injury to the muscle layer underneath? If you have any resection and there's no blue in your resection, then you've got two options. Either you've gone too deep and you've got a muscle injury, or it's just simply unstained submucosa. So you can quite simply use your submucosal injectate that contains the dye. Without putting the needle out, you irrigate into that defect, and if it fills up nice and blue, you know that you've got a safe, clear margin. The next thing you really need is the foot pump. That's essential to be doing EMR to maintain a clear field of view, particularly if there's some intraprocedural bleeding. Use a transparent cap to access your lesion, and use a stiff snare. The process of, this is a colonic EMR, is a sequential submucosal lift and resect technique. And the submucosal injection and the snare technique are both dynamic. And I think that's really the key thing about the technique that I wanted to take away. So with the submucosal injection, what you're trying to do is really improve your access. So if you've got a lesion that it goes over a fold, or it's sort of around a flexure, that initial submucosal injectate will bring it out from behind a fold or from around the flexure to improve your access into it. The submucosal injectate, again, it will also help define your lesion, and I like to think of it a little bit like, with the resection, a little bit like a jigsaw puzzle. So you basically want to follow your line of your resection to make sure you're having a continuity approach of the resection, and you really would ideally like to follow the haustral folds as well. The snare placement is also very dynamic, so it's not sort of a matter of simply placing the snare over the lesion. Ideally what you'll do is impact the tip of the open snare. So basically, as soon as I get the snare down, I ask my assistant to open it. I'll then withdraw it back into the channel of my scope, and then I'll point my scope onto normal mucosa. Then I pass out the snare that's opened, impact it into normal mucosa on a cushion of fluid, and then push the catheter out as I'm backing away with my scope. And this is sort of like a three-hand technique. So usually what I'll do is I'll have all my controls in one hand, I'll be holding the snare tip at the catheter with this hand, and these fingers I hold my scope. And so then I can push the catheter and use my hands for the knobs. And then once you've got the lesion completely resected with snare, then to treat the edges with snare tip soft coagulation. As we know, this reduces the residual. And if it's a lesion that's over 20 millimetres of size in the right colon, then we have good quality randomised controlled studies and a subsequent meta-analysis that shows that the rate of post-procedural bleeding is significantly reduced if we close that defect. I'm going to show just a short video. It's one I took a little while ago. This is a Paris 01S non-granular lesion that's located in the cecum. It's in between the appendiceal orifice and the ICV. And we can see it's got a Kudo-Pitt pattern type 4. And there were no concerning features for advanced malignancy in this lesion. So the first thing that I do is just assess the whole of the lesion and just make sure that we've got we can see the extent of it and sort of plan the resection. Which I think this might have been a transverse lesion, apologies. And then this is the injector. So what I'm just doing is sneaking it underneath the edge, so I'm on the lateral margin. You start injecting, you ask your assistant to start injecting before you advance the needle into the submucosa, and then the submucosa will start to fill with fluid as it finds that space. If you don't see an immediate lift, you need to pull the needle back to then find that space. You don't keep on injecting into the peritoneum. And then the subsequent injections just follow into that cushion that you've sort of created first. Then I'll look around the polyp, just carefully making sure that I've got the entirety of it lifted. Got to put a little bit more in for good measure. And here I'm going to attempt to do an en bloc resection. I've got a 20 millimetre stiff braided snare, and I like to go past my lesion and then basically lay the snare as I'm pushing it out, sort of as my scope comes backwards. So it's sort of a dynamic snare technique. And then I've swung to one side to capture one edge, swung back to the other side, and then I'm going to pull back a little bit so I can make sure that I've got a nice margin of tissue in the V, in front of the V there, before I suction down to reduce the amount of carbon dioxide, and it really means you've got less tension on the wall of the colon here. And then ask my assistant to start closing the snare. And then with something, a lesion of this size, using a stiff, this is a braided snare, this is not a thin wire snare here, you close it, I like to close it all the way. It's not going to cut through, and I check the mobility, and it's not moving the whole colon, so I know that I don't have muscle underneath there. And then it's just a quick cut with the endocut cue, that's the yellow pedal. And I like it to come through quickly. If you sit there sort of burning, that's heaps more energy and heat that's going into the defect. I've left a bit on that distal wall. Here you could change to a small snare. It'd probably make your life easier, but I was being frugal with the government's money, and so I was using one of the stiff snare as well to just take that back edge and cut that off. And so this was almost an en bloc resection. And then the edges were then cleared, so treated with snare tip soft coagulation, and it was then clip closed afterwards. And I think for good measure, actually, I took off that little nubbin at the front just because I like to have a neat defect. Yeah, though I wasn't worried about that one. And I was just treating some bleeding as well. There are some other techniques that have been described for EMR. This is a study from a few years ago called the anchor EMR technique. And I think whilst this study, it was an interesting sort of idea, and I think that we adapt a lot of these sort of things. It's what I was talking about with the dynamic snare maneuver, that you impact the tip of your snare to then make sure that you know that your tip is onto normal mucosa. With this study, the aim was really about getting the biggest sample possible, and they had a perforation rate of 3.5%, which I think is a lot higher than we would accept. But I think that principle that if you're having trouble in having your snare stay in place, it just keeps on sliding off your submucosal lift, what you can do is just use the tip of the snare to burn a little hole into the submucosal lift onto normal mucosa, and use that as the anchor point for your snare before you place it. Intraprocedural bleeding is very straightforward to manage. This is where it just doesn't settle down by itself. You can treat it with snare tips, soft coagulation, coagulation graspers, or through the scope clips. It's important to recognise a perforation when it occurs during EMR, and this is the sort of so-called target sign of muscle injury, which can be graded using various sort of perforation grading guidelines. But essentially, if it's full thickness through and through, then you should give the patient some antibiotics and close it up, or it may be a more superficial defect. And you can see that here. This is a superficial injury to the muscle layer characterised by a white cautery ring. If you have a perforation, it's important to recognise it early, don't panic, position the patient so the defect is not in the dependent portion. So if you have to roll them, you do that. Make sure you are using CO2 insufflation, give antibiotics if necessary, and then simply close the defect. And usually you've got time to perform some more resection to ensure that you're not clipping your defect closed with adenoma in there as well. So clear the lesion and then close it. I typically would use through the scope clips to close an EMR perforation, but you can also use over the scope clips and suturing devices as well. Now, I think we've sort of talked a little bit briefly before about clip closure to prevent bleeding, and this was the recent meta-analysis that confirmed that really we should be clip closing all hot EMR defects that are 20 millimetre or greater than size. Lesions that were clipped closed had a bleeding rate post-procedurally of 3.5%, and if they weren't clipped closed, it was 9%. And the number needed to treat is 18. So you have to clip 18 lesions to stop one clinically significant bleed. This is not all bleeds. These are bleeds that need hospitalisation or blood transfusion, so they're significant bleeds. So the numbers are good. Okay, so I think that's what we should be doing. However, the thing about this is not all EMR defects can easily be closed by clips, okay? And so it's that 20 to 40 millimetre size, that's the sweet spot. But we also do know that partial closure is better than no closure. So give it a go if it's possible. I wanted to briefly mention on the non-lifting polyp. So when you're doing a resection or you see a lesion and it doesn't lift very well, it doesn't necessarily mean it's an invasive lesion. This could just be submucosal fibrosis, particularly if the patient has got a history of colitis, it's at a flexure point where there's a lot of peristaltic motion, or they've had previous resection attempts or vigorous biopsying. And the technique here is cold avulsion and snare tip soft coagulation, or CAST technique. And this is where you simply just can't get the snare around it. It keeps sliding over. It doesn't matter how hard you try. You might try and suction on it to create a pseudopolyp, and it's just not coming off. So you use cold resection, cold biopsy forceps, and it just peels away incredibly well. So you've achieved the aim of resection. It's just using forceps, and then you use snare tip soft coagulation to get rid of any residual adenoma. We've mentioned briefly about the role of snare tip soft coagulation to the defect edges. This has been shown in a prospective study of close to 400 patients that the residual adenoma rate significantly reduced from 20% to 5%. So anytime we do a hot EMR or indeed a cold EMR, we should look at doing this technique to reduce the residual edges. And then when you bring those patients back, you need to carefully examine the EMR. Because 5% is still 1 in 20 patients will have some residual polyp, and we need to be able to recognise if there's any residual lesion there, as is in this case. Again, here and here. Thank you.
Thank you very much. We're actually really eating into lunchtime now, so we might save the questions till the end, maybe during lunchtime if that's okay. So thank you, Associate Professor Holt, for that talk.
So we'll welcome back Spiro Raftopoulos to the stage of talking about colonoscopy pot puree. So we've sort of all sorts of different colonoscopy techniques that he might discuss here, and as mentioned, we'll save questions till the very end now. Thanks. Welcome back, Spiro.
Thanks, guys. I'll try to keep this brief so that you can all get to lunch. So there's a little bit of an overlap here which will allow us to take up some more time, but essentially I was going to talk about these three principal areas. So this, for those of you who don't know, this is Lucky Diamond Rich. He's an Australian, and he is in the Guinness Book of Records for the most tattooed man in the world. So he's got over 200% of his body tattooed. So that's tattoos over tattoos. Now, for Lucky, his tattoos are his fortune. But when we talk about spot tattoo in the colon, these are not without their potential risks. And so when I get referred a case like this, my heart always sinks. And I realize that the person who has sent this patient to me is not understanding the indication of when to use spot and how to administer spot tattoo. So, you know, we have a lesion here that is clearly described in relation to a known anatomical location. So, you know, 2 folds distal to the ileocecal valve on the same side gives me a very clear indication where that lesion is. We also have a spot tattoo which has been injected proximal to the lesion instead of distal, which certainly, not in this location, but certainly in other locations, does increase your potential risk if this patient is sent for surgical management that the bit of bowel that you want removed is left behind. So the standard understanding is that spot should be distal to the lesion of concern. This is a 2A granular polyp, so it's a benign appearing polyp with a very low likelihood of invasive cancer. The referring clinician here has decided that this is not for them to remove, and so, why necessarily spot tattoo this lesion if it's benign and you're going to send it to someone else? Rather defer to the person who will resect this polyp to determine whether spot is required. Spot has been injected, and unfortunately you can see that spot is involving the base of this polyp, which we know now increases submucosal fibrosis and increases the risk and reduces the success rate of for first-time resection. And lastly, this is not a subtle lesion. If the person you're referring this patient to cannot find this lesion, then they probably shouldn't be removing polyps. This lesion is easy to locate. It's not very subtle. So what are the indications? In my opinion, I think subtle lesions, such as serrated lesions, which are in an uncertain location and difficult to identify, those lesions because you see them and then all of a sudden they disappear and you spend another 20 minutes trying to find it. If you're not going to remove it, it may be useful to put some spot tattoo. For lesions that you suspect have a high likelihood of having cancer, which you will be on referring in the event of positive histology, reasonable to spot tattoo that to prevent them having to come back for a second procedure. So why do I go on about spot tattoo? Well, it's not a benign intervention. This series was from the Westmead group, so they reported 4 cases of spot-associated complications, specifically peritonitis, perforation related to poor lift with an EMR, and even hepatitis following injection at the hepatic flexure. So if injecting, I would consider the indication, and in my opinion there's 2. Ensure at least that you are 3 centimeters from the lesion, in particular if that patient is being referred for resection. And in that setting, I would suggest that you use a smaller volume. And I also encourage a saline pre-injection technique to avoid spot going into the peritoneum, which can sometimes be a problem if that patient goes to surgery and potentially cause the other complications that I've already mentioned. So I just want to poll the audience here. For those of you who identify a lesion that is cancer, and you are going to refer that patient, how many of you inject spot as the last intervention? You've seen it, you've taken your biopsies, you're going to do spot and get out? Show of hands. Okay, so maybe half. How many of you will inject spot at the time of identification before you do anything, actively? So not too many. And how many think it doesn't really matter, just do it whenever? The rest of you. So, okay, so I just want to bring your attention to this Dutch study which looked at tumor seeding during colonoscopy as a possible cause for metachronous colorectal cancer. So this group actually looked at patients who'd had a colorectal cancer removed surgically, who then presented with a metachronous lesion within 12 months of having had their surgery. And they actually proved in this study that there was about a 5% rate of incident cancer at sites of either biopsy, polypectomy of other polyps, or sites of injection. And there have also been case reports of seeding of tumor into peritoneum at the time of doing a spot tattoo. So after this study, actually, I changed my practice, and I would encourage everyone to really, if you see a malignant lesion, the last thing you should do is the biopsy, and I would suggest that at that point you inject spot tattoo, and that's the end of the procedure. Even if you see distal polyps on your way out, because this is a real risk and can have significant implications for patients. So I just want to show this video of the technique that I use. So I always tell my nurses to prime the needle with saline, and I leave the saline connected. So this way I can access the submucosal plane quite nicely. So my first bleb, so I still have saline on my needle, and I do it in 3 walls. Again, access the second submucosal bleb. And now I get my nurse to change over to spot tattoo because I have 2 mils of dead space in that needle, which gives me 2 mils of time to find the next submucosal space. So I found it here. 2 mils later, I'm going to get some spot tattoo coming in. And I can then now safely go to the other 2 areas that I've raised with saline, and I can very accurately and confidently know that I'm getting spot into the correct place. And I think this is a very simple thing to do. It doesn't take much more time, and it just avoids those potential issues that I've spoken about. This is what AI thinks terrified nurses look like. And this is often the response I get when I ask nurses to bring out the polyloop. I love the polyloop, and I use it quite a lot. So I'll spend a little bit of time here on this device because, unfortunately, it is a little bit counterintuitive. But
there are 4 processes. So the loop that comes in a polyloop, you can sheath and resheath it many times, open and close it many times. So just like you would a clip. What you can't do is close the loop by advancing the collar. That you can only do once. So using the sheath to backwards and forwards to open and close the sheath until you're in a good position, and then opening the sheath in small increments and closing down the loop, small increments closing down the loop until it's fully tightened, and then you can release the loop once you're happy. So I'll just demonstrate it. So this is a pedunculated polyp, very similar to the one that Bronte showed. You know, sometimes with these large pedunculated polyps, you take them off and you may be half an hour later still trying to control bleeding. So I personally like to place a loop. So here we're opening the loop by issuing the command sheath back. And I tell the nurses, don't touch the handle because that risks deploying the loop accidentally. And so once it's open, as you would place a normal snare, I'll then maneuver that over the head of this polyp, and I'll snug it right down to the base of the stalk, because it is important you get a wide margin in the event that there is cancer there. So now I'm closing the loop by sheath forward, and this now allows me to get a precise positioning of where I want that loop to now finish. If there's peristalsis or there's movement, your loop is not going to shift away from that position. And now, through a small process of opening the sheath and closing down on the handle, I can then slowly close that loop to until it's in the exact position that I would like it to be in. And you'll see here that the metal will start to come in there soon. So there's the collar. So here you can see the collar starting to appear. Now I can pull the sheath all the way back. You can see the transparent collar there. I used to be concerned that you would cut through these snares, these stalks cold if you went too tight, but in reality, if you can cut through cold, it probably didn't need a loop. So I close it quite tight. I look to see that the polyp gets a bit dusky. And then in the opposite direction, you can then release the little hook that releases your loop. So we have entered into a clip tsunami to the point that that health funds now are even talking about taking them off the device list, which means that patients potentially are going to be made liable to pay for these. And in fact, Ramsay Healthcare had mentioned not so long ago that they may even push that onus onto the practitioner to recover those costs if you use clips, because there has been a significant increase utilization of clips, and unfortunately in many cases not really with valid reason. So Bronte has already spoken about the literature in for use of clips, but I would say, clips should certainly be used in the setting of perforation or MP injury. If you're doing hot snaring with lesions more than 20 millimeters, early resumption of anticoagulants and antiplatelets. I would also say use it for localization. The surgeons love it because sometimes we're not, in fact, a lot of times we're not very accurate with tumor localization, and that can make a difference to how the ports are placed and what position a patient is in. And you may not see lesions on CT if they're early. So putting a clip right at the lesion and then sending them for their staging CT gives you absolute localization of where that tumor is. I also tend to think about it when I've really struggled to get into the right colon. And I say, I never want to come back into this colon ever again. I will clip a defect shut. And then there are certain patient factors. So obviously patients going to very remote communities, patients who cannot have blood transfusions, I will consider it. But cold snare-related oozing, which I see a lot of, there is really no role. Just be patient. It will stop. Left-sided lesions, the evidence is not strong, and obviously small and diminutive polyps. And I just want to demonstrate the technique here. So this is a patient who had a large neuroendocrine tumor resected from the rectum. So I tend to place the first clip just distal to the lesion, suck down slightly and close, and that brings the edges in, and then just doing it in a zipper-like fashion, one clip after each other. So placing the clip, slight suction, downward pressure, and then close down. And that can be continued in that fashion until the lesion is completely closed. And as Bronte mentioned, sometimes you can't close mucosal defect to mucosal defect. It doesn't matter. Even if you get partial closure, you will significantly reduce that patient's risk of post-polypectomy bleeding. And I won't discuss this. This was very nicely seen, but recognizing a target or mirror target is important. If you see this, close it with clips. It saves the patient having surgery later down the track. So thank you for your time.
We'll do the questions at the end, if that's okay. So welcome back, Associate Professor Bronte Holt, this time talking to us about emergencies and for colonoscopy, so acute lower GI bleed, perforation, and pseudo-obstruction. Thank you, Bronte.
Okay, great. So with this emergency in colonoscopy talk, I'm going to talk about three main areas: acute lower GI bleeding, perforation, and acute pseudo-obstruction. So when I was thinking about this topic, I was like, well, what's going to be a 000 call for acute lower GI bleeding? And the way that we can think of these causes of acute lower GI bleeding is vascular. So is this from an AVM or is it a diverticulosis? And this is actually the most common cause of a acute lower GI bleed. It accounts for 30 to 40% of cases. It's actually a rare complication of the disease. It's just that diverticulosis is very common, particularly in Western populations. It typically occurs in the absence of diverticulitis. Diverticulum often develop at the site of an arterial vascular penetration. So a diverticular bleed may be large volume and arterial in nature. Right-sided bleeding is more common than left-sided diverticular bleeding because the wall of the bowel there is thinner. It's usually self-limited. So if a patient presents with a diverticular bleed, it will often settle down in 70 to 80% of cases. Rebleeding, however, occurs in 40% of those patients. So if you've had a patient with a diverticular bleed, you can tell them, yep, it's a good chance, 40% chance that this may happen again. The other vascular lesions are, so we've mentioned angiodysplasia, also ischemic and radiation-induced. The most common out of those are angiodysplasia or AVMs. AVMs are particularly common in patients more than 65 years old. So AVMs are dilated, tortuous, superficial blood vessels which are epithelial lined, so they're not muscular lined. Bleeding, therefore, is venous, and so it's usually low volume and rarely results in a 000 call. It's treated by colonoscopy with APC, but this is usually done on an outpatient basis and not as an emergency. Hemorrhoids can sometimes present with a large volume bleed, but generally it's very uncommon to be large enough to be causing any hemodynamic instability, but it can cause a large volume loss over time. Inflammatory causes such as colitis are usually associated with other clinical symptoms that would sort of point towards the etiology. And then there's neoplastic bleeding as well, so from malignancies. These are really anyone that's gone through residency will sort of know these steps of the management of acute GI bleeding. These are the features, however, that can predict worse outcome with an acute lower GI bleeding. If the patient has hemodynamic instability, they have persistent bleeding, significant comorbidities and advancing age. Bleeding in a hospitalised patient is also a poor predictor. A history of previous diverticular disease and angiodysplasia-related bleeding. If they're on current aspirin, and I would sort of add to this any blood thinners. If their blood results show essentially that they're sick, so an elevated INR, hypoalbuminemia, anemia, elevated urea, so renal impairment and abnormal white cell count. Also a predictor of worse outcome is a non-tender abdomen and no diarrhea, as these are otherwise treated by different mechanisms. If a patient is hemodynamically stable and present with an acute GI bleed, then these are patients who would go for a colonoscopy and try and identify the source. If it's identified, for example, it's a diverticular bleed or an AVM, then we would simply treat it. If a source hasn't been identified, then we need to sort of figure out where it's come from. If the episode's isolated, self-limited, and they don't have iron deficiency anemia, if it was isolated, self-limited, and not associated with iron deficiency, then we would have expected management. If, however, any of those were present, then we would have an upper endoscopy, look for a source from the upper end. And if no source has been found at the top as well, then we would evaluate for small bowel bleeding. If a patient is unstable and presents with acute lower GI bleeding, then our guidelines would suggest following resuscitation, then we really need to talk with our colleagues, because these are patients that may not be suitable for a hot colonoscopy. So consult with surgery just in case it's needed, and or interventional radiology. They may be looking at doing a CT angiography or direct to DSA. Perform an upper endoscopy once they're hemodynamically stable, because if they're unstable, there's a good chance it's actually an upper GI source. If there's no source on the gastroscopy and the bleeding continues, then we would do a CT angiogram to locate it. Because this is basically saying that if someone's having a really large volume and they're unstable bleed, you don't want to go in and do a colonoscopy, because it's probably probably going to be from higher up, or something that you're not well enough equipped to treat compared to interventional radiology who would do embolization. This is the diverticular bleeds. So diverticulum don't have a muscle layer. So these are outpouchings, and because of the thinned layer within the diverticulum, this is what predisposes them to the bleed. So we've got to be really careful in treating anything within a diverticulum. If the bleed is at the neck of the diverticulum, then there should be some muscle underneath it, and you can treat it either with clipping or banding. Very judicious use of diathermy. If it's at the base of the diverticulum, then you need to be very careful of using any diathermy techniques, and it's more a clip-based approach if you can get to it. Studies have described as well using the band technique. I've not personally done this, but it's very effective if you're able to get a colonoscope with a banding system up to the bleeding diverticulum. And you can see on the image down the bottom what they've actually placed a clip first to help localise it with their diagnostic colonoscope. Then when they've gone back with the bander, that allows for easy identification of that's the culprit lesion. Because when someone's got active bleeding due to diverticulitis or diverticulosis, often it can be really difficult because all the diverticulum are full of blood. So it's hard to know which one is the culprit one. And then this is the, I think that's the same, pretty much the same image actually. There you go. The further thing that I wanted to briefly touch on is AVMs. This is a examination here that shows a rectal radiation proctitis. But the treatment is the same for AVMs throughout the colon. In the rectum, when we do APC or argon plasma coagulation, typically we wouldn't inject beforehand. But if I find AVMs in the right side of the colon, I will always do a small volume saline injection underneath the lesion, because you can perforate these patients, so they can have a microperforation, so it just increases the safety. The top images are actually from the APC, from the IRBI website, and they talk about the different thermal tissue sensitivities throughout the gut. So when you're in the colon, it's sort of a moderate sensitivity. So this is where you need to dial down the heat that's used. Whereas in the stomach, because of the thick muscle layer, you can use a higher wattage for the APC. And so if I'm in the colon, I would typically set my monitor at 30 watts and at 0.8 litres per minute. And then if you're simply not achieving any burn, then I would increase the wattage by 5. And this is a non-contact procedure. It's really important to know and understand what sort of APC device you've been given. The most common would be a forward shooter. That's where the argon comes out through the tip. And then you can also get ones which have got like a little rubber ball, like a little ball on the end where they go side scatter. And then you've got other ones which are side shooters. So you need to know what you're being given by your nursing assistant. And you want to ideally maintain a short distance between your mucosal surface and your device before applying APC. If you do get if you do touch the surface, there's two issues. You get coagulum onto the tip of your catheter, which can mean that your arcing is not as sort of predictable. But the other thing is then you get argon gas into the submucosal layer of the colon, which we want to avoid. Then the next 000 call would be colonic perforation. Now, colonic perforation is typically not an endoscopic problem. This is where we would be calling our surgical colleagues, or ED would. But there are some times where we might be involved, and this is mainly if it's been an intraprocedural and they've had a delayed presentation. So they present with acute abdominal pain, peritonism, fever, sepsis. They may or may not present with those features, but it's typically abdominal pain and all. They'll have a CT scan, which will typically show some extraluminal gas. I think many of us who do snare resection and EMR will have had a patient or two where there's been some microperforation. And those ones you can often treat conservatively. So post-procedurally, it may be from a resection, but it actually may be from your scope, from the shaft of your scope, with a luminal tear or a splenic laceration. It may be from a diverticular perforation or acute colitis. If it's a post-endoscopic resection, then I would encourage, consider an urgent colonoscopy if it's been less than 24 hours since it occurred and it's a contained perforation. This is a prospective multi-centre registry published recently in Surgical Endoscopy. I believe it was from Korea, and essentially they looked at 84,000 patients across multiple centres, and they were prospectively evaluating which patients had perforated. So they had a dedicated nurse at each site who were collecting this information, and they found that perforation was more common in therapeutic colonoscopy. It sort of makes sense. However, if it occurs during a therapeutic procedure, the outcomes are better because that makes sense as well. If you've had a perforation while you're doing a resection, you can close it up at the time. And typically, if it's a more complex resection, it's someone who knows how to use clips and is very comfortable in that sort of circumstance. If it's occurring during a diagnostic procedure, it's typically from the shaft of the scope. So it's an injury from the actual scope itself, and it's more common at the sigmoid colon and at the flexures. Risk factors for patients requiring a prolonged admission in the hospital is a sigmoid perforation. If there's been a delayed recognition, so this is why we need to monitor the patients in recovery afterwards, and they have abdominal tenderness because that's a marker of peritonism. Predictors of patients needing surgery is it was a diagnostic procedure because it's a shaft-related tear and rebound tenderness. How am I going for time? I'll just very quickly go through. This is another large study which was looking at the characteristics and treatment of both interventional and non-interventional iatrogenic perforations. And essentially, most of the patients who had non-interventional perforations required surgical procedures. My last sort of thing I wanted to touch on is acute colonic pseudo-obstruction. I must admit I didn't know a huge amount of this. I don't think we see it that often. So pseudo-obstruction is dilation of the large bowel in the absence of an anatomic obstruction. It presents with signs and symptoms of bowel obstruction, so abdominal pain, nausea and vomiting. They have an X-ray or CT imaging that shows proximal colonic bowel dilation. It can be acute or chronic. So chronic intestinal pseudo-obstruction is, or SIBO, is typically associated with some neurological diseases such as Hirschsprung's disease and Parkinson's disease. But acute colonic pseudo-obstruction is a different sort of kettle of fish. So this is a case report from New England Journal of Medicine in an unwell inpatient in hospital who developed abdominal pain and vomiting. And this is the classic X-ray imaging of the dilated colon. And this is known as Ogilvie syndrome. It most commonly affects the large intestines from the cecum to the splenic flexure. We don't know the pathophysiology. It's thought to be due to autonomic nervous system dysregulation. It mainly presents with inpatients, so those that have had surgery or are critically unwell, and symptoms can occur rapidly or progress slightly slower over a few days. If they have fever, severe abdominal pain or peritonitis, this indicates ischemia of the gut or perforation, and so they should be very closely evaluated for potential surgery. The initial management is with bowel rest, and they need some bloods taken. And then management is identifying the contributing factors, so correct electrolyte abnormalities, make sure there's no infection on board that's contributing, such as C. diff, and look at the medications. So anticholinergics and opioids are associated with this condition. Place a nasogastric tube to decompress the gut. A rectal tube can be placed on dependent drainage, and then it's treated conservatively if they seem to be uncomplicated, and will often resolve. So if the patient's cecum is not particularly dilated, it's less than 12 millimetres, is that correct? No, 20 I think it's meant to be. No, 12. There's no ischemia, peritonitis or significant pain, and this has a high success rate, around 77 to 96%. So the next stage, if that's successful, then we consider low-dose PEG administration to keep the bowels moving. If, however, they have only a partial response or no response, then we use neostigmine, and this is only as long as they don't have any contraindications to it. It's given as a slow push on a telemetry bed, and it's effective in 85 to 94% of patients. If that goes well, you can then essentially give them some PEG and away we go. If not, then colonoscopy is performed for decompression. Thank you.
Thank you very much, Bronte, and I'd like to thank all of the speakers for this session. It's been excellent. Thank you. Just a couple of housekeeping messages from Raj. We'll take a half an hour lunch break now and be back for the start of the next session at 1 o'clock. Questions, there's a nice 3/4 of an hour session, Ask the Experts, in the middle of the next session. So if you have had questions for the speakers in this session, there'll be an opportunity to ask them at that time. So time for lunch.
I'll just welcome back everyone. So we'll move on to the next session, and I'll introduce the chairs. And we have with us Dr. Gary Nin, who is Senior Consultant Gastroenterologist at the Queen Elizabeth Hospital. And we have Dr. Devinder Raju sitting next to him, who's the Head of Colorectal Surgery at the La McEwen Hospital, as well as Dr. Diane de Fontegelin, who is a Senior Consultant Colorectal Surgeon at the Flinders Medical Center. So I'll leave it to the chairs to introduce the next speaker, and we'll take it from there. Thank you.
Thanks, Raj. And thank you for everyone who have come for this session, which is Extreme Endoscopy and the Future. We're going to start off with the second talk. That's Professor Sano, which is titled EMR versus ESD, Should We Meet Halfway? Thank you.
So, good afternoon, everyone. So Noria skipped his talk because he's focusing on gastric cancer. So I move on lower GI. The title is very difficult to conclude. EMR, ESD, should we meet halfway? But I would like to talk from the Asian side. So ESD developed in 1998 in Cancer Center in Japan, and I started to perform the ESD 1999. So in colon. So that 24 years experience in ESD in colon. I performed many live demonstrations in the world, and this is a South America, and this is a maximum size of the 20 centimeters and per 10 centimeters. It is the mixed type lesion. This is intramucosal cancer, so located in the rectum. So this is a guideline for colorectal endoscopic submucosal dissection by the JGES. So in the guideline, among endoscopic treatment, ESD is the most suitable method for unblocked resection, particularly for large lesion, more than 20 million size. And piecemeal EMR may make it difficult to establish pathological diagnosis of invasion depth and to determine the free resection margin. And when piecemeal EMR, magnifying endoscopic observation, which is the best way to identify the carcinomatous part of the invasion, should be done before treatment. This is a guideline in Japan. So. Published in 2019. And this is an indication for the ESD in colon. It's a lesion for which in block resection with snare EMR it's difficult to apply, such as LST energy, particularly pseudo-Deplester type, or lesion showing type 5I, because we must perform the magnifying endoscopy. This is a Kudo type 5I pit pattern. And carcinoma with shallow invasion suspect, or Deplester type lesion, or large prodoring type lesion suspect to be carcinoma. And second 3-4 is layered. And this month, on the Gastroenterology Journal in the US, three correspondence. So it's a fashion, and I introduced 4 or 5 papers in this month, right, on the gastroenterology. So this is a published large cohort data prospective study conducted in Japan regarding to the ESD in colon. This study showing between the February 2013 to January 15, enrolled more than 1,800 colorectal epithelial neighbors, more than 20 million size at 20 academic hospitals. And so we follow up more than 5 years after ESD. And the study's primary outcome were overall survival or disease-specific survival and intestinal preservation rate. The author is Dr. Ohata. He's a sniper doctor in Japan. And this is outcome. 5-year overall survival is very good, 93 overall. And so non-curative resection, the 5-year overall survival is a little bit low, 88%. And intestinal preservation rate is also low if the non-curative resection performed. Non-curative resection are including performing a ESA but switch to piecemeal EMR. And but in this study showing local recurrence occurred only 8 lesions, so that 0.5%, and 15 metachronous invasive cancer were identified. So we conclude a favorable long-term prognosis indicated that ESB can be standard treatment for large colorectal epithelial neoplasm, more than 20 million size. And so can we meet halfway? I think it's very difficult. So this is editorial so to the Dr. Ohata's paper. This is from German doctor and American doctor wrote this editorial. And what is blocking ESD from entering center stage clinical practice? The first technical issue, special training and expertise, and high incidence adverse events. But however, the rate has recently drastically fallen. And doctors believe that the EMR results in high R0 rejection rate. But now some new paper is reported. I talk later. And reimbursement issue may block the performing ESD. And lack of expertise and the technique may antagonize supporting it. So this is an editorial to the Japanese prospective study. But in summary, so ESD is being performed more commonly in the West. The top priority is to validate its safe and efficacy in our own population. I think it's a good thing. But this month, this is correspondence to the Japanese paper on gastroenterology. This is from Australia. Colorectal endoscopic submucosal resection, not a case of the one-size-fits-all. Yes, I think so, yes. And so multiple lines of high-quality evidence indicate that such conclusions are not correct, very strict. The EMR recurrence data present in Japan study, this study, are out of date and incorrect. In a multi-center intestinal trial of more than 1,000 lesion, recurrence was 1.4%, so published in 2021. And EMR is easily so matched the ESD outcome with 98% patient being adenome-free and avoiding surgery at 16 months. So it's published as a GAT. And the current data indicate that ESD offers no benefit in reducing recurrence compared with piecemeal EMR for large colorectal epithelial neoplasm. Very strict message to Japanese doctor. Thank you. And this is the comment from the Dr. Lex Paul Hagel from US. They commented, LST homogeneous type is typically associated with a risk of the 1 to 2% of submucosal invasion, thus requiring 50 to 100 ESD to prevent one surgical resection in region with morphology. And 13 ESDs were required to avoid one surgical resection in patient with T1 cancer. Okay. And practical barriers to a policy of universal ESD for the large colorectal neoplasm in some countries often have their foundation in the reimbursement and the cost issue. I think so. The relative risk of EMR and ESD also affect costs and thereby choices. I think so. Yeah. And in some setting, selective use of ESD based in part on lesion morphology and partly on rectal region. I think. And in the best interest of many patients. I think so. Very important message for us. And this is a reply from Japanese side. So the recent meta-analysis revealed the incidence of local recurrence after endoscopic resection of large LST increased time regarding 4.5% at 5 years. So we want to say, so longer follow-up is very important. And almost all recurrence occurred after piecemeal resection in our country's data. Therefore, a long-term surveillance is necessary to conclude that EMR. The study's median time for metastasis recurrence was the OHAT study median is 14 months. So therefore, it is difficult to conclude that it is effective as ESD without long-term prognosis for piecemeal EMR. So obvious benign tumors such as sessile lesion or granular homogeneous type LST, so could be treated, I think, a piecemeal EMR. Whereas M or SM cancer with a potential risk for metastatic recurrence should be rejected en bloc, considering the cost of surveillance. This is our reply. Yes, so very difficult to conclude. But this is my case. The recurrence case 4 years after piecemeal EMR. This is finally occurred as advanced invasive cancer. So some cases showing very longer period. So they showed some recurrence as a invasive future. So that this is my conclusion. So endoscopic piecemeal resection is acceptable, I think, we think, for large colorectal lesion and with a low risk of carcinogenesis. So SSL, large SSL, or homogeneous type LST. And there is several issues that need to address before ESD and EMR can meet halfway. First is reimbursement for EMR ESD. In Japan, the reimbursement is 22 million yen, so that yes. 1,600 US dollar per ESD in colon. Gastric ESD a little bit cheaper. So colon ESD is the most expensive. So 1,600 US dollar. And whether hospitalization is required. So in Japan, the patient can admit several days. It's covered by Japanese national insurance system. And education on learning the technique, it is also important. And regulatory approval of ESD device. You know, so in Japan, so lots of accessories developed. In China as well. In China, so I think much more accessories they have for the ESD. So there is a issue, I think. And so we believe that large multi-center long-term follow-up study, more than 4 or 5 more, is needed to prove it piecemeal EMR for large colorectal neoplasm has similar local and metastatic recurrence rate as ESD. Because before establishment of the ESD technique, I think so 1998, so every Japanese doctor performed EMR or piecemeal EMR. But now, I think most of all doctors, so they don't doubt to perform the ESD for the colon or stomach and the esophagus because we can obtain the precise histology and so time is very shortened because we have lots of accessories for ESD. So I hope someday we meet halfway. Thank you very much.
Do you want any questions? Yeah, any questions for Professor Sano? Okay, we might move on in view of time to the colon MDT, where I think Raj Singh and Andrew Ruskovich are going to present some cases and get the panel to comment on things.
Okay, thanks, Gary. There were a couple of questions from the earlier session, so perhaps we'll try to answer those first. And I've just got it in front of me here. So we'll ask some of the previous speakers before we move on. So I think, Spiro, you touched on SPOT, and there were a couple of questions from the audience. One of the questions was whether any post-polypectomy site or distal to it, I suppose, should be spot tattooed for ease of surveillance later on.
Yeah, I mean, firstly, if you're removing a lesion and you have a concern about there being cancer, yes, you should spot tattoo definitely in that situation. I don't personally spot tattoo for EMR localization, although Michael Burke had mentioned that kind of now when we're getting to the third and fourth follow-ups, the scars are becoming increasingly difficult to see, and I think he is routinely doing it, but I still rather try and describe it in terms of distance or close to an anatomical location. I don't routinely spot.
And the other question was, and this was coming from the previous chair, was he's seen quite a bit of spot being placed in the rectum, which I think is a big no-no as well, in addition to the cecum.
Yeah, I must admit, I've always shared that same belief, but a few of the colorectal surgeons at our centre have said that when a malignant lesion is found, they actually want us to put spot in the rectum.
because they feel it does help them in terms of knowing how far down they're going to put their staple. So I suppose it's knowing what your local surgeons want. I mean, we have a very good working relationship with them, and they tell us exactly what they'd like us to provide them. But yeah, you're right. You could describe it as centimeters from dentate line and clock face orientation, and you can give them accurate. But our guys actually want us to put spot in.
What about Diane and Devinder? What would you guys prefer for rectal cancers?
We'd prefer non-interference of the malignancy in all ways. If we're going to do a TEMS for a polyp that you've taken out that has, you know, a PT1 or early PT2 lesion, we'd rather you put a clip on it so that we can take it out. But that distorts.
About that point there, because that is a common debate and discussion we have with our surgeons. I mean, the problem with, so if we remove a polyp that has a high risk or has cancer in it and has got poorly favorable features, the risk is not local recurrence, it's nodal recurrence. So how does it
that's a very...
How does the TEMS help that situation?
Okay, so it's not for every patient, eh? So rectal cancers, you manage the patient, not the cancer. So if you had an 88-year-old man with a PT1 cancer that you've incompletely excised, his treatment is not an APR. His treatment is a TEMS excision because there's a 25% risk of local recurrence. And if your MRI staging shows node negative disease, there is no need to go on any further at that age. But if they're 40 years old, the management algorithm is completely different. So you're right, you have to liaise closely with the colorectal surgeon to know what to do.
So
but
incomplete resection, not complete resection.
yeah, if you piecemeal and you have a margin that's dubious that you don't know whether you've completely excised it, that's why we go back and look at the depth of invasion. But yeah, that for the 88-year-old, yes, it's incomplete resection. But if you completely resect it, then you have to discuss the pathology at the meeting and work out whether they should have some adjuvant treatment like radiotherapy. But we tend to, for the very early cancers, we tend to take the whole thickness of the bowel wall and leave the mesorectum behind, especially if there's no negative disease on MRI.
Tarek, what are your thoughts?
I agree with what Diane said. I don't see any value in spot in the rectum. In fact, when you're doing the resection, it can be quite problematic because everything goes blue in the background. The extent of the margin is generally based on clinical criteria and MRI, which are much better than where you would put the spot, because we're often talking about a margin of a centimeter.
Yeah, again, this is the preference of our surgeon.
Yeah.
They've asked us specifically spot, but I agree.
Which comes to my next question, and perhaps a little bit more controversial as well, is TEMS, TEMIS versus ESD. Professor Sano, what happens in Japan if you, or Mohan, what happens in Japan or India if you've got a lesion in the rectum, which there's a suspicion that there is superficial cancer there? Would you proceed with ESDs, or would you subject the patient to a surgical type strategy?
If the lesion are diagnosed as early cancer, so we try to perform ESD at first. And recently, some prospective study was conducted. If the lesion is massive invasion, the patient receives ESD with chemotherapy after that. Yes, this is a prospectively yes or now ongoing.
Mohan,
we also have the same strategy of deep invasion, ESD followed by full histopathological assessment and followed by additional chemoradiotherapy.
Are you guys comfortable doing a full thickness rectal wall excision, or is that left up to the surgical team?
Yes, maybe we perform this using a knife or IT knife.
So there's this
including
yes. There's this layer. Increasing concept where we try to do an intramuscular dissection.
Yes.
An IMD, but obviously that's still kind of a new concept being pushed by certain institutions, including one of the chaps which was presented. His name is Moods. I think he's from Amsterdam.
But Raj, you also have to argue that if
Yes.
you are needing to take muscle, you're
Yes.
not dealing with an early colorectal neoplasm. You're
Yeah.
dealing with a cancer that has a high risk of nodal metastasis, and that patient needs to be surgically appropriate, offered surgical treatment or adjuvant chemorads. A full thickness resection does not change
No.
your staging. I think you
No.
can get the staging on an ESD.
Yeah, so full thickness again is pretty tricky in the rectum because of the adjacent structures. You know, if you want to sort of do an EFDR type strategy and you capture part of the bladder or the vagina, it's going to be a big problem. So
It's, like in an 88-year-old man with a low posterior T2 rectal cancer,
Yes.
full thickness excision may be an acceptable treatment option. And that, again, comes down to what the goals of care are for that individual patient. And I think where we struggle sometimes is the decision for ESD versus EMR versus TAMIS doesn't necessarily always account to all the various factors that
Yep.
we need to make a decision, and that's what makes it complicated.
Scott, do you have any comments?
No, we had a similar debate at the surgical conference a couple of weeks ago.
Yep.
And it goes, as you say, essentially it's beyond just the surgical technique, it's all those other factors that make it difficult.
Just another question to Professor Sano. So you did mention earlier on in your talk about the JNET classification and the 2B sort of JNET 2B lesions where the accuracy overall is about 60 to 70%, and then you use a dye or chromoendoscopy. Can you tell us what dye do you use and what's the concentration?
So we use a dye in Japan, so we use a crystal violet dye, 0.05%. Or in Australia, I think Methylene blue can you use? Okay, Methylene blue is I think enough.
Okay.
Yes.
And this question is for Bronte with regards to the hot current. Consenting patients, EMR, do you have a size limit? For instance, you see a 3 centimeter lesion, would you take the patient back, come back again another day, or do it right away?
Yeah. So if it's going to be a hot EMR more than 20 millimetres, I'd usually bring them back after I've appropriately consented them for a hot EMR. A cold EMR, I don't. I just resect without specific consent. It's part of the standard consent procedure.
Okay. All right. We'll try to move on now to the MDT session and see how we go. Just before that, we just got this update. So as you know, this session is being streamed live. So this was probably a couple of hours ago. And there are about 400, I guess, people who had a look at that stage. So it's good. So welcome again, anyone who's seeing this over the internet. So I'll just go on to sort of look at a few cases, and Andrew will assist us with some pathology. And please stop us at any time and ask any questions. So this is a lesion which is important. We didn't touch on this today, but this is a lesion which probably measures about maybe 2.5 to 3 centimeters. We can't see the entire lesion due to the cap, and there's a bit of bleeding on the surface. But one of the most important things when we describe lesions is to describe its morphology. So before we go on and have a look at the surface pattern and use all of those classifications, which you should remember by the time you leave today, we need to know something more basic, which is the Paris classification. So anyone would like to shout out what this is? 1, 2, 3, or 4? 2A. I thought there was a little bit of depression in the center. Yeah. So just for everyone's knowledge, the sessile lesions obviously is, it looks like the AS rock as we commonly describe it. And the height of that lesion is normally 2.5 millimeters above the surrounding area. Now, some people say, how do you assess the height? Normally it's eyeballing. You don't put a sort of biopsy forceps next to it to try to assess the height. But that's eyeballing and trying to sort of discern that. Flat lesions generally appear like this, so obviously they are kind of flat onto the surface itself. But when there's an area of depression, then the risk of submucosal invasion increases. All right, so we have to be a bit cautious and careful, and that's where some of these classifications come about to help us with therapeutics. Lesions which are depressed, or lesions which are bulky, 1S lesions have got a higher risk of submucosal invasion. And you can look at various papers which has been published with the ACE group. So that central area was reassessed with a neofocus mode, and that's why I was asking Professor Sano earlier on, can we use the neofocus mode to sort of call the JNET classification? So this is the area which was depressed and had a little bit of ooze or bleed. What do you think, Professor Sano?
Yes, this is the surface structure can be seen still. I'm sorry. Do you have a pointer? Okay. Yes. Thank you very much. Okay. Okay. So in the whitey object is a surface structure, and so some surface structure can be seen here, but in the center unclear. But anyway, so the when switch take a look at bezel features, some bezel thicker and some bezel thin, and some bezel stop to extend, also stop to extend. So fundamentally, so normal bezels capillary demarcate around each crypt, but the formation so destroyed. But we can still identify the irregular bezels and the irregular surface pattern, so that this classified as JNET 2B. Sorry.
Thankfully. I was a bit worried there. So Professor Sano hasn't seen all the slides, just for your information. So yes, it is. Yes,
that's
please.
That's taller than a biopsy forceps.
I think it also depends on the insufflation and how much of gas you have in there. Unfortunately, this is not a moving video, but I think what I tried to show is whether we can first look at the morphology and then try to look at that depressed area in greater detail. So you can actually see on the scope, the near focus mode is on, as well as what's called as the digital zoom function. So, as Professor Sano said, if you can print out that, what's that called, a poster, and put it in your rooms, it may help to differentiate and discern these sort of lesions. So based on that, we did not use crystal violet here. We basically performed an ESD, mainly because of the worry that there is some suggestion that there could be a submucosally invasive cancer in the center, although the mucosal imaging side of things was a JNET type 2B. So probably superficial submucosal invasion was a possibility, and at this instance our intent was to remove this in an en bloc fashion. I'll just go to this slide as well. Again, not moving videos, but we'll have videos later on. This is obviously a granular lesion, and it's got, as you can see, two nodules, one at the 3 o'clock and the other at the 9 o'clock position. So when we looked at this area here, you can probably call this as a JNET type 2A. Professor Sano? Yes, thank you. It's quite tough when you have the creator of the JNET classification sitting right there. But we've known each other for a long time, so I think we kind of clearly identified things together. what do you think this is? So this is on the nodule at the 9 o'clock side. Maybe you'll need the mic again. Okay. And
can I explain?
Please, please.
Okay. So take a look here, right side. As you can see, the white longitudinal so surface pattern can be seen, but the edge almost smooth, so that this part so classified Janet 2A, and so brownish bezel can be seen. But take a look here. This is a borderline, and you can see the so thicker corkscrew-like irregular bezels can be seen, and so the surface pattern, of course, the edge is not so just so irregular, showing so just irregular features, so branching, and the margin is quite irregular compared here. So I think this component diagnosed as adenomatous still, but here I think high grade or some invasive cancer slight, or anyway. So I think.
Yes, thank you.
Janet 2B.
Yes, and that's why it's important to ensure that when we take these lesions off, we don't sort of piecemeal this area here, which is abnormal. We have to be a bit careful looking at that. In this instance, what we did was a piecemeal EMR, but we basically got that nodule out separately in a separate pot, and you're right, that was a submucosal invasion. And this sort of lesion, you would immediately know that you're not gonna start putting in a submucosal lift and trying to take this off, doing all sorts of fancy things, because just by spending a bit more time, as we discussed yesterday, you're able to discern the surface pattern, and in this case, quite clearly, this is going to be a JNET type 3. There's total, the structure of the pits and the vascularity is totally destroyed. So we're going to take biopsies from there and tattoo it distally and leave it for the surgeons to remove. This is quite a nice... So that's Nat speaking, actually. Nat's in the audience. Sorry, Nat. I'll just go back because it was in video GIE, and this was one of our cases we did together. So this is obviously an SSA, and we took it off. And this is just an issue with tattoos, which you could see there, that the submucosa. And sometimes the muscle basically picks up this tattoo. But that was quite easily taken off with a cold snare. And then we have another sort of serrated lesion, which is close by over there, right? So it looks like a serrated lesion because it's next door to one other serrated lesion. And I guess the teaching is if there's one, there could be more, right? But you'll probably already noticed that there's something going on there, and you can see these concentric rings around this sort of serrated lesion, and as a bit of water is being put through, it's actually an inverted diverticulum. All right, so you don't want to take that off, especially with a hot snare, because that could lead to trouble. This is just another example, and Spiro touched on this earlier on with regards to the contentiousness of trying to take this off with a cold or a hot snare. This lesion was looked at. We did find a few areas which were sort of depressed, and it just pays a bit of time just studying it. So conventionally, I do use a cap. It's a transparent cap. It just allows us to look at the lesion in greater detail when we switch on the sort of magnification function, which is not being switched on now, but now it's switched on, as you can see there. The image becomes a bit blurred. And then because the cap tends to trap water, it actually sometimes gives us a good sort of magnification type capability. So just trying to wait until water fills in the cap to look at that depressed area, and you can clearly see this is going to be a JNET type 2A, right? It's regular, right? It's not irregular. That sort of, after spending probably about 30 to 45 seconds, we decided that this is going to come off cold, and I think this patient was on anticoagulants and whatnot. So I won't go through the technique, but Bronte and Spiro basically have given you tips and tricks on how to do this, and we tend to just do this sequentially using a thin wire snare and slowly sort of taking it off from one area and then just moving to the other. So the first cut is always disappointing, but you slowly move on, carefully look and keep going. You can see some remnant bits there which we need to sort out. But this can be easily done. I think this procedure took us about maybe 7 or 8 minutes, so it doesn't take very long once you get pretty good at it. And if you're not happy with certain areas, you can still go on and cut it as well if you're quite worried about the margins or within the actual segment itself. And all of the bits, as Spiro was saying, could be sucked in because they're fairly easy to suck in. They're all sitting just a little bit more distal to this lesion in a fluid pool a few centimeters away.
Raj, can I just ask you a question? I was
Sure.
going to ask Spiro before. Do you think there's any value to taking the suction button out to collect those pieces so they don't fragment as much?
No, I don't think so. They're reasonably soft, and I think there's been some data to suggest that the cold snare cuts more superficially compared to the hot snare. So they're not as stiff and hard as remnant from a hot snare. So they easily just get sucked into. And the best way to sort of suction them all in is to go and look for a fluid pool, which generally they just tend to sit there. Obviously, there are times when certain bits are not sucked in and they're sitting elsewhere.
There was a paper that looked at that question, and they did show that if you left the cap on, there was more fragmentation compared to cap off, button off. But I suppose the question is it clinically relevant if you're not concerned? Those if you are concerned, you want to try and avoid breaking it up anymore.
So this is just another video, and we'll come to pathology, but I think this is quite relevant with regards to a question from Afalabi earlier on. So this is a polyp within a diverticulum, and the issue here is that what would you do? So I think Spiro nicely summarized it by saying that with these sort of things, there's not much options, I suppose, other than using a full thickness resection device if you're capable, or if you think you can get it all within the FDR type device, failing which probably it's either continued monitoring, but what are you really monitoring, or surgery. So in this instance, we opted to do an FDR here. So an FDR is quite a clumsy device in a sense. It's quite large. The cap itself is pretty large, and obviously what happens is that the lesion can be either sucked into the cap, in this instance pulled into the cap with the forceps, and once we're happy that the entire lesion is within the cap, we release the device actually. So the idea is no suction because we are worried that it will capture a tissue outside the bubble. And then obviously the snare is only used after the clip has been deployed, not before. All right, so that's the end result of that lesion, which was actually an adenoma with low-grade dysplasia within a diverticulum. Yes, but that's mostly in the appendicular sort of region rather than, I suppose, diverticulum. So the risk is higher when one tends to remove stuff or polyps which are going into the appendicular orifice. Yes, please.
I've got one that's stuck down into the appendix, and the guy who can't have surgery. If you then just attempt cast something, at least cognitive function.
It really depends, I suppose. Has the patient had an appendectomy before?
Oh no, this isn't a sigmoid.
Oh, sigmoid diverticulum. So you could attempt this technique, or send the patient to somebody who can do that. Because
that one entails being sucked into the channel. Like you suck that one in.
So what we can do is use a grasping forceps, which comes with the company basically has a grasping forceps as well, and it's got a wide mouth. And what we can do is to capture that and pull it into the cap. Yeah, pull it into the cap and try to get a bit of normal loose type mucosa around so it gets into the cap. The cap's about 2.3 centimeters, if I'm not mistaken. But the actual volume within the cap itself is large. So any lesion between 2 to, in fact, going on to 3 centimeters can be pulled in, provided that there's a bit of looseness to that tissue. This is another lesion which is obviously flat, non-granular, and you can see the NBI image there of this lesion. And maybe there's some suggestion whether there's a little bit of depressed area in the center, but that depressed area is due to biopsies. And sometimes that is the issue we face. Lots of these lesions, sometimes they kind of pin down quite badly, either due to tattoos or due to repeated biopsies on that lesion, sometimes 10 or 15. And occasionally there are lesions such as this where there's an attempt at polypectomy. So we're just trying to sort of work out the proximal margin, as you can see there. Again, using just the NBI type magnification function. So Professor Sano, this would go for a Janet type 2A?
It's a border between the 2A to B. So yeah, here I think the area 2A, but this area the bezel pattern so slightly dot-like, and here is also. So it is very difficult to classify that so clearly, but yes, 2A border to B. But anyway, so intermucosal region, yes, this finding.
So we in this instance, we were quite convinced that this was a previous biopsy site, the center. It's kind of showing that the pit pattern is quite intact there. It's not distorted. Again, using a bit of an underwater technique to just try to see the center of that area there. So we were quite happy to take this off in a piecemeal fashion. So I know the debate is there, and there's this back and forth ESD, EMR, ESD, EMR in gastroenterology. But these sort of lesions, given that we've got previous biopsies, which show that it was just a tubular adenoma with low-grade dysplasia, but quite badly hammered in the center, we went on and removed it, and you can actually see why or how the fibrosis is in the center there. So this is purely because of biopsies. So this is quite a nice image of showing how bad the biopsies are. And I think to Bronte's point with regards to the duodenum, it's also quite interesting that if we take biopsies on the fold, it really pins it down even more somehow. and I'm not quite sure why, but that's what happens. You can actually kind of make out the fold here. Though it's an easy target, the fold is there and you just take it. This is a patient who has this sort of lesion in the rectum. So we've got quite a few surgeons here. It's bulky, and this is a sessile lesion, of course. What do you think, Bronte? What would the risk of submucosal invasion be here?
I think it's quite low, having submucosal invasion.
So given that this is in the rectum, surface pattern is in keeping with JNAT type 2A, would you be happy with a piecemeal EMR, or would you sort of try to take this off in one go?
Yeah, I mean, it's interesting. I did a rectal ESD last week, and it came back as low-grade dysplasia, and it took me probably about 4 times as long as it would have done to piecemeal. So, I mean, these are at high risk of the 1S component.
Yep.
I think it would depend on the patient, but I would take either approach. It's easier to do a piecemeal resection.
So we actually decided to do it in an en bloc fashion for this instance. So this is obviously fast forwarded. Okay, it's not that quick. Okay, but it is bulky, and given that access was reasonably easy in this instance, we decided to try to take this off in a single piece.
About a 20 spiral, which will have a 3-centimeter diameter en bloc resection.
No, I think this is probably larger than that. Yeah, sorry, you're talking about a snare?
Yes.
Yeah, maybe that could that could work. That could work, I think, if you get enough of the margins around. I find the issue with the larger snares are sometimes you cannot quite judge. You've taken it out in one go until after the fact, and then you suddenly find a little bit of a remnant bit at the edges.
Does that matter?
It doesn't, but sometimes in this sort of instances, if there is submucosally invasive cancer, if there is, then it just complicates the whole issue.
So Raj,
Yeah.
Sorry, you classified this as a JNET 2A?
Yes, the surface pattern was JNET 2A, but there's this, yeah, go ahead, your question.
No,
sorry.
no, so I was just trying to work out your rationale for going to ESD.
Yeah. So there's this concept of covert cancers, which basically suggests that even though the surface features look like they are in keeping with a benign lesion, there's a risk of submucosal invasion. And the risk of covert cancers increases the more distal the lesion is. If it's non-granular, these are the two main risks. So immaterial of the surface pattern, that risk increases if it's more distal, and that's
so
been...
That
yeah.
may be an argument for more ESD rather than EMR.
I think you have to be...
in the debate.
Yeah, I think you have to be selective. So for instance, if you've got a granular lesion which is flat like that in the rectum, then you can easily do a piecemeal EMR. So when it's...
5%, right?
Sorry?
Risk would be 5%.
Yeah.
Only. So 95% is a benign lesion.
Yes.
Yes. I mean, I would have personally done a piecemeal for this, but
I think you could probably unblock that with a large snare.
Sure.
And you can do other techniques as well. For instance, cutting around it and then using a snare as well, which is it's called a hybrid technique, if I'm not mistaken. So we did an en bloc ESD in this instance, these sort of lesions are actually, at least from an endoscopic perspective, quite easily seen. You can actually cut fiber by fiber as well, which I think increases our chances of being very specific and very accurate with regards to what's being done. And if a perforation occurs, then generally it's a small one, and we try to close the perforation maybe after the procedure if the patient is stable, or close it first and then keep on cutting. So in this instance, we had to close this area, although it's distal. I think this patient was on apixaban and needed to be on it. So we, for safe measure, we sort of easily closed that base with a few clips. Again, taking Spiro's earlier talk that if this was done cold, then we'll probably just leave it alone, provided obviously it's flat and benign. Oh, so Andrew.
Yes. So yes, we received this in one piece, and the lesion is benign. So it's neoplasm. You can see here the luminal aspect of the lesion, deep margin on 3 o'clock. We looking at the layers which are included, and here we have a little bit of submucosa. I looked very hard for muscle and didn't find any. It also is important to look into the muscularis mucosa, because on occasions you may find some surprise. They are naturally occurring lymphatics there. Now, as you can see, there are some villi and there are some tubules. So this is, maybe next slide. So this is tubulovillous architecture with low-grade dysplasia in predominant portion of the lesion. There were some foci of high-grade dysplasia. When we report focal high-grade dysplasia, this means it's predominantly low, only foci. And then we specify where the high-grade dysplasia is located. Is it in superficial compartment or close to the muscularis mucosa? Here, it was towards the surface. Grading of dysplasia, it's a little bit different in West and East. We pay more attention to architectural changes. In East, it's cytology. But in this area, I think we can agree that this is a focus of high-grade dysplasia. There was no breaching muscularis mucosa. Deep margin was clear. And no invasion anywhere.
So, Professor Sano, would this classify as some sort of low-grade intraepithelial neoplasia in Japan? Or how would you call this?
Yes. Yeah, I'm endoscopist, but previously I learned GI pathology for years. So that, yes, this part, Japanese pathologist, some foci of the high-grade dysplasia, and yeah, almost same as, yes, diagnosis. Your diagnosis.
Can I take opportunity to ask you a question? Are you still using term intramucosal adenocarcinoma? Because we do.
Yeah. We use intramucosal carcinoma. Yes, often. Or high-grade adenoma. So adenoma with a high-grade atypia. We use atypia, low-grade atypia. Yeah, and intramucosal cancer. Yes.
Thank you.
So this is just. I guess we've got probably about 5 minutes. This just. Trying to show, I suppose, a point of one of those blind spots. You know, as Cameron mentioned, there are a few blind spots in the colon. This is at the hepatic flexure. This polyp wasn't reported on index colonoscopy. We went on to resect another polyp in the sigmoid, and on completion colonoscopy prior to the resection, we actually found this lesion, which measures probably about maybe 6-7 centimeters in size, and you can actually kind of see how extensive it is just by slowly observing and moving around the edges with NBI. This is just showing again the pit pattern, which is in keeping with the JNET type 2A, in my opinion. You can see those dots on the left-hand side, 9 o'clock, and inferiorly where there's normal mucosa. And obviously, the margins can be clearly discerned, again, just by using the conventional scopes which we have these days. So quite an extensive lesion. We dealt with an area which was more abnormal lower down in this patient's bowel, and the patient is due to come back in a few weeks' time for a resection of this lesion. How would you address this, Bronte or Spiro?
I would take this out by hot EMR.
Hot EMR. Spiro?
Yeah,
Cold?
I mean, from what you've shown, there's nothing there that looks concerning to me for invasive cancer. It's a flat polyp. I think it would come out quite nicely with the cold EMR.
Yeah. So
it makes the point though, Raj,
yes.
that if this is a surveillance colonoscopy, which it was, that often the polyps that you find are in difficult spots.
Yep.
It sort of enhances the importance of knowing where the hotspots for missed lesions are. And
Yeah.
they're often in difficult spots to take out.
Yeah, and very true. So you can see, from the initial views, one would have probably quite easily missed it. So, and it's quite an extensive one. This is another lesion which was located in the sigmoid colon, and we obviously normally I just spend a bit of time just doing a bit of mucosal imaging before removing these lesions, trying to work out what exactly we're looking at. This looks like a JNET 2A. What do you think, Professor Sano?
Yeah, 2A.
Yeah. So we took it off in a piecemeal fashion, mainly because we felt that there was no areas which we were concerned of. But again, the issue arose in the central area there. That simply failed to lift that well. So we had to pin the scope or the snare down quite drastically actually, and pull it off, and then use what's called as hot avulsion technique, which Spiro has described as well, and to take off the central area, and then use the STSC to clean the edges as well as the central area further. Given that this was, I think this patient also was on anticoagulants, we just decided to close it. We didn't realize what the histology was until Andrew reported it. Andrew, you.
Right. So you can see there is a quite extensive extensively sampled submucosa with spaced smooth muscle fibers of muscularis mucosa. We always look in submucosa to assess fibrosis if present. That may cause us a lot of problems in interpretation. There is a little bit fibrosis here, but it's not causing us any troubles. Now, this is the epithelial neoplasm, and you can see there are some villi structures, and it's obviously dysplastic. However, if we look on higher power, you can see a few things here. First, a very different configuration of basal crypts. Some are horizontally orientated, and that's almost like a hockey stick. And on the surface, you can see remnants of residual serrated crypts. And also in these areas you can see some resemblance to hyperplastic polyp-like crypts. So this is sessile serrated lesion with dysplasia. Not uncommonly, on next slide, we will see that when dysplasia occurs in serrated lesions, the lesion actually acquires a little bit of villus architecture, and that's recognized phenomenon. So if you have only something like this in biopsy, it is probably okay if it's called villus elements, villus adenoma, but when we have the whole lesion for assessment and we look carefully for all components, then it is easier to say it's advanced serrated lesion. Now, the issue here is with grading dysplasia. It is not recommended to grade dysplasia. However, if we don't grade, then I will be getting phone calls from my colleagues asking, is it high or low grade? You tell me that. So anyway, we continue to grade this. I probably say that those advanced serrated lesions are a little bit under-recognized by pathologists in general. And then there is another question about terminology. You remember that initially it was sessile-serrated polyp, then it was changed to sessile-serrated adenoma to accommodate 5,000 gastroenterologists in the United States, and then finally it's WHO decided, European people decided to call it SSL, sessile-serrated lesion. And I see that Professor Sano also is using this new terminology.
Yeah, so I think right now it's SSL, so hopefully it doesn't change to SSN or something else. So anyway, we'll move on.
It is quite possible because there is literature criticizing that the name change.
Yeah. So this is probably the final slide because I realize Spiro has to leave soon. And this is a lesion which clearly is a cancer, right? It's an invasive cancer. There's this area of abnormality which Professor Sano initially mentioned. If they are flat, depressed areas, if they're more than 3 millimeters in size, then you for sure know that this is going to have submucosal invasion, probably beyond 1,000 micrometers. In this instance, the patient was really quite comorbid, actually. And given that this lesion was found, we had an MDT discussion, and the plan was to try to remove this using an ESD method in a single piece and try to see if we can get some sort of representation of what actually or how deep this lesion is. So it lifted well, and we didn't have much problems taking it off in a single piece. A bit of bleeding there, which was easily controlled. So final histology, Andrew.
Right. So this is resection specimen. You can see that this is quite a substantial lesion. It's invasive adenocarcinoma, low-grade PT1A going into submucosa. It's always very difficult to grade Kikuchi level when we don't have muscularis propria sampled. But here it's probably between 2 and 3, and we know what is the risk of nodal disease in Kikuchi 3, which is quite substantial. Next slides will show an additional feature, which is again quite underreported on in general. So this is vascular invasion. Pathologists have problems with recognizing large vessel invasion. We are much better with small vessel when you have empty space and you've got few cells there. But this is submucosal vascular invasion. Deep margin is in the right lower corner. So, of course, there is a question always about the risk of nodal disease. Currently, in daily practice, at least at our place, we rely on routine pathology assessment. However, we know that there are molecular findings which indicates more aggressive cause of the cancer. So microsatellite stable with BRAF mutation and so on. But currently, it is the size of the lesion. If it's more than 4 millimeters, it is and deeper than 2.5 of invasive component is associated with adverse risk. Other features I mentioned already about vascular invasion, tumor budding. If you think tumor budding is something new, probably not. It was reported more than 20 years ago by Jeremy Jia's group, and the first author was Hideki Ueno from Japan. So this is this lesion has a significant risk of nodal disease.
Okay, thanks, Andrew. I think with that last words, we'll call this session to a close. Just before we go, Spiro needs to catch a flight. So thank you very much, Spiro. Hopefully you can have this. Hopefully you can, don't drink that on the flight, I guess. And we've had a lot of help. In fact, tremendous help from Kate. So Kate, thank you again. Something for you as well. We'll just need to break, I guess, short break, and then we can come back for the last session. So thank you all, and safe travels, Kate and Spiro. Thank you.
Gastrointestinal Oncology in Osaka International Cancer Institute. His current research interests are application of new endoscopic imaging and therapeutic techniques in the management of gastrointestinal cancers and establishment of efficient training of advanced endoscopic procedures. He's published 220 articles and now serves as an associated editor of Endoscopy International Open, Digestive Endoscopy, and Annals of Gastroenterology. He's here to talk to us about training the future endoscopist. Thank you.
Thank you for kind introduction. So this time I'm talking about training using a simulator model. I don't know whether it is already popular in Australia, but still Japanese education, endoscopy education is like see one, do one, and teach one. So now I'm really a bit interested in this field. So basically, apprentice-based training is usually used in medical training. It is started in the early 20th century. And but because it is very quite old, so there is some issues like large variety in competency, and also quality of teaching is deeply depend on the expertise of supervising physicians, and also skill of supervised trainee. And also, actually Japan, we have a lot of senior doctor who wants to teach, but sometimes some country not so many doctor who is willing to teach. So, and also problem is a long procedure time with a small number of trainee. And if the number of trainer is small, a small number of trainees also number is small. And a large learning curve, and difficulty in finding opportunity to train and maintain the skill. So, and also of course, patient safety is also concern. So apprentice-based medicine learning, education, usually training is almost performed or undergone during the clinical practice. So sometimes a bit difficult to distinguish what is practice and what is training. And also at that time, doctors and young endoscopists, it's rushed by supervisor, sometimes rushed by supervisor or sometimes nurses. So no time to deep consideration. And as a result, someone complete the enough competency, achieve competency, but some are not. But if we use simulator for the medical education, he or she can perform deliberate practice using simulator under safety environment. But even though we use simulator, someone get achievement, but someone cannot achieve the enough competency. However, when we use the simulator, we can repeat the deliberate practice again and again. That is one of the merit of this education model. So basically, any artist or sportsman always practice again and again for a long time. But sometimes people think that the repeated practice makes perfect, but practice only makes permanent. Practice with feedback makes perfect. Feedback means during the procedure, how to do or what is the issue and how to improve the procedure. We have to always consider such things during the practice. So simulator model can be performed under such kind of, can perform a deliberate practice under safety environment. So to learn ESD, like such kind of very complicated advanced endoscopy procedure, good simulator-based learning model or curriculum is desired. So previously, when we attend or when we conduct the hands-on training, usually we teach the ESD step according to a time sequence, such as marking or injection under mucosal incision or submucosal dissection. But to make the teaching more efficient, I reconstructed the procedure into maneuver base. It means region or scope positioning, and the maneuver planning, and device maneuvering, and ESE endoscopic surgical unit setting and application. Because sometimes, basically, mucosal incision and the submucosal dissection is a really different procedure. But when we really consider the actual maneuver of the movement, it is almost the same. It means when we cut the mucosa, vertical direction is a bit more than other frontal or lateral movement. But when we perform submucosal dissection, probably frontal movement or frontal power is more than the other movement. So if we can really learn how to maneuver or how to move the device for this three-dimensional dissection, we just change the proportion of the movement so that we can achieve the different maneuver in the same kind of movement. And also, when we described the procedure in these fragments, we found that some belongs to knowledge concept, knowledge domain, like how to get a good position and how to cut the tissue, or how to appropriately set the ESE unit. That is a kind of a knowledge domain. And then how to really move the scope or device to get a good position, and how to maneuver the device according to planned line. That is almost like a technical skill domain. So I think we can divide it, each learning point can be divided into two main concepts. So previously, usually when we attend a hands-on course, we just learn everything, including knowledge and skill during the hands-on course. But probably knowledge part can be divided into different time. For example, before coming to a hands-on course, we can deliver the online contents and or some information to the participants, and then so that they can practice or learn knowledge point before participation to the real hands-on seminar, and so that we can really spend full time for technical learning. So, for example, I want to explain about maneuver planning. So, in this case, where do you want to cut, or where do you plan to cut? So, usually in the center of the line, because this central part has the strongest tension from the both mucosa. So if we apply the spark into this line, tissue is spontaneously separated efficiently. So not right side and not left side. It's better to dissect the tissue in the middle line of the mucosa. And how about this situation? So you can see the muscularis propria muscle here. So not the center. In this situation, if we can see the muscle, not the center of the submucosa, we usually cut this part, this line, deepest submucosa. Usually we touch the mucosa on the sheath, which is isolated from the isolated by ceramic tip, and then about the half diameter of the distance we keep dissection, so that we can dissect the plane, even depth of the plane like this, evenly. So like this. So always touch to stabilize the device, and then dissect the plane in the same depth of the submucosa. And another reason why we dissect the deep layer of the submucosa is that usually submucosal vessel is ramified from the bottom to the mucosal surface. So if we dissect the shallow submucosa, you may cause many oozing, bleeding. However, in a deeper submucosa, vessel is less, unless you don't cut the thick penetrating vessel. So that is also a reason why we dissect the deep submucosa. So for example, sometimes stomach, gastric corpus, or proximal colon, usually superficial submucosa contain many fatty tissue. So at that time, very difficult to dissect this shallow submucosa. So we have to dissect the deep submucosa like this. And in case of we cannot see the surface of muscle, how we can determine the dissection line or plane? Usually here. Usually submucosal fiber exists like a vertical direction. So 90 degree perpendicular to the fiber is an appropriate direction for the dissection. So not from here to here. We try to keep the same dissection plane perpendicular to the submucosal fiber like this, so that we can keep the same dissection plane to the muscle. So as I explained, usually cutting or dissection line is predefined before the movement of device based on anatomical finding of the submucosal tissue. Probably usually surgeon always learn local anatomy before cutting the tissue. So something similar is concept can be available for endoscopists to dissect the tissue. And then after making a planning, we correctly or precisely maneuver the device according to the predefined line. So at this time, we have to practice how to accurately control the device. So as I mentioned, but sometimes teacher just teach cut right side or push more or press down or something. But the most important thing is not what to do, how to do. So to press, to get the frontal movement, we usually push the scope or sometimes push the device through the working channel. And for vertical direction power, we achieve using a large wheel upside down, up and down, up or down. And for lateral movement, we usually use scope torque to using a lift or sometimes right hand torque holding a scope. Or sometimes we use a small wheel to right or left deflection using a small wheel knob. And to practice the accuracy of such movement, we make a video like this and then explain how to control the movement, how to control the scope to obtain such kind of direction movement. And to practice this maneuver, I developed a kind of like a paper ball simulator. And using a pencil lead or some sheath of the device and a paper ball. I think it is better to use commonly available things so that everyone can make it easily by themselves. And another concept why we use pencil is usually we use the monopolar device to cut the tissue. So device should be contacted to the tissue to conduct the electricity from the device to the tissue. If sometimes beginner hook the tissue and then detach the device from the tissue so that the electricity doesn't conduct, so we cannot cut the tissue continuously. So it's better to be contact always and then move along the predefined dissection line. It's somewhat similar to drawing a line with a pencil or a pen. So for example, this is our junior colleague, but I think he's good skill, but still bit unstable. Line is bit unstable. And then maybe bit experience doctor when he perform, we can really follow the line accordingly. And after that, we can evaluate a deviation from the intended line and the time of the procedure. And then a young doctor can practice again and again. And this is just a dry model to learn how to maneuver the device or scope. But recently, we have a kind of wet type simulator model to learn how to deliver the electricity from using a surgical unit. And also, of course, if you have a animal training center, we can use the animal model. In this case, we can really learn how to manage the bleeding or everything and how to change the electric mode. We can learn something like that. So usually, according to my experience, sometimes very different level of participants is come to the hands-on course. But I think for very beginner, it's better to use just dry model so that they can learn device maneuvering. And then they can step up, after some certain expertise, they can step up to a wet model to learn efficient electrical delivery. And then before embarkment of the clinical practice, they can perform animal model training. So not necessary to always prepare animal labo. Maybe you just make this and then you can practice in your hospital again and again. So maybe in the future, we would like to make such kind of model and curriculum. So to learn ESD efficiently, implementation of simulator-based learning is useful, I think. And further development of good simulator model and curriculum is expected. Thank you.
We have time for a couple of questions. Anyone for any questions? If I may ask you a question, have you taken many of your students through this model through to completion?
Still not yet, not so many. Usually we have three or four residents a year. So at the beginning of the practice, we always try to use it. But still maybe less than 5.
5, I see. Okay, thank you. Any other questions? If not, we'll move on to the next speaker. Thank you very much.
Thank you.
Okay, I would like to invite Dr. Ramchandani back to the podium to give us a talk on third space endoscopy. Where are we heading? Thanks.
Thank you, Chairperson. And again, I think last but not the least, this is an era of third space endoscopy where we are moving away from the luminal part and also moving away from the deliberately creating a hole in the stomach and going into the peritoneum to a potential space which is known as the submucosal space. And this is exactly what third space is. This allows us to do the scopy in the potential space which is between the mucosa and the muscle, and help us to do certain surgeries which were up till now treated by the surgeons. And this is not only known as third space endoscopy, also known as submucosal endoscopy or submucosal endoscopic surgery. So it all began with Professor Sumiyama's paper, where he described how to go into the submucosal space and also be able to cut close the mucosal defect, because up till now the gut wall was like treated as a single organ, and if there is a disease even limited to the muscle like achalasia will require either a removal of this completely or go from peritoneal side and cut the muscle, or if the disease in the mucosa, it requires organ removal. But with the advent of this technology, where a mucosal defect is created and selectively mucosa is cut, and then there is a potential space which is expanded by saline, and you can enter into the submucosa, and once you create a safety valve mechanism where the mucosa is deficient but muscle is intact, and the layer where mucosa and muscle both are intact, and subsequently you can go and do intramural or even transmural surgeries, and even coming back, and you can seal off this mucosal defect with the hemoclips. And that made this procedure very attractive for endoscopists who are not surgeons, can still be able to do such type of surgery transorally and also able to close this defect without worrying about perforations. And this is what exactly has been achieved by third space endoscopy, where a mucosa is separated from the muscle layer, and we can create a working environment in the submucosal space. And that led us to do many endoscopic procedures, which allows us to do separation of this gut wall from the mucosa and muscle, and selectively treat the disease which are localized to one particular layer. Like even the disease is early cancer, you can do tunneling, separate the mucosa, get rid of the mucosa, keep the muscle intact, or if the disease is in the muscle, remove the muscle, keep the mucosa intact, and each layer is strong enough to act as a barrier. And so this is the digestive endoscopy tunnel technique, and predominantly known as third space endoscopy, which led to so many of the disorder which can be treated, starting from achalasia cardia, which is known as an esophageal poem, the gastroparesis, a subset of patients who have predominantly pyloric spasm as the feature, can be treated by gastric poem. Many subepithelial tumors or esophageal diverticulum can be removed. Zenker's diverticulum treatment has evolved from directly cutting the cricopharyngeal muscle to selectively going inside the mucosa and doing the same procedure with much more safety profile. We are able to treat long esophageal strictures and also treating Hirschsprung disease. So these are some of the things which can be done. This is the basic procedure where one has to learn from the esophagus, where a mucosal entry is created, and then subsequently the submucosal dissection, the loose areolar tissue which runs between the mucosa and muscle is separated, and then once you achieve the separation, you can selectively cut the muscle which is spastic, and we can get rid of this spastic muscle, and then subsequently close this mucosal entry site safely by the instruments which are available on our routine clinical practice. That is, we do not have to worry about some full thickness closing devices, and this brought this type of endoscopic procedure very attractive option for even for the patient who opt for scarless surgeries, and we can do the patient can go home either same day or next day home. The evolution of the POEM is also, it's almost now more than 10 years procedures, and gradually we are now having long-term data on POEM efficacy for more than 10 years. And also we learned how the reflux can be controlled in POEM by not only doing procedures more carefully and also if required we can go endoscopic fundoplication. The 1-year data was there and also has been shown to be very effective in children, because children, we do not have dedicated balloons for achalasia cardia, and the children around 3 to 5 years can also be easily treated by this. And it has taken over all the conventional treatments, including the balloon dilatation, or even has been shown to be non-inferior to the existing standard of care, that is laparoscopic myotomy. And after 2 years also the efficacy remains same as compared to lap-Haller's myotomy. There are many more things coming up. We started probing about what is anterior POEM, what is posterior POEM. Anterior is POEM when you cut the muscle anteriorly at around 1 to 2 o'clock position, while posterior POEM is when you cut the muscle posteriorly at 5 o'clock position. So what is the difference? And ultimately, first of all, we showed that the POEM in the posterior fashion has associated with more reflux. Subsequent studies have not shown that, but we realized that it is because of cutting the sling fibers posteriorly, which may cause more reflux. Subsequently, we also worked upon what if you're dealing with type 2 achalasia cardia. Type 3 achalasia cardia is more of spastic disorder where we need to have a long cut, but type 2 achalasia cardia is in initial stages, and the patients whom we have type 2 achalasia cardia, it's totally unnecessary to cut long muscle, even 6 centimeter, and we showed that even if you cut 3 centimeter muscle, which will not only shorten the procedure, but also may help in esophageal emptying, because there is some functioning of the muscle intact, and totally paralyzing these muscle is totally unnecessary. And we showed that a short myotomy of 3 centimeter in esophagus was equal to the long myotomy of 6 to 8 centimeter. Subsequently, we also had now devised how to treat these spastic disorders. These spastic esophageal disorders have needs a very long length of myotomy, and I was talking to Bronte yesterday, and she also agreed that by the manometry we can assess by what length we have to cut the muscle, because the POEM allows us to do as high as possible in the esophagus as compared to lap-Haller's myotomy, where we are restricted in the length. And these spastic disorders are truly problematic for the patient, where these spastic muscles cause severe pain, dysphagia, and if you have a proper analysis of the length of myotomy which you want to achieve, can be achieved with the help of manometry and also assessing the spastic segments on timed barium swallow. And by this, we are able to achieve now around 20 to 26 myotomy, and these patients get a lot of relief. So gradually this procedure has evolved from just being POEM to anterior versus posterior, short versus long, and also the reflux. Now reflux was the major criticism for POEM, because you are not doing any laparoscopic fundoplication, but subsequently there was much literature coming how to preserve this sling fibers. These sling fibers are different from the clasp fibers. These sling fibers are responsible for angle of phase, and it is totally unnecessary to cut these sling fibers, because they do not contribute to the spastic nature of the LES, but they help as an anti-reflux mechanism. So it is now easy to identify where are sling fibers and where are clasp fibers. And this is known as the vessel penetrating sign, and anything on the left towards greater curve or sling fibers or anything on the right of these penetrating vessels are glass fibers. And now we are selectively cutting the muscle onto the right of these sling fibers, that is towards the lesser curve, and the reflux has significantly come down. And also we have realized cutting more into the stomach is totally unnecessary. If you cut more than 4 centimeters in stomach, it is going to cause reflux. So it is important for us to not only go to the direction of the lesser curve, but to cut less in the stomach to minimize the reflux. So we are learning how to minimize reflux, which was the major criticism. Not only that, now the endoscopic fundoplication is being attempted, but the instrument available are not that robust. We still use the loop and clip method, where we go into the peritoneum like this after doing an anterior myotomy, keep on dissecting towards anteriorly, make a hole, deliberate hole in the peritoneum like this, and then we enter towards the fundus of the stomach, which is here, and we make a run where we see whether a pulling of that fundus part is causing adequate fundoplication or not. And then once we mark our area, we load our loop onto the scope and go into the same spot and apply the clip onto the distal end of the open loop, and then 4 clips are applied there, and subsequently onto the right cut margin of the myotomy in the esophagus, the proximal end of the open loop is applied, and then this loop is closed, bringing the fundus towards the tunnel side and creating a fundoplication. So this is the endoscopic fundoplication being done now. Mostly to patients we are offering upfront who really are more prone, like some people who have young people who wants very worried about reflux. They also are included sometimes, but we do not have a firm protocol because we still believe that we are waiting for some of the robust technology to allow us to do a serosa to serosa approximation, like full thickness suturing device, which can allow this fundoplication to stay there for long, but still we are waiting for some of the instrument to come. A monopolar device also poses some problems in a closed tunnel because there is a lot of collateral damage. If you are not careful enough, you may cause mucosal burns, you can cause delayed perforations, because these monopolar currents travel a lot and are requiring a lot of voltage for the cautery to work. But now we have more bipolar device, which is nothing but a radiofrequency ablation cutting and integrated device for coagulation. So that reduces number of exchange which can be done in the tunnel. This is the radiofrequency cutting, and then there is a protective hull behind. You can see this is the protective hull which rests on the muscle, and then you can cut on either side to create a tunnel. This device was as also you can see there is a coagulation being done over there. It required 10 seconds, and the same device you can do mucosal cutting, coagulation, as well as the myotomy. And with a bipolar device, much less collateral damage and much less post-operative pain has been shown with this. This was about POEM, and then subsequently we saw the POEM being extended to the stomach, treating the pyloric spastic lesions when there is a gastroparesis, and there are certain patients, the choice of patient is difficult. The procedure remains same, very simple. You have to come 1 to 5 centimeter proximal to the pylorus, and then create a same mucosal bulge, and then incision, and then go underneath the mucosa and reach to the pyloric ring, and then cut that muscle. So this is the end point of this tunneling. We need not to go into the duodenum, and once you reach to this ring, you have to create a 1 to 2 centimeter maximum myotomy, which releases this pylorus spasm and is effective in around 60 to 70% of patients who have gastroparesis, irrespective of the etiology. Even the diabetic gastroparesis have been shown to show the response. But the choice of patient, we have to, a lot of research is required how to choose proper patient who will respond to gastric poem. The third space endoscopy also been utilized to remove the intramural tumors, even if they are arising from the muscle layer. They can be either removed by a method known as stir, where you need to create a tunnel before, like a poem, where you need to enter into the submucosal space proximal to the tumor, and then expose the tumor, and then keep on dissecting between the muscle layer and the tumor, and muscle layer and the mucosa. And once you completely free this tumor, you can remove this full tumor en bloc, and yet you can see this tumor is being removed. After that, you can go back into the tunnel to see whether there is any bleeding or any residual tumor. This completely removed, and this tunnel can be closed. Similarly, the tumors which are not separable from mucosa, they are transmural, especially duodenal neuroendocrine tumors, can now also be removed by endoscopic full thickness resection. That is the exposed technique, where you are deliberately creating a complete removal and creating a defect in the muscle layer, but you are ready with some of the closure device known as, again, which we showed on the loop and clip devices, which allows us to do serosa to serosa approximately. The full thickness closure is achieved once you are catching both the muscle layer and mucosa and sort of garlanding this open loop and then closing it like a purse string a suture, and then you can achieve full thickness closure. So you may avoid certain major surgeries. The Zenker's diverticulum is the one which has also been modified once this third space endoscopy was introduced in conventional way. In the Zenker's diverticulum, there is a diverticular lumen, there is an esophageal lumen, and you just need to cut this septum. But the problem here was how deep to cut. If you undercut, you may cause recurrence. If you overcut, you may cause perforation. But if you cut under a mucosal cover, like is being done in this, you can even overcut, but yet not cause perforation because you are under a tunnel. And you can see the mucosal incision, exposure of this septum. On this side is the esophageal lumen, on this side is the diverticular lumen, and you keep on cutting to the proximal esophagus and create a good cricopharyngeal myotomy, and then subsequently this lesions, this mucosal entry site can be closed. And this is about the Zenker's diverticulum. We find a lot of patients who have corrosive strictures because of the caustic injuries, where we are not with a complete obstruction of the esophageal lumen. In such cases, a retrograde scope is passed through the peg tube, and then based on that, the guide by this, we come from the oral route and then create a submucosal tunneling, and through this fibrous scar, we keep on going down till we pass a wire which is grabbed by this scope, and a new lumen is formed by passing a fully covered stent. Subsequently, this fully covered stent is removed, and patient is kept on dilatation program every 2 weeks till we achieve complete dilatations. Similarly, the third space endoscopy has been utilized in treating Hirschsprung disease, especially those patients who have short aganglionic segment, and a complete dilated colon. This aganglionic segment is mapped by the previous biopsies, where suction biopsies are done, and along with the pathologist, we work with them. You can see this is the biopsy mapping. This is the scars. This is the dilated sigmoid or proximal rectum. And after knowing which is the ganglionic, which is aganglionic segment, a mucosal entry is created at the anorectal junction. In a transverse mucosal incision is made, and then subsequently the scope is passed into the tunnel, separating the mucosa from the muscle layer, getting rid of all these vessels in a conventional way like poem, and then keep on going proximally till we go to the desired length as has been previously mapped. And then once we reach to the proper depth, this aganglionic segment, which is spastic, is completely cut. As we come down, we do selective circular myotomy at the anorectal junction. And then once we have reached to the anorectal junction, we subsequently close this incision. And this was described by Dr. Amol Bapai from India, and he has a lot of experience. We also have done few cases, and it does work, and the dilatation and the symptomatic response is very good. So with this, this third space endoscopy has brought a new era where we can do many things, including removal of the cancers like ESDs, or reshaping the anatomy like myotomies. We can do placement of stimulating or monitoring devices. We can harvest tissues. We can do removal of intramural lesions. We can take biopsies of nerve and muscle. So where we are heading, I think we have just made this video. This is for you to, we hope that someday will come when third space will be like much more easy. Already we have a capsule who have a robotic arms can be delivered. This is just a futuristic approach made from some of our engineers, and you can see here there is a mucosal. You need not to have a scope. Maybe 30 years down the line, we'll have this type of realistic view. This is just for a fun. You can see this caterpillar is going right into the tunnel, creating separation of the mucosa from the muscle layer, and then cutting the muscle layer, and then coming out, and then sealing off this mucosal incision. This may be the future. Let us see if it materializes. We have already devices like this. It's time maybe the test for this type of technology. So with this, I thank you for your patient hearing, and will be happy to answer any questions.
So we've probably got time for a couple of brief questions for Professor Rem Chandani. Anyone got any questions?
Sorry, are you using that technique for gastric cyst as well?
Yes. So there is a size difference. For esophageal lesion, which are more leiomyomas, we are more liberal in size, because even if you cut piecemeal, they are oncological okay. But in cyst, if you break the capsule of the tumor, it's upstaging of the tumor. So the size less than 3 centimeters is the cutoff for gastric cyst. For esophagus, it is the 5 centimeter subepithelial tumor, which can be easily removed.
Any other questions? Okay, we might move on to Raj, who's giving us a talk on AI. Raj, thanks for giving us a talk on artificial intelligence. Will it change our practice in the future? Thanks, Raj.
Thanks, Gary. And how's everyone feeling? I think everybody's tired. So we not only have to worry about AI, I guess, we have to also worry about worms. Looks like it. This was an article a few days ago, I think an editorial on the future of AI and how it's threatening humans actually. I think you would have heard that there are quite a few number of AI experts around the world. I think in the hundreds have signed this so-called petition warning humans that AI is coming and may lead to the death of humans and not AI. So I'll just go through a brief timeline of how this all started. Not very long ago actually, about probably 60, 70 years ago. AI was apparently born in 1955. There was somewhat of a winter during the 60s, 70s and 80s, and then I think a lot of you or some of you may remember that this system called Deep Blue played the chess champion Garry Kasparov. Some of us here are old enough, but a lot of you I know are born after this, 1997. But Deep Blue beat Garry Kasparov 25 years ago. In 2011, we have Siri coming in to play, and then something called Watson, which was apparently a failure by IBM. And then more recently, this system called AlphaGo, which beat the Go champion. So apparently Go is quite complex and much more difficult than playing chess. But the system has managed to crack this as well. So AI in endoscopy have got a few different connotations. You can see there's machine learning, there's sort of speech recognition, text to speech or speech to text. A lot of us and a lot of this where we are involved with endoscopy per se is with image recognition. And there's other things like natural language processing as well as robotics and whatnot. So the number of publications has increased dramatically or drastically. As you can see there in 2020, it just jumped up many folds, and there's just more and more and more of AI research coming in. It all started from an endoscopy perspective, as I mentioned, with image recognition and mostly with colorectal polyps. So I'll just try to be quick and brief and try to discuss some of the interests. And as I said, this is moving so quickly that almost every day you see a new publication coming up with AI in endoscopy. So in Barrett's esophagus, you would have seen this slide before. It's quite difficult to kind of make out where an area which was biopsied and has come back as a cancer. As you can see, this could be an area which probably showed the cancer, and I showed this slide yesterday as well. But obviously that's just a previous biopsy site. So we went on looking and we found this area which has got abnormal pit pattern and vasculature in keeping with an early Barrett's cancer. But perhaps we don't need to rely on the human eye anymore. And AI can help us with sort of picking these things up. One of our PhD students, Jin Tan, together with my colleague Asif and a few of our other collaborators have looked at a systematic review and meta-analysis looking at what is the present state of play with AI in Barrett's esophagus. So there are quite a few groups, but generally they tend to publish things time and again. And as you can see here, this group has published 3 papers, and the D group has published another 2. But all in all, it shows that there is pretty high sensitivity and specificity with these AI type models. But all of these generally were retrospective type studies, so studies which looked at images in the past. We're trying to sort of see if we can prospectively look at something not too dissimilar, given that we've got a huge repository of images and videos with more than 500 patients which have been collected over the last 12 years or so. So this is preliminary data which we are trying to publish, and I think Jin and Dilip, who's in the audience here, is trying to write this up, looking at a training and testing set, NBI, white light, multimodal. These are just some of the videos which we have used, and you can see the dysplasia sort of thing changing there, mainly because the AI system has picked up that this to the AI system looks dysplastic, like a dysplastic nodule. All right, so that that qualification, if you may, can change from non-dysplasia to dysplasia, but this is a very preliminary model looking at real-time videos, though, of patients who have dysplasia or do not have dysplasia. This is just a similar sort of representation, but looking at an NBI model, and you can see that the AI system is calling this dysplastic. It's called this as non-dysplastic initially, and then slowly as it looks at things with this so-called transformer model, it's basically telling us that this area here is dysplastic. So certainly a lot of interesting work, and it will come a point, I think, from an endoscopy perspective, although we are holding the scopes, we're going to rely more and more on these sort of modalities to tell us what is dysplastic and what is not. As you can see that area is dysplastic in the Barrett segment. This is just the other modules, sort of looking at again, AI models. So we found fairly high sensitivities and specificities. I won't go and bore you with the details of different modules using transformer and what's called as ResNet. And it's certainly an interesting space. With gastric cancer, a lot of work has been done in Japan and also in China. And these systems are quite extraordinary. Look at the accuracy rates here of more than 95% in some instances. And they look at invasion depth as well. I quite like this series of videos because it actually shows a system called EndoAngel ME. And it basically looks at erosions. So it may make the lecture which we heard yesterday moot if this sort of systems can tell us which erosions are non-dysplastic, the top two, versus cancer, which is in the bottom video. So you can see that the system is telling that a carcinoma is detected. So pretty accurate in contrast to what looks like an erosion here, and of course here in the right-hand sort of slide, but certainly there was nothing suspicious from an AI perspective. Blind spot monitoring is quite extraordinary feat. So this is a group from China which looked at a system called Y-Sense and versus controls, and they look at blind spot rates. So you can see a cartoon slowly developing there, basically telling the endoscopists that they have gone, obviously in the esophagus, we know that, but it kind of shows as they're progressing which areas were not seen. So reminding the endoscopists that although this is the duodenum, the fundus needs to be looked at, maybe a bit of the cardia. So on the way out, perhaps don't forget that. So as the endoscopist is retroflexing and looking, you can see that the sort of obviously stomach is being created there on the left-hand side. Quite a clever technology actually, and just prevents blind spots from being missed, I suppose, in a sense. Still, there's a little area not seen there, and as the endoscopist is pulling the scope back, you can see that completes the kind of visual examination at least. So in colonoscopy, there's of course this CADE. So CADE is what's called as detection mode, and characterization mode is called CADX, and the QI mode is called CADQ. So lots of mnemonics and different terminologies. In a nutshell, again, as I said, there are lots of studies coming up. This is a systematic review and meta-analysis of 5 studies, which was published 2 years ago, looking at ADRs. I know in Australia we've got fairly high ADRs, but in this paper they looked at an improvement which is about 12%, 25% to 37% on these 5 studies. Also, they looked at not only diminutive polyps, because we know these systems can probably pick up smaller polyps, but interestingly, there was also a change with larger polyps, which is quite interesting. Control 6% CADE, CAD detection sort of module at 11%. It didn't address sessile serrated lesions, and that is one of the issues as well. And there's a time lag delay with the older modules, but increasingly we're seeing that even that is not a problem anymore. 50 millisecond delay is not a problem anymore because the computers are being produced quick. I mean, the programs are much more quicker, the computers are much more stronger, has higher power of and capability of generating and deciphering these images before sometimes we can even notice things. This is one of the earlier modules, and Mori, Yuichi Mori, who will be visiting Australia soon, has basically spearheaded this endocytoscopy type model. And you can see that the system basically is telling us what's happening. It's got also a funny sound. Adenoma sounds quite pleasant actually, in contrast to probably a cancer. Yeah, so non-neoplastic, these hyperplastic polyps, you saw similar types of images which Professor Sano showed earlier on. So these are obviously non-neoplastic. So what's the beef in this? CADX, these are some of the newer studies looking at more than 1,000 patients. So in essence, they found actually there's no difference between so-called experts, endoscopies alone, and AI-assisted sort of algorithms, 88% versus 88% with the cat-eye system. With the endobrain system, again, not too dissimilar, 88 to 90%. But what's interesting is the polyps which were called with high confidence was much higher with the AI system compared to the endoscopies. So maybe that's the plus point. So it's able to basically predict histology in a larger number of polyps compared to the endoscopies, who are experts, by the way. Some issues is that it may not be as impressive in picking up adenomas in high adenoma detectors. For instance, like Cameron may have an ADR of 70%. So will it become 71%? We really don't know. There's this false positive rate as well, and what's called as AI fatigue. So this is quite interesting. These two experts look at 40 videos, and they found that there were 27 false positive AI pickups per colonoscopy. And sometimes it's the bowel wall, sometimes it's the bowel content. When they looked at the videos, they were able to resolve things just by looking. Oh, that looks like a diverticulum, it's not a polyp. But in about 23% of those total videos, they needed quite a bit of time working out, oh, is this really a polyp? Or we can't quite make sense out of it. So that's one of the issues. And when it keeps beeping to you, for instance, like, what's the time now? 3:30, and everyone's tired, you'll just switch it off and finish off the colonoscopy and go home, right? So this is just an example of, obviously we know that's not a polyp. The AI is picking up villi in the terminal ileum, and then the appendicular orifice. Obviously you don't want to put a snare there and take it off. This actually a scar from a previous EMR resection site. So the AI is trying to say there could be a polyp there, but actually it's not, and we don't want to remove it, of course. We're just evaluating the base and working it out that it's just a benign scar, and that's using NBI with a bit of magnification. So we don't quite need to do anything other than probably taking a couple of biopsies to prove that. But it also picks up the snare, as you can see, right? So that square. So that kind of obviously after a while may irritate people. So we need to differentiate polyps, and we know it's not kind of black and white. We know it's not just remove the polyp or send it for surgery or something, but there are different types of polyps, and we have to try to build an algorithm to look at this. We've tried to sort of do this as well with a few studies, and we found that very quickly accuracy rates were pretty good using a 5-class polyp classification, which was in GI endoscopy, with accuracy of about 94%. So false negative is the other issue. So AI is on here, target mode, and you can see that it's not picking up this lesion. Obviously, you're not going to miss this, right? If you do, then maybe your attention was elsewhere. But these sort of things can happen, and you never know that they could end up being neuroendocrine type lesions as well. So it's quite important to understand that there's false positive and false negative. I mean, we certainly would be able to use AI, I'm sure, with scar evaluations and other sort of visual-like pathologies, but we really need what's called as the ground truth, which I will come to in greater detail. It can now tell us the bowel prep score, Boston bowel prep score, and where cecum is reached. So if, it obviously, it's picking up something. It may be picking up actually this interestingly, maybe it's picking up this sort of question mark sign there, which is there on this device. So who knows, but it can certainly pick not only the cecum, the Boston bowel prep score, obviously large polyps like this is quite possible. It can assess inflammation in IBD, and I won't bore you with the details. Can also sometimes work at natural language processing. And this 12,000 reports, I think, were read within probably 15 to 30 seconds, all right? And it shows that the accuracy rates are similar to a manual report, which would have taken people, I don't know, months maybe to sort of look or sieve through this. So all that may occur soon. AI will probably write our reports, which is not a bad thing, I suppose. You'd be typing away and you realize as soon as your scope is out, AI generates a report for you. So there's issues. Again, this is called the garbage in, garbage out theory. I think some of you may have heard about this. So your data is rubbish, but the model is great. The result is rubbish. The other way around, data is fantastic. Model is rubbish, result is rubbish. So you need everything to sort of work well. So this is quite interesting, the so-called ground truth. So if you take a 15-minute endoscopic procedure with 30 high-definition frames per second, there are 27,000 images, all right, which collectively gets lumped up into, I suppose, a 15-minute video. So what is actually correct and what is not, it's very difficult to say with all of these devices which we have, who determines this. So you need somebody to annotate these polyps, to tell the AI system this is the IC valve and this how a stool looks like, that sort of thing, this how a snare looks like. So somebody needs to do that, and it's gonna be interesting to know who that somebody is and whether there's some sort of inter and intra reliability measures or variations, as well as the patient population, and whether this training data actually match the intended clinical use. So there are lots of databases as well out there, free databases. You can use your own repository. That's what we've been doing for some time, but that's also subject to bias. And then there's trust and medico-legal implications. This is just an algorithm which basically looks at endoscopies and the CAD sort of agreeing that this polyp is TA, and then we sort of putting a confidence strategy into it. But there are times when you think it's an adenoma, CAD says it's hyperplastic. You are highly confident, CAD is lowly confident, so what happens then? We really don't know. Maybe the high confidence prediction prevails, so you are right, but if the other way occurs, would you believe the computer? If the computer says it's an adenoma and you think it's a hyperplastic polyp, it's hard to know these sort of things. This needs to be worked out. So there's so many different platforms. And there's, as I said, user fatigue. Cost is the other issue. And this is really an interesting study by Yuichi Mori's group as well, with Cesare Hassan and Doug Rex. The cost of, it will detect more polyps, right, AI system. So we're going to start taking off more polyps. That's going to increase the cost. But then it may reduce cancer because our ADRs are better, right? So long-term sort of cost effectiveness actually is actually, and this is just a model again, it's not real-time study, shows that there's an incremental reduction of colorectal cancer incidence by 5%, and reduction of cost per patient by $57 US dollars. So savings of $290 million US dollars if everybody in the United States who undergoes screening colonoscopy has AI on top of their routine colonoscopies. So it's quite interesting study, but again, this is a modeling study. It's not in kind of real time. But they also went to this extent to say that somebody needs to then invest, right, AI system. So who's going to pay the upfront cost of $250 million a year to put all these AI systems in each unit? So you have to invest first before reaping the benefits 10, 20, 15, 20 years later. Confidentiality is the other issue. You have all of these systems, and if it goes up to a cloud, who owns that data? I think this guy Tristan Harris said, if you do not pay for the product, you become the product. And then I think he was sacked by Google. So responsibility is the other issue. Still important to understand and master. I think mucosal imaging. That's why most of us are here today, trying to work this out as well. So the future is, it may start checking our performance. We never know. We may have systems which can pick up our ADRs as we go, every colonoscope perhaps. We need to obviously integrate this if it's going to come into play, because right now somebody's just looking at squamous cell cancer, or Barrett's, or gastric lesions, or blind spots. Nobody's kind of collectively looking at it together. So maybe that will come as well. Maybe the AI systems can also look at other things at the tip of the scope, the temperature of the environment within the stomach or the esophagus or the pH, that sort of thing. We really don't know. Can measure other things perhaps. And maybe assist us with taking off polyps, telling us what to do next. So we may not need Noria telling us how to cut the submucosa. AI may be telling you, okay, this direction, that's how you're going to do it. We don't know. This was just out, and some newer studies saying ChatGPT provides good answers to patients' questions about colonoscopy. So this group, and this published in Gastroenterology a few weeks ago, this group looked at 8 questions, I think, and they found that ChatGPT, if one were to ask ChatGPT about a colonoscopy, they'll get pretty good answers from ChatGPT. And another system, and Andrew's not here, any new AI system can tell normal from abnormal colonic biopsies, and that's published in Gut a few weeks ago as well. So certainly it's coming. But not all systems are the same. So I think there's still some caution advised when we look at these AI systems. With regards to training and data sets, we need RCTs, of course. I really don't know whether, we need to, or whether we'll wait for them and these sort of AI wave will just take over. I'm not really sure. Maybe it could lead to de-skilling of endoscopies. We won't need to look much anymore. AI is going to tell us where the polyp is. Obviously, if it tells us it's the terminal ileum, we should not put that snare down and try to cut it off, because it's going to be probably a bit of trouble after that. So we really don't know, but this technology is coming, and it's coming quite quickly actually. So with that, thank you, and happy to take questions. If not, I think we're all quite tired, so thank you all for staying back and for coming.
Does anyone have any questions for Raj? That was a very nice talk, Raj.
So, Raj, not a
Yes.
question about your lecture, but maybe to Bronte.
Yes.
I'm interested, with very large right-sided resections, do you counsel the patients about avoiding certain activities, and for how long?
Yeah, so if it's a hot snare resection that's planned, then I usually just ask if they've got someone, they need someone at home with them that night. And then I usually just assess whether that sort of person is going to be hiking out by themselves or going for long solo bike rides or that sort of thing, and I counsel them not to for a week or two.
Is that about risk of bleeding or risk of risk of perforation with weightlifting or heavy physical activity?
No, so I tell them for 24 hours if they ask. So they'll say, "Oh, what about working out?" And so I usually say don't go to the gym and lift heavy weights, but otherwise, yeah, let's find exercise.
And in somebody you're resecting numerous cess ulcerated lesions, is there a limit to how many you could take in one session?
As many as you can. No, I don't have a limit, but usually I find that when I get to about 20, the imaging just isn't as great anymore, and there's more contraction in the colon, and there's more blood sort of in the effluent that's just coming out, so you just tend to not see as many anymore. And I'll have a number of my SSP, so cerebral palsy syndrome patients who, you'll go back and there's another 20, there's another 20 kids.
Sometimes for those SSP type patients, it's quite worthwhile to try to remove these polyps in a segmental nature. So start off from the cecum, ascending, maybe hepatic, stop there, come back another day. So I think that's also quite helpful. I find doing it that way. Any other questions? If not, I'd just like to spend a few moments to thank our speakers who have come from afar. So I'll start off with Noria. Thank you very much. We've got something for you. So Cameron, thank you. Better not drop this. Thank you. No. Thank you all again, and hopefully you have a good weekend ahead. It's still early in the weekend, I guess. Nice weather out there. Thank you for coming, and hopefully we can organize this again next year. So thank you all for your time. Thank you.
See you.